Believe in yourself and all that you are. Know that there's something inside you which is greater than any obstacle ahead. Honorable speakers, faculty members, respected teachers, seniors, delegates, my dear colleagues and juniors, a very good morning to one and all, and a very happy Ambedkar Jayanti to one and all. It is my pleasure to welcome you all to the 11th Practical Pediatric Endocrinology course being organized under the auspices of Department of Pediatrics, King George's Medical University, Lucknow, Grow Society, and Med-E classes. We've assembled a panel of renowned speakers and faculty who will share their expertise and insights on the latest developments in pediatric endocrinology. Through this event, we hope to foster a culture of continuous learning and improvement among healthcare professionals. We have a formal inauguration planned at 12 p.m. and without much delay, we would like to begin with our academic sessions. Our first session is about glucose, diabetic ketoacidosis, and hypoglycemia. With great joy and enthusiasm, I would like to request you all to welcome on stage Dr. Anurag Bajpai, Consultant Endocrinologist, Regency Hospital, Kanpur, who's our first speaker for today. Our panelists for the sessions are Dr. Shalini Tripathi, Additional Professor, Department of Pediatrics, KGMU. Can we please have a huge round of applause for all our speakers and panelists? Dr. Arpita Briguvanshi, Associate Professor, Department of Pediatrics, KGMU. And Dr. Lokesh Sharma from Medanta Hospital, Lucknow. I also invite Dr. Dhwani for the case presentation.
Good morning, everybody, and thanks for this wonderful invite. And I really thank Dr. Arpita and the entire Department of Pediatrics of KGMU for providing us with this wonderful opportunity to interact about the practical pediatric endocrine course. We'll talk about this in much more detail subsequently. So we'll start off with a bit briefing about what we are doing and why we are doing before we go ahead with this talk, and then we'll have more discussion there. So we started Grow India around 10 years ago with an aim of increasing awareness with regards to various specialities of pediatric endocrinology and problems related to diabetes, obesity, as well as the other issues of growth. And we tried to start off with the general public with different school-based interventions, but we realized that unless and until the pediatricians are made aware about these conditions, it would be very difficult to really, because often the referral is very late. And that's an important problem. So we then started developing a lot of pediatricians initiatives. So the last 10 years or so, we have conducted across the country around 10 practical pediatric endocrine courses, over 100 workshops, and a lot of modules have been developed which are available online as well. These programs are all available on the YouTube, which is there in the channel, which has got all the videos related to pediatric endocrinology and a lot of information there. We then realized that we need to have more structured learning. So we have developed a learning portal, which has got a lot of videos, other information, interactive sessions, and validated teaching tools to focus on different aspects of pediatric endocrinology. Via our website, learning.growsociety.in, we have got specific courses for the postgraduates, the fellows, as well as a fellowship program in pediatric endocrinology. We have got publications which cover the entirety of pediatric endocrinology from basic to advanced. And we've developed a mobile application which provides validated guidance for assessing and managing pediatric endocrine disorders. We'll try to go through all that subsequently in terms of these aspects. So today we are going to focus on a lot of aspects of pediatric endocrinology, including growth, puberty, thyroid, electrolyte, calcium, and decay. The first 3 hours are going to focus largely with regards to the emergency conditions. So we'll start with glucose first, then we'll talk about calcium and then electrolyte. The second session post-lunch will be on more office-based issues in terms of puberty, growth, and thyroid in that regards. So we'll start off with this session, and the plan is very simple. We will have an initial introduction around 15 minutes of the subject in which the expert will put forward the issues, and then we'll have an interactive session with the panelists on that perspective. So we'll start off with this first case who presented to us recently with DK. 4-year-old girl received fluid and insulin from outside. At the admission, the potassium was 3.2. Now, the treating team at that point of time gave a normal saline followed by insulin. Now, what do you think would have happened in this case? We want this to be interactive, so you can ask and we'll also ask questions. So what do you think would happen if you give insulin to this girl who already had a potassium of 3.2? All the potassium will go inside the cells and there would be a sudden cardiac arrhythmia, and that's what would happen. So this is a very, very unfortunate situation in which we could have avoided this if we had given potassium in the hydration phase. Now, if we look at what is quoted as the prevalence of diabetes across the world, you will find India is supposed to be in the low incidence country or a low prevalence country. But I would say that this is largely because of missing of cases rather than a lower prevalence or incidence. Large number of cases are not being diagnosed, large number of cases are not being managed appropriately, and unfortunately, what we are seeing is the tip of the iceberg. And it is the responsibility of us pediatricians to identify and appropriately manage it over the night time in terms of DKA, because this is something which could really save this. So in this session, we'll have a brief overview about what DKA is, and then we'll use cases to highlight those scenarios. So basically, when we talk about DKA, it is a combination of insulin deficiency and counter-regulatory hormone excess. Now, both of them play an important role in pathophysiology. The insulin deficiency largely causes the development of ketoacidosis, and it is this ketoacidosis which causes the characteristic breathing, the abdominal pain, the vomiting, and all the other dehydration symptoms which are there. The counter-regulatory excess, in addition to insulin deficiency, causes hyperglycemia, and this excess amount of glucose causes osmotic diuresis, which results in the loss of glucose. Along with that, you lose sodium, potassium, and phosphorus. So there's a huge deficit which happens in these perspectives, which we need to be careful about. So what is the impact of DKA on the body? Now, what we look clearly is that everybody generally will be dehydrated. It will be like 7 to 10%. Now, do we underestimate dehydration in DKA or overestimate dehydration? Underestimate? What else? Somebody else has a different. So it can be both. There could be difficulties in terms of assessing hydration in DKA, because if you look at the tongue will be dry. So you will overestimate. If you look at the skin mucosa and you look at the turgor, there will be increased osmolality. So turgor will be preserved. So you will be underdiagnosing. So there could be a lot of confusion. So there is not a very reliable way to assess. But generally, when we talk about less fluid, we don't want to give too much fluid. It's better to be a bit conservative in terms of fluid replacement rather than being aggressive. And this is what is important. Second thing is about sodium, and there is a deficit of 6 to 10 millimoles per kg. Do we underestimate sodium deficit or do we overestimate sodium deficit? So the sodium in hyperglycemia is falsely low. And because of that, you will be overestimating the level of hyponatremia. For every 100 milligram per DL rise in glucose, the sodium level will typically go down by around 1.6 to 2. So you should always go for a corrected sodium rather than going ahead with a simple sodium value that you're looking at. Third big issue, as I discussed, is potassium. Now, what do we do in terms of potassium? There is a definite intracellular deficit. But because when you have insulin deficiency, when you have metabolic acidosis, the potassium goes out of the cells. So you will underestimate the potassium deficit. For every 0.1 decrease in pH, the potassium goes up by 0.6. So suppose your pH is around 6.8, you actually should ideally subtract it by around 2.4 to 3 to get the right figure. So a 5.4 will become 3. So if somebody is at 3.2, you know as soon as you correct acidosis, as soon as you give insulin, the patient will have severe hypokalemia and that will cause a huge problem. So this understanding becomes important, that you will be underestimating the severity of hypokalemia in this setting. And this is why we are talking about this formula: 0.1 pH decline, 0.6 increase in potassium is what you should look into. There's also a lot of phosphorus deficiency, and now we have clearly seen that in very severe metabolic acidosis, pH less than 6.9, phosphorus is very important. If you do not give phosphorus, you will have rhabdomyolysis. So this is an important factor to remember, and phosphorus correction is also important. Now, what do we do in terms of treatment? The first treatment is fluid. So if you give the initial fluid bolus, the blood sugar automatically decreases by around 100 milligram per dl in the first hour. So there is no rush of giving insulin. Just by giving normal saline, because your counter-regulatory hormones come down, the fluid volume expands, your glucose will come down. So this is something which is very important to understand. So there is no rush in the first hour of giving insulin. If you give insulin, you will have a rapid change in glucose, osmotic flux, you will have hypokalemia. It will be more dangerous than beneficial. But subsequently, to suppress ketosis, you need insulin, of course, in that perspective. And very importantly, if you give too much amount of fluid, there will be a risk of developing cerebral edema. And we'll talk about whether when you give too much chloride, you will have hyperchloremic metabolic acidosis. Now, many of us are seeing that you take much longer for resolution of acidosis, and that is because of this chloride load that we are giving in that perspective. If you give too much insulin, what will happen? You will cause hypokalemia and you will cause a rapid thrust in that perspective. Now, what are we worried about in management of DKA? The most important, of course, is cerebral edema. So if you have a very sick child whose pH is less than 6.9, who has received outside fluid, somebody has given a lot of fluids outside, that is a very, very high risk of cerebral edema. And remember, they may actually have cerebral edema right at diagnosis. We'll highlight a couple of cases on that regards. So if you have a child who is sick, who has altered sensorium, has bradycardia, has hypertension, unequal people, think that there may be a cerebral edema right sitting at that time. Don't wait and watch. Otherwise, there will be a lot of mortality, and immediate mannitol will be life-saving. The second big complication is hypokalemia. So always be wary of potassium. And we'll talk about that if you have hypokalemia at the beginning, give potassium in the hydration phase, defer insulin to allow a more gradual control in that perspective. Acidosis can be there because of ketoacidosis, because of lactic acidosis, but very importantly, towards the end of the treatment, if the child is stable, this could be hyperchloremic metabolic acidosis. So again, you don't need to worry about that in that regards. Very importantly, do not give bicarbonate, and it's very, very rare expression. I would have given maybe in 2 or 3 patients bicarbonate out of 500 or whatever I would have treated. So it is required, but extremely rare. We'll talk about why we should not. Always be wary of infection and thrombosis. Do not put unnecessary central lines, because if you put central line, this is a hyperviscosity state, there will be a thrombosis. If you are putting a central line, give low molecular weight heparin. That is a very, very important thing to remember. And finally, if your phosphorus is very low, you can develop rhabdomyolysis. Suddenly there will be a pain in the leg, eye colored urine, the patient will go into renal failure. So you have to be very, very cautious about rhabdomyolysis from that perspective. Now, what really is diabetic ketoacidosis? The answer is very simple. It is DKA. So you need to have diabetes, you need to have ketosis, and you need to have acidosis. Now, one point I like to highlight is that you should always go for a blood ketone and not a urine ketone. Urine ketone is an unreliable marker of ketosis because it measures acetoacetate, while the ketone in the blood is actually beta hydroxybutyrate. So go for blood ketone, easily available, 150 rupee per strip. You should have this in all the ICUs, and it will help you on that. Now, very importantly, if you have only ketosis and acidosis, you need to have all three. If you have only ketosis and acidosis, this is rare, but you have to think of something else. Maybe this is organic acidemia that you're thinking of. If you have only hyperglycemia and ketosis, this may be a stress response. And if you have hyperglycemia and acidosis again, so depending upon all three present, your DK is definitely what is required. In children, you will hardly have any case of euglycemic DK. They will have sugars of 500, 600. There's no confusion on that perspective. So what do? Of course, put an airway. If the child is unconscious or has recently taken a glucose-containing feed, put an NG tube, because as soon as you improve DK, the gastroparesis will improve and all his glucose will come into the blood. So the sugar will really shoot up. 2 wide bore lines should be put up, oxygen, but very importantly, avoid ventilation till it is possible. I'm saying till it is possible, it's not contraindicated, but often you don't need it. It may cause more problems. avoid a central line because that may cause thrombosis, and do not give too much fluid. Do not give too much boluses because child is looking sick, you give bolus, 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 and then they will develop cerebral edema. Now, some of you might have heard about the lot of studies which have come from the US and the North America, which talk about that whatever fluid you give, whatever sodium you give, the pica and tile, it says, doesn't make a difference in terms of cerebral edema. But the mean pH in that study is 7.1. What is the usual pH that you see with DK, Dr. Lokesh? In our setting, 7, 6.9, we also see 6.8. So we cannot compare that 7.1 to our children. So in our children, you can't be so liberal in giving whatever fluid. We have to stick to the old protocol unless we have our own studies to prove that. That is an important thing to remember. Now, if you have a child with DK who comes to you with shock, this is an important thing. A child with DK should not be in shock. Why? You have counter-regulatory hormone excess, you have got vasopressin excess, you have got epinephrine excess. So whatever you give for vasopressors is already there. So why should they be in shock? So if a DK child is in shock, there is something grossly wrong going on. If they have hypokalemia, nobody should have hypokalemia. If they have hypokalemia, do not give insulin. As I said in the first case, if there is fever, worry about infections, don't worry about counts. Counts will be high, 30,000, 40,000. We see those counts, but if there is fever, you have to worry. And if you have altered sensorium at presentation, this could mean that there is something wrong. This could be a cerebral edema right away. From that, if there is hypertension, think about other possibilities like AKI also, which is common in DKA. And very importantly, you may have high TLC. You may have high amylase lipase, which is not a problem. Now, fluid bolus, and there are certain changes which have happened in the recent guidelines. They basically say that if you have definite evidence of hypovolemia, you have to give a fluid bolus. Otherwise, it may also be helpful in mild DKA. So if you have a child who has mild DKA, you give him some fluid, not at all bolus. That will help in resolution quickly and you can send them home. Do not give too much fluid, 10 ml per kg, maximum 40 ml per kg over 4-hour period. And if there is a shock, you can give a more faster bolus. You have to deduct it from the total fluid. This is something which is important to realize. And very importantly, do not give more than 2 boluses. And as I said, not more than 40 ml per kg over a 4-hour period is what we recommend from that perspective. So hydration, all you have to do over 24 to 48 hours, give maintenance and deficit in a standard formula 4:1 for maintenance, and for deficit as far as dehydration is concerned. I would prefer normal saline in most cases. However, the child has milder DK, you may think of N/2 as an option. Do not ever give about 3 liters per meter square, which is basically double maintenance, because that can cause harm. And in children who are above 30 kgs, body surface area based dosing are better. You don't want to give too much. Giving little will not be a harm. You can also think of alternate options like Hartmann solution or plasma light, which can also be helpful, which has got lesser content of chloride in that regards. Now, insulin, always give as IV infusion. If that's not available, intramuscular is also an option, which ISPAT guidelines also mention about. Now we talk about a lower dose insulin. So in most severe cases, you may start with a lower dose of insulin, and that will be beneficial. Always flush the tubings, because otherwise it will be stuck to the tubings and you will have a problem in terms of not delivering insulin in the initial phase. Don't change too dramatically, and do not use the burette set. It doesn't give you a good amount of picture. Infusion pump is a basic minimum. If there is a problem, you can give an intramuscular in moderate DKA. You can manage from that perspective. You should have an improvement in sensorium. You should have improvement in hydration. Very importantly, urine output should be monitored. It should be above 1 ml per kg per hour. Sodium, the corrected sodium should be stable. The potassium should remain normal, and the ketones need to improve. Usually, ketones may go up a bit and then come down. It may take up to 12 hours for ketones, 8 to 12 hours for ketone to resolve. Acidosis in the severe cases takes up to 12 to 18 hours, usually from that perspective. Now, just a few points. If your serum potassium at the diagnosis is less than 3.3 or 3.5, add potassium in the hydration fluid, defer insulin. If it's normal, less than 6, and urine output is established, you add potassium at 40 millimoles per liter. Do not give potassium only if the child is anuric or the potassium is above 6. So these are the criteria you need to worry about. Very importantly, if a child develops sudden polyuria, this could be hypokalemia. Why does hypokalemia cause polyuria? Anybody? Hypokalemia, polyuria, Dr. Nitin? So AVP resistance, that is a situation which may happen. Myopathy, of course, may be an indicator. And intervention, of course, is to give infusion, reduce insulin, and magnesium also deficient in many cases. So we have to give magnesium to correct hypokalemia. Dextrose, always your glucose will come down before your resolution of acidosis. So very importantly, you have to basically look at blood glucose. If the blood glucose is less than 300, add 5% dextrose. Less than 200, add 10% dextrose. Do not wait for acidosis to resolve. Do not decrease insulin, add dextrose. I think this is an important thing. And very importantly, bicarbonate is not required. For your purposes, bicarbonate is not required unless the patient's pH is less than 6.8, is in cardiac shock because of acidosis, or there is refractory hyperkalemia. As I said, 2 out of 500 maybe I would have given bicarbonate, that ready to, that the child will develop cerebral edema in that scenario. So again, as we'll discuss, that usually if your ketones is normal, it is not because of a decay, it is because of a possibility of a chloride load, which will give you a picture in that perspective. So hyperchloremic acidosis, do not continue insulin for a long time, that will improve. Bicarbonate will cause CNS acidosis, it will cause hypokalemia, it will cause cerebral edema. So avoid it unless and until you have severe hyperkalemia or hemodynamic instability. There also do not give it as a push, give it as an infusion. That is what the message would be from that regards. One thing which used to say, okay, don't worry about phosphorus, because all guidelines were saying 50% potassium should come from phosphorus. But now what we have realized, that if your pH is very low, below 6.9, if you do not add phosphorus, they will develop rhabdomyolysis, and that will cause a lot of problem. So if your phosphorus is less than 1 milligram, definitely potassium phosphate is required. And very importantly, if anybody has persistent myopathy, altered sensorium, or red colored urine, or you have sudden oliguria, think of hypophosphatemia. That becomes important. And we give 50% replacement at K-phos. It's easily available. So ideally, we should give it in most patients with DKA from that regards. One thing which I have to tell you is cerebral edema, and this is our study published a few years ago. It showed that many patients in India have cerebral edema right at diagnosis. That is because they have received treatment outside, they have received fluid. So be wary about that, and the prognosis will be good if we treat appropriately. So finally, to summarize before the case discussion starts, the first phase is hydration, give 10 ml per kg normal saline. Second phase is deficit plus maintenance over roughly 48 hours. You start insulin, and as your potassium will always fall down, unless there is anuria or there is a hyperkalemia, you give potassium. And once glucose becomes below 300, you give dextrose. Do not give soda bicarb, and beware of cerebral edema. If you remember this slide, this is what I've been talking about throughout. Now, very importantly, what we have found, that despite all the protocols that we have, lot of errors happen. And this is from our own center. We found that many prescription errors were happening. The calculations were not right. So what we thought that we can improve on that by developing a mobile application which provides accurate guidance, which is individualized, specific for whatever weight, pH, CO2, sodium, potassium. You enter, you get the exact output which is there. So this is available. We have validated this also, and we have proven this. So we'll now be starting with the case. I'll invite Dr. Dhwani to come over to start the case discussion. For that, we are joined by Dr. Shalini Tripathi, who is from KGMU, doesn't need any introduction. Dr. Arpita, who is again the main person behind this conference, and Dr. Lokesh, who is there in Medanta at the moment. He has done his pediatric endocrinology from SGPGI, and he's working in Medanta. And Dr. Arpita, everybody knows. Dr. Shalini, everybody knows, I think. So we'll start off with the first case, Dr. Dhwani.
Thank you, sir. Good morning, everybody. Moving on to the first case. So we have this 4-year-old girl with severe decay. who had presented with pain in abdomen and vomiting, was managed as diarrhea, and was finally referred in view of no improvement. At presentation, she had a pH of 6.8 with bicarb 4 and ketosis of 7.1. She was drowsy at presentation and had anisocoria with brisk reflexes. So I would like to ask Dr. Lokesh, what went wrong with this case? What could have been managed differently?
Hello. So, fulfilling criteria, like we have pH of 6.8, less, significantly less than normal, and very high ketones. Blood ketones, if you do not use like more than 3 millimole per liter is diagnostic mostly of like it is mostly due to ketosis only. I will say normal is less than 0.6 millimole per liter, and in between there is very moderate like modest ketosis. So more than 3 is ketosis. This is 7, significantly higher than that. And other thing what we can see, she is drowsy and anisocoria. Anisocoria is a telltale sign that she has something significantly happening in the CNS. So she has most likely cerebral edema. And this reflex is also showing the same thing. Next slide. So
as sir has rightly mentioned, that in this scenario where the child has received fluids abundantly from outside, one must think of cerebral edema at presentation and give mannitol right away. And again, in such cases where you expect a cerebral edema to have developed, you give a slower correction, not over 48 hours, but over 72 hours. So the messages from
is that when a child comes to you and you have diagnosed as DKA, it is not like we are waiting that cerebral edema usually develops in the end during end of like mid or end of the treatment. It may be at the presentation also. So whenever you are suspecting that, in this we have very clear cut signs. But many times we do not get that much clear cut sign that anisocoria is not very uncommon. You will have brisk reflexes. You will have to see that child has seen a sign. Then if you're finding them, straight away you should go for mannitol and you should plan your flu treatment or prolong. Like usually we treat PK of 48 hours. In these cases, if child is not in shock, then we are not in any hurry. We should prolong it to more than 48 hours, even 48 to 72 hours will give. So we will have to remain conservative towards fluid more than other cases. So that is what we are trying to say by this case.
Thank you, sir. Moving on to the next case, we have this 11-month-old boy with failure to thrive, had a pH of 7 at presentation with positive ketones and an RBS of 440. So I would like to ask Dr. Arpita, how do we go about in this case?
So can I have the case, please? Just 11. Case of 7. Yes, definitely the child is having the so the duration of the maintenance therapy should be a bit prolonged. More than the 48 hours, it should be extended over a bit 72 hours. And the insulin, we have to start with a lower dose at 0.05 units per kg per hour. And we have to constantly monitor this patient hourly with the blood sugars. And we have to keep in mind that cerebral edema can develop anytime. And we have to be prepared for that catastrophic event.
Okay, thank you so much, ma'am. So like ma'am has mentioned that you may not always find cerebral edema at presentation. It is a process that you will have to keep monitoring for. Moving on to the next case, so we have this 9-year-old girl who is emaciated at presentation, has hyperglycemia acidosis, and ketosis. I would like to pose this question again to Dr. Lokesh. So how do we go about in this specific case scenario?
So again, diagnosis is DA, all three criteria are fulfilled. Now, coming to the bolus, yes, we'll give. And then coming to insulin, duration, like as whenever we are in doubt, we should prolong therapy. And 48 hours is the standard treatment duration for any kid. Like, am I audible? I think we can speak like that only. So, what do you do? How do you manage DK? Like, I remember from my MD days, or our colleagues used to read Nelson that writes Milwaukee Protocol. So, are you aware of SPAC guidelines or not? So that is like we were not very familiar with the SPAC guidelines. Mostly we used to do a Milwaukee Protocol. That is like slightly aggressive. Like they give 8.5% dehydration straight away for any kid, 85 ml per kg dehydration, and they mostly they manage it 24 hours. SPAC guidelines do not say that. Be conservative. Only emergency in DK whenever child is in shock. Shock means like if child is in shock, then we should go by PALS criteria. We'll manage shock according to PALS. Once shock is over, then we should be more conservative. We are not in hurry at all. So DK, cerebral edema is the most catastrophic thing, and that takes life. That's it. If we can prevent cerebral edema, then we are not in hurry. Like child is going, like definitely child is going to improve. So we should be more conservative in fluids if child is not in shock. And mostly they are not in shock. So standard criteria we will manage, we will give fluids over 48 hours, we will go slow, and if is there any doubt, like child is very young, severe dehydration and severe ketosis, pH is less than 7, then we should go even more than 48 hours also. So these are the things. After duration, insulin mostly 0.1 is the treatment of choice. Whenever you are dealing with young kids, like child is very small, or I will say mild to moderate ketosis also, we should start towards lower end of the normal range, like 0.05 to 0.1 unit per kg per hour is the treatment of standard treatment. So we will err towards lower side. Whenever child is very young, we have mild to moderate ketosis. So in this case, we will go 0.05 units per kg per hour because this child, so give a slide. Emaciated. So whenever child is emaciated, our potassium results are lesser than that, like lesser than normal. We read hypokalemia is a complication of malnutrition. We read in SAM. So we give potassium supplement also in SAM. So this child will have potassium results less than normal kids. So insulin is a major factor which decides potassium levels initially. So we will go slow. We will give insulin at the lower end and precaution hypokalemia. This child will have higher chances of developing hypokalemia than other kids. So these are the things we need to see in this child.
Thank you so much, sir. That was very well explained. Moving on to the next case, we have a 3-year-old boy with severe DKA, managed for 6 hours, but continued to have persistent metabolic acidosis with positive ketosis and developed hypokalemia. At 6 hours, had a potassium level of 2.8. I would like to pose a question to Dr. Arpita. What do we do now?
Okay, so we have a 3-year-old boy, definitely in severe decay, being managed outside for 6 hours. And here we can see a very dangerous complication of severe decay, that is hypokalemia, very severe, it is 2.8. So this is the lab value, and we know that it is underestimating actually the hypokalemia. So the potassium level is in fact more low. So here we have to decide our management according to the potassium values. So if the value is less than 3.3, we have to start with 20 millimoles per liter of potassium right away in the initial fluid boluses. And if it is between 3.3 to 6, as Sir already has mentioned, we have to give 40 millimoles per liter of potassium in the maintenance fluid over 48 to 72 hours. And if it is more than 6 millimoles per liter, we can avoid potassium in that case. But still, we need to monitor potassium or at a constant interval to look for hypokalemia. And whenever we are encountering hypokalemia, we need to supplement that.
Also here, we need to defer the insulin therapy because as soon as we will start the insulin therapy, there will be resolution of metabolic acidosis and hypokalemia will further worsen. So we need to defer insulin in this case before the potassium corrects itself. So the key messages coming out of this case is that potassium will definitely fall during the treatment. So we need to correct it before starting insulin therapy. And hypokalemia at diagnosis is a very dangerous event because it will lead to sudden cardiac arrhythmia. So it needs to be corrected in the bolus phase itself.
Thank you so much, ma'am. Moving on to this next case, we have this 10-year-old girl with hyperglycemia, um, severe metabolic acidosis with pH of 6.9 and a potassium of 5.8 at presentation. She was found to have dehydration of 10% at presentation. Clinically, she was estimated to have a dehydration of 10%. So how do we go about in this case?
Yes, again, diagnosis is very clear. She has all the features, high blood sugar, very high blood sugar, acidosis and ketosis. So diagnosis is DKA. How do we classify DKA? Severity of DKA? Like 7.3, 7.3 is like 7.35 is normal range of lower normal. Then from 7.3 onwards, we say it's acidosis. So from 7.3 to 7.2, and then 7.2 to 7.1 and less than 7.1. So these are the three mild, moderate, and severe DKA criteria. And according to bicarb also, are you aware that earlier we used to read 15 millimole or less than that? Recently, ISPAT has changed. I think a few months back only. I think 4 or 5 months back only. They have changed to 18. So now we are going to more aggressively, like 18 is normal range of normal bicarb. Earlier we used to say DK below 15. Now we say at 18 onwards, we will start DK protocol. So we are more aggressive. After 18, 10 and 5 are the other marks we should know that will define severity, moderate and severe ketoacidosis. So these are the two things by which we can classify severity of DKA. And these are very important because our management and like our how fast, how aggressively we are going, and how are we going to prognosticate, and any other important thing that how we should be concerned about cerebral edema. More severe the DKA, more the chances of cerebral edema will be there. More the chances of other complications will be there. So everything will be dependent on our classification. Other things also should not at diagnosis. Because it shows how much dehydrated we are, child is, and other thing will be PCO2. After a level of washing out of CO2, cerebral perfusion starts deteriorate. Like it is a mechanism of safety, but in the end, it ends at the damaging our cerebral perfusion. So when PCO2 is less than 20, we should be worried about that our child is at more risk of cerebral edema. So these are we should know at onset. Severity of the DKA, what is the BUN, and what is the PCO2, because these are the things which are going to tell us how much at risk of our child is at risk of DKA in the coming hours or days. So that's how we will do. In this child, he had severe DKA with the pH of 6.9 and dehydration of 10%. So we will start by hydration bolus, that will be saline for our 1 hour, 30 minutes. Like shock, we have not there is no indication that the child is in shock. So we will go slow. There is no need of fast boluses. We'll go first bolus 10 to 20 ml per kg, 30 to 60 minutes, and after that we will start our hydration, total hydration of deficit correction 10 ml per 100 ml per kg with maintenance fluid or 48 hours. So that we will plan, and that is how we will calculate the fluid dehydration correction with maintenance.
Thank you so much, sir. So again, highlighting something here is that because we know that clinically it may be difficult to assess the dehydration percentage in these children, pH may be a rough guide to know what percentage of dehydration correction to give. So less than 7.1 and severe DK, we end up giving 10% dehydration correction. In moderate, we give up 7.5%, and in mild, we give up 5% dehydration correction. At 4 hours, the child had blood sugar of 650 and a base deficit of 22. So at this step, what do we do now?
So the right. So the child is already on treatment and still the blood sugar levels are high. Metabolic acidosis is still. So we need to see our therapy. Is there something wrong with our treatment? So first thing first, we have to see whether we are giving too little insulin or whatever insulin we are giving is too diluted or is sticking to the tubings and we have not flushed our insulin. For management of DKA child. And the next thing, if we have ruled out all these things, we need to see whether the child is in shock. So the DKA child should not be in shock. So there is something else happening. So we should keep a possibility of sepsis and start the child on broad-spectrum antibiotics and also manage shock in this child.
At 8 hours, the blood sugar improved. It came down to 190 with a base excess of -12. So we were going on the right track. What do we do?
Right. So the blood sugars are coming down and the base the acidosis is also improving. So the response expect managing DKA child, we expect the sugars to fall within the 6 to 8 hours and ketosis to resolve in 10 to 12 hours, followed by the resolution of metabolic acidosis. So this is what is expected. So here we should be wary that we should not be abruptly stopping the insulin infusion. It should be continued till the acidosis improves. And rather than decreasing the insulin infusion or stopping it, we should be titrating our dextrose concentration depending on the blood glucose. So here, as the child is having sugars of 190. So if it is below 200 milligram per deciliter, we should be starting with the 10% dextrose. If it is between 200 to 300, we should be starting 5% dextrose. Above 300, we should be avoiding any dextrose in the fluid. So that is the way forward.
Thank you so much, ma'am. At 10 hours, the sugar shot up with a base excess of -11 and potassium went down to 2.6. So Dr. Lokesh, how do we go about here?
So now it is going as we had planned, sugar is good, base excess is improving, but complication now we are seeing hypokalemia. So first, this is lab report, so there is no confusion. Sometimes we should know that we are doing electrolytes 4 to 6 hourly, then symptoms which may indicate hypokalemia already sir told that polyuria, myopathy, if they are there, we should be aware that this may be due to hypokalemia. And when there is hypokalemia, what are the things we can do? One thing we will increase potassium. If we are giving 40, we can give 60. If potassium is less than 2.5 or we have ECG changes, we should give potassium infusion straight away or 60 minutes to correct acute correction of the potassium. Other thing, if potassium is not improving by our maneuvers, then I will say only situation in DK when we stop or we will reduce insulin to up to significant levels before correcting acidosis is persistent hypokalemia, because persistent hypokalemia is dangerous. So sometimes we may have to stop insulin even for 1 or 2 hours until we build the potassium at the safe levels, and that's how we do about this.
Yes, so hypokalemia is something we need to think of here and increase the supplement, potassium supplement in our maintenance fluid. Okay. At 14 hours, the child was found comatose. So Dr. Arpita, how do we go about now?
So at any point, as we have already seen and discussed, that cerebral edema is a devastating complication of while managing DK. It may be a presentation upfront or it may develop any time during the management of DK. So any child having sudden deterioration of sensorium with unequal pupils and bradycardia, all those signs of raised ICT will signify that the child is in cerebral edema, and we need to treat that by giving mannitol infusion. It should be ready bedside when we are managing a DKA child, and we should immediately administer mannitol at the rate of 2.5 to 5 ml per kg. And we should avoid cerebral edema, and we should not wait for any specific investigation, any imaging. We should rely on our clinical judgment while managing such patients.
At 20 hours, the child had a sugar of 190 and base excess of -12. So, Dr. Lokesh, what do we?
Whenever acidosis is persisting like after 24 hours or so, everything is going on good, child is improving, all vitals are going well, sugars are improving, but acidosis is not improving. We should think about hypochloremic acidosis. This is very important because then we do not need to treat that. Like we can switch over from IV fluids and insulin towards subcutaneous insulin and oral intake. So how do we know? We can do one thing is very important, that we can keep an eye on the anion gap. Very simple measure. Anion gap is directly reflective of ketones in this case. Anion gap is reflective of any other acid product in our body. In this case, ketones will be that acid product. So if we do not have bedside blood ketones, then other proxy of that blood ketone will be anion gap. So we can keep a watch of anion gap. If it is closing, then we know that our child is improving. It is due to hyperchloremia, and chloride will definitely be higher than normal. Like up to 108, normal lab references are up to 108, and it may go up to 115, 120, 125. And anion gap is closing. And if we have blood ketones at hand, then we should do blood ketones also. If that is normalizing, then we should definitely think about that this is due to hyperchloremia. And we can switch over from IV insulin to subcutaneous, and we can switch over to oral fluids and oral feeds.
At 28 hours, the sugars were at 170. Base excess had decreased. The child was conscious. He was allowed orally assessed.
And the insulin was basically stopped. Carry on. So, Dr. Lokesh, what do you think went wrong here?
Like when you were explaining pathophysiology of this decay, so main major factor behind decay is the insulin deficiency. So when we are giving high dose of insulin to revert that pathophysiology, now we should know that we cannot abruptly stop insulin. We need to replenish that insulin. So we will do a switchover of the IV insulin to subcutaneous insulin. So there are several ways of doing that. One very simple way is like we are doing since at least from my MD days, at least for last 10 years, we used to do subcutaneous shot, and we will overlap that IV infusion for 1 hour. And after that, we will give a meal. So there will be at least 1 hour of overlap of regular insulin and IV, subcutaneous regular insulin and IV insulin. Nowadays, we can give rapid acting insulin also. In that case, 30 minutes overlap is okay. And another thing, we can give long acting insulin also. In that case, like that is I will say that is the best idea when we can keep long acting insulin on board previous night. Like we are planning to stop IV fluids and IV insulin on next morning. So we will start glargine or any other long acting insulin in the previous night. We will titrate IV insulin according to sugars. And in the morning, then we will give subcutaneous insulin, and then we'll stop IV insulin. So that is the idea how we should go about that.
Very importantly stated, there should be an overlap between stopping infusion and giving subcutaneous insulin here. In this case scenario, where it was abruptly stopped and the sugar had shot up at 2 hours to 560. Post decay, the child was started on sliding scale insulin at 2 units per kg, had fluctuating blood sugars. So, Dr. Arpita, what could have been done differently here?
So any child post decay sliding scale now is redundant. It is not at all recommended. and because it causes fluctuating sugar values, so it should be avoided at all cost. What is recommended now is the basal bolus regime, in which closely mimics what is happening in a normal physiology. So that is closest to what is happening naturally in our body. So what we can do is to have a combination of basal and bolus insulin. Basal, we can have any Lispro and Aspart along with a long-acting insulin such as Glargine and Degludec. So this has to be followed. And along with that, we should educate our children for proper monitoring of the sugars, the pre and the post meal values. We should also be explaining to them about the hypoglycemia signs and symptoms and how to manage that at home. Initially, after post-DK, the insulin levels, insulin requirement is quite high because of the glucotoxicity, and the insulin dose can be as high as 2 to 2.5 units per kg per hour. So during the initial management, we need to counsel the parents that the insulin may go up and down, and even the sugars will be fluctuating a lot. We need to plan. We need to explain that in detail to our parents before they leave the hospital, and we need to educate how to manage the hypoglycemia emergency at home too. So that should be done before the discharge is planned for this child.
Yeah, so I think this is a very important message that often we say that DKA is very simple to manage. We tend to make it complicated. So if we follow the rules, it's one of the best conditions, best response will happen. So if we can have the slide, please. So DKA basically is a tightrope. If you give too little fluid, you will have dehydration. If you give too much fluid, you will have cerebral edema. If you give too little insulin, you will have a delayed correction. If you give too fast insulin, you will have severe hypokalemia. Now, how many of you would like to have a slightly dehydrated child for in the ICU for a few hours more, rather than somebody who dies of cerebral edema or ketoacidosis or hypokalemia? I think there is no doubt. So the mantra of DK in 2023 is go slow. Less fluid, less insulin, less intubation, less aggressive. Go slow and you will have a good outcome happening. The other big message is often we get calls that patient is not getting control with insulin. The reason is you need to give a much higher dose. Start with 2.5. Give Lantus right away at night before. You will have a much quicker discharge, and this is the two messages we'll give from that perspective. Now we'll quickly change gears from too much to too little. So I'll now be talking about a bit about hypoglycemia. So we know that there are three major organs which are responsible for glucose control. We have got the liver and the kidneys, which are going to provide the source of glucose. And of course, we have got the alternate organ of adipocyte, which produce ketones. So the body needs glucose as a major metabolite. Most cells are dependent on glucose. Ketones are alternate substrates, which our heart can use, which our brain can use in certain scenarios. Everybody who becomes hypoglycemic should produce ketones. If you do not have ketones, you are thinking of a problem in ketone production, you're thinking of an insulin problem, or you're thinking about galactosemia, which we'll talk about a bit later. Now, the major regulator, of course, is the insulin hormone, and there are 4 counter-regulatory hormones which are acting against it. So insulin is going to cause increased glucose utilization, deposition of glucose in the liver, reduction in glycogenolysis, reduction in gluconeogenesis. So net glucose will come down. Then you have got the cortisol, epinephrine, glucagon, and growth hormone, which are by different mechanism increasing lipolysis, increasing glycogenolysis, increasing gluconeogenesis to ensure that the glucose levels remain normal. So evolution has 4 hormones to increase glucose and 1 to decrease it. So if you have deficiency in one, doesn't matter. So if you want to develop hypoglycemia, you need to have a multiple pituitary hormone deficiency. You cannot have an isolated problem causing hypoglycemia in that perspective. Very importantly, if you have hyperinsulinism, the body would require much higher amount of glucose infusion rate and ketones will be absent. If you have a problem in the level of the hormonal problem like cortisol or growth hormone, you will have a ketotic hypoglycemia along with low level of sodium, particularly if it's a multiple pituitary hormone deficiency. If there is an issue which is there in the hepatic exchange, the glycogenolysis, it usually will happen after 6 months of life. You will have a huge liver. You will have lactic acidosis. You will have ketosis that will give you a diagnosis. And if you have a problem which is gluconeogenic defect, you will have a later onset beyond 1 year with severe lactic acidosis. And rarely you can have fatty acid oxidation defects and multiple pituitary hormone deficiency, which can also present from that perspective. So hypoglycemia can be because of decreased production. This decreased production will be managed just by giving a basic physiological dose of 6 milligram per kg per minute. If you give, they will be fine. Or increase utilization where you will need a much higher dose of 12 milligram per kg per minute. Now, decreased production could be substrate issue because of prematurity, SGA. However, in SGA, the major cause now we know is hyperinsulinism, which I'll talk a bit later subsequently. And you can have a metabolic defect in which you can have an endocrine problem like a combined growth hormone and a ACTH problem like a multiple pituitary hormone deficiency. Typically, these children will have micropenis, cleft lip, cleft palate, midline defect. So I'm just talking about pointers. When we go to approach, it becomes much easier. Or there is a metabolic defects like galactosemia or fatty acid oxidation defects, which can cause a hypoketotic form. If you have cataract and cholestasis, think of galactosemia as a possibility. On the other hand, you have increased utilization because of infection or cardiac failure or hyperinsulinism. Hyperinsulinism is a big topic. The main message is it is non-ketotic and any detectable insulin during hypoglycemia is significant. There is no business for insulin to be present when your sugars are low. So any detectable insulin becomes hyperinsulinism. It could be transient for 1 to 2 weeks. There is very important prolonged form which stays for 6 to 8 weeks, typically in the setting of a SGA child. And then finally, you can have a genetic form which will present with macrosomia, very high insulin requirement, and potassium ATP channel defects. This is what we'll basically summarize because we're not talking too much into detail on that. Now, everybody who is hypoglycemic, once the sugar becomes less than 50, and this is important that glucometers are not reliable at that level. So you need to confirm it via a lab sample. So if your glucose is less than 50, you would expect insulin to be 0. You would expect the ketone to be above 2 millimoles per liter. You would expect the cortisol to be above 550 or 500 and growth hormone to be above 10. Now remember, these are supraphysiological levels. So often labs will say, okay, cortisol is 200 and it's labeled as normal. But that 200 is not normal for the level of hypoglycemia. So critical samples have to be assessed as far as the particular levels are concerned, and lactate should be absent also. Very importantly, if you have any detectable insulin during hypoglycemia, it is hyperinsulinism. If you have hypoketotic, you're talking about insulin excess, fatty acid oxidation defect, or galactosemia as a possibility. If your lactate is high, you're dealing with GSD1 or gluconeogenic defect. And if your growth hormone levels and a cortisol levels are below 10 and 500, you're dealing with a multiple pituitary hormone deficiency. So you have to correct it in accordance to the actual levels that you're seeing. As I said, glucometers are unreliable at lower levels. Do not keep the sample in the place because fluoride, even if it's there, your glucose will go down. For every hour, glucose will go down by 10. So often you will see lab reports of sugars very low, which is not really reliable because they were kept on the desk for a long time. And finally, if you have polycythemia in a child, it may cause a falsely low level of blood sugars, which is there. So these are the most common causes and what is the most important investigation. Now, most important is ketone. If your ketone is low, think of hyperinsulinism, fatty acid oxidation defect, or galactosemia as a possibility. If your lactate is high, only 2 causes, GSD1 along with gluconeogenic defect. Then pH, if you have acidosis, again, you're talking about organic acidemias, lactic acidosis, GSD1, gluconeogenic defect. Any detectable insulin, you're talking about hyperinsulinism, and glucagon tests we don't usually need to do, but rarely it may be required. So from a pediatrician's perspective, we need to know about ketone, lactate, pH, this 3 will decide. So we talk about critical sample. So what is critical sample? During hypoglycemia, you take the sample. But don't send all the sample at the time because otherwise you will waste a lot of money. Based upon the reports, you can then decide which sample to be processed subsequently. So the approach is, if your ketone is hypoketotic or absent, 3 possibilities: do a reducing substance. If reducing substance is positive, you're thinking of a galactosemia or a fructose intolerance. If reducing substance is negative, check insulin. Insulin is undetectable, likely fatty acid oxidation defect. If it's detectable, you're talking about hyperinsulinism. While ketone is high, look at lactate level. If lactate is high, you're dealing with GSD1 or a gluconeogenic defect. If lactate is normal and there is a huge liver, you may have rare causes of GSD3 and 6. While if it's absent, think of cortisol and growth hormone deficiency. And if they are normal, then only you label what is known as ketotic hypoglycemia of infancy or accelerated starvation. That is a diagnosis of exclusion. The most important investigation is ketone, urine reducing substance, pH and lactate. 95% you will get the diagnosis based upon these results from that perspective. Just a few words about fetal physiology. We know that the fetus is entirely dependent on the mother to get the glucose, and there are specific mechanisms by which fetus actually induces insulin resistance in the mother. And it is because of this insulin resistance, mother's sugars go up, which the fetus then extracts. This is a classical parasite response. I would say you produce more glucose, you get that glucose. The fetal physiology is largely directed towards an anabolic pathway. You've got high insulin and you've got low glucagon. You're storing all in the form of glycogen, and this is being stored basically for the postpartum period, and that's what is very important. Now, once the child is born, this whole supply goes off. So you are entirely dependent upon whatever glycogen has been stored. And in this case, you will have, first of all, increased epinephrine. Then you will have a reduction in insulin and increase in glucagon. Most glucose which the baby will get will come from glycogenolysis, followed by gluconeogenesis, and lipolysis and ketogenesis is not good in the first day. So if you check ketones in the first day, they will be low always. Anyway, you don't need to check because that's what we'll talk about. So what happens is, whatever you do, the sugars will fall. The lowest sugar will happen by around 2 to 4 hours. And this will be particularly important in the preterm babies. After that, you will have a rise, and by 48 hours, all your mechanisms are established. So at 48 hours, you can say the child has become a small adult. Duration of fasting will be less, 5 to 6 hours, but they would be able to sustain that. So beyond 48 hours, any hypoglycemia is significant. Now, when should we bother? There are no cutoffs for hypoglycemia in children because you don't have the Whipple triad. There are operational thresholds. Of course, a symptomatic child you have to act, but otherwise the sugars are less than 25 in the first 4 hours, less than 35 in the first 24, less than 50 in the first to second day, and less than 60 up to 72 hours is significant. There may be some minor variations by other protocols, but this is what essentially is important to assess from that perspective. So these are the cutoffs you have to look at in that regard. So you don't need to evaluate every child, every neonate. If it's a persistent hypoglycemia, if the GIR is very high, and there are no evident risk factors like low birth weight, birth asphyxia, you should think of evaluating from that regard. Now we'll start with the first case. Till Dhwani comes up, there's a 6-year-old boy with blood sugar of 36. Dr. Shalini, what would you like to do in this scenario?
So very good morning to all of you. So we are now discussing the small babies with hypoglycemia, which we very routinely get in our NICUs. So a 6-year-old boy with blood sugar 36. I think, Dr. Dhani, you want to say anything?
Yes. We know that 6-year-old boy and the cutoff at 6 hours is 35.
Yeah.
So,
okay. So this is a case of hypoglycemia. So if we say the typical operational threshold as per the WHO, it is the blood sugars which are less than 45 on which we have to act. But actually there is a lot of controversy about this hypoglycemia, and why we are so much worried about hypoglycemia, because it is actually having a lot of implications in the neurodevelopmental outcome of these babies. So especially that is the reason in all the NICUs, we are really very much obsessed for hypoglycemia. But then if we need to know that whether I want to evaluate very extensively this baby, I will say no, because already which is discussed that all the babies, they will be having sudden stoppage of the mother's supply. So the initial first 4 hours, this level of 25, 30, they may be having. They will be adjusting to the extrauterine environment, and then gradually the levels after 2 days, they will be able to, just like the adult physiology. So in this baby, if it is asymptomatic, for this baby, only the observed feeding in the NICU after 30 minutes, we can repeat the blood sugar levels will be suffice. And if there's no risk factor, and the blood sugars are within 48 hours and the baby does well, so no need to do any exhaustive critical sample and endocrinological investigation in these cases.
Thank you so much, ma'am. So the key messages that we
Yeah. So in this case, there is no need. In the small baby, in 6 hours, there is a risk factors, SGA, or there is substrate deficiency. There is no need to do the evaluation. We'll have to have these cutoffs in mind. We have to follow this baby, and I think the baby will do well. Yes.
Moving on to the next case, we have a 3-week-old boy who had symptomatic hypoglycemia. On examination, had micropenis. So, ma'am,
So
again.
yes. So this is a baby which is different. So this is a 2-week-old. So he has already passed that 48 hours. And there is a very specific thing, that is there is micropenis, which is evident here. So can I then we have already discussed that any baby who is having hypoglycemia, the first thing we will do always the ketones. So for the ketones, I just want to ask, okay, so ketones are 2.3. So if we take the blood ketone levels, which we usually do not do, we should do actually ideally with the help of a ketometer, just like a glucometer, we should have that, so that we can get the values. So in this case, the ketone levels are above 2. So they are normal. So it is ketotic hypoglycemia. So on the right hand side, we'll go, that is the ketotic hypoglycemia, and there is already the sodium levels they have seen, that is hyponatremia. And we all know this is a clear-cut case of CAH, in which, or there is hyponatremia, there can be hypokalemia, and we have to look for the 17 OHP levels, and we have to give the steroids. And
No, ma'am. So here the catch point is micropenis with
yes.
Yeah.
So it is because I'm always thinking in that way. So it is basically, we'll go that side of the chart, and because the patient is having I mean the ketones are high, and there's no organomegaly. So this is a case of multiple pituitary hormone deficiency.
So both of them will have hyponatremia and hypoglycemia. It's a very important point. And micropenis was a clue, as Dr. Shalini had.
Okay. So
yes, so here
cortisol.
the cortisol was 125. It was reported to be in the normal range, and a growth hormone of 4.
So in this case, it is reported as normal, as already told that in the case of hypoglycemia, it should be very high. It should be expected to have, because they're all stress hormones, they should be above 550. So it is inappropriately low. So this is a very important message in this case, that this case will be taken as a deficiency, being reported as normal by the labs. Yes.
Often we get the lab reports, everybody says it's normal. So remember, normal, and this is where endocrinologist's opinion will come in. What is the perspective and the clinical scenario?
So usually labs, they will report 4 to 25, like common unit of cortisol is microgram per DL we see in the lab reports. And nanomole per liter is the SI unit, which is being used also. So they will report 4 to 20 or 4 to 22 as normal. So that will be around 120 to 550 will be normal range. So mostly they will report as within normal range. But we should know what is the clinical scenario. So in this case, child has hypoglycemia, and child has hyponatremia on labs and micropenis. In this case, definitely we should think about cortisol deficiency, and that is also central in origin, because micropenis in this age group mostly there may be other uncommon causes also, but mostly this will be due to multiple pituitary hormone deficiency, which is causing adrenal insufficiency and gonadotropin deficiency, which is causing all these things. And growth hormone 4 nanogram per ml, that is also low when child has hypoglycemia. Actually, In infancy, if child does not have even a hypoglycemia, that is also then also child usually they have good normal growth hormone, because in infancy I will say in neonatal period at least in first few weeks of life, growth hormone remains at in normal ranges, because tonic secretion of growth hormone happens in that age group. So that will be more than 7 at least. Usually earlier they used to say more than 10, but that at least that should be more than 7. And when child has hypoglycemia in any age, that should be more than 10. So it is definitely low. So low cortisol, low growth hormone. With this case scenario, we should go for multiple pituitary hormone deficiency, and child will require MRI.
Messages from this case scenario that micropenis with hypoglycemia with palpable gonads, one must think of NPHD. Normal cortisol and growth hormone levels, and moving on to the next case, we have a 10 days old girl with hypoglycemia at a GIR of 14 milligram per kg per minute and negative ketones with negative reducing substance. So, Fatima ma'am.
So this baby girl at 10 days of life has severe hypoglycemia requiring such high GIR of 14 milligram per kg per minute. So it is definitely prolonged or persistent hypoglycemia. And any child presenting with neonatal hypoglycemia, first we need to see for the ketones. So here the ketones were low or absent. The next step is to see for the urine for reducing substance to rule out the galactosemia. We also need to rule out other stigmatas associated with galactosemia, like cataract and cholestasis if it is there. So in this case, the urine for reducing substance was negative. So we need to measure the insulin. So the insulin levels were
any detectable insulin
okay.
level was
So the insulin levels were right. So the insulin, although reported as normal, but any detectable insulin in uh, in hypoglycemia is significant. So this is signifying hyperinsulinism, and we need to treat this baby. We need to because therapy is available for hyperinsulinism. So we should be definitely treating this baby as hyperinsulinism and follow this baby and treat with diazoxide.
So detectable insulin in presence of non-ketotic hypoglycemia showing positive glucagon response. So yes, we're thinking of hyperinsulinism here. Yes, so
this will be important. But some of these patients may actually have undetectable insulins also. So it does. So if you have detectable insulin that is sufficient to diagnose hyperinsulinism, rarely 10-15% cases you may have even negative insulin also can have hyperinsulinism. So then we have got all these which is probably not required for this setting mainly. So if you have high GIR, non-ketotic, you can think of hyperinsulinism as a major cause. It's the most common cause of persistent hypoglycemia. So Dr. Shalini, what do you think about this hyperinsulinism which is now emerging as an important cause in the neonatal period?
Yes, sir. So hyperinsulinism, first thing we will always suspect if we are having very high GIR requirement and persistent hyperinsulinemia. So especially in the newborn period, the GIR requirement as high as 12 to 14 mg per kg per minute and persisting beyond 7 days. So that is a clue towards it. And of course, the hypoketotic hypoglycemia. Because in that group, we have only 3 situations among which galactosemia, hyperinsulinemia, and fatty acid oxidation is very rare. So we have these 2 things among which hyperinsulinemia can be suspected by this. So
yes, so consider hyperinsulinism in presence of high GIR and non-ketotic hypoglycemia. Detectable insulin with low sugars is what will point to.
There was a point like when we should take critical sample. That is very important. When the child is having low sugars in the glucometer, we have to take a critical sample. But at the same time, sometimes these low values, they are not so low because it actually overestimates. So the random blood sugars, they should also be sent at the same time. And we should take real estimations of the values based on that report rather than our hypoglycemia.
Yes, so moving on, we have a 2-day-old girl with symptomatic hypoglycemia, negative ketones, reducing substance was negative, and insulin was at 6 in the detectable range.
Yes, so again, this is also a 2-day-old girl and she's having seizures. So first thing is ketones, which are not there, which are low. And here the two possibilities, again, hyperinsulinemia and galactosemia, among which galactosemia, non-glucose reducing substance was sent, which was negative. So it is out. So then insulin came as 6. So even in the textbooks in the newborn, they write more than 2, as I know, as I consider. But then you said it should be actually 0. So any detectable insulin, it should be a red flag towards hyperinsulinism. So this is also a case of hyperinsulinism.
And we had an LGA baby with weight of
Yes.
4.4.
Okay. So this is a SGA baby, and SGA babies, they are okay. This is a LGA baby. Okay, correct. So in this case, for the LGA babies, there can be the infant of diabetic mother, and in which the baby is exposed to high level of glucose and with the insulin overproduction in the fetus, so which may be there as a transient or prolonged hyperinsulinemia, which may resolve over a period of 3 months.
Thank you so much, ma'am. So yes, consider infant of diabetic mother with early onset hypoglycemia.
And maternal.
Yeah, but still see patients in this mother have not been really screened for hyperglycemia. You should be aware that this child was referred as congenital hyperinsulinemia. Will require long-term evaluation. You said first test the mother. So that is the message basically there, that always check the HbA1c in the mother before you go ahead with extensive investigations. And the onset is also very early. So as Dr. Shalini was discussing, galactosemia typically will have 2-week, 3-week smoldering presentation, not a very high GIR. Fatty acid oxidation. So if you have very early onset severe hypoglycemia, hyperinsulinism is the bet you have to go for in most cases.
Moving on to the next case, we have a 14-day-old boy with birth asphyxia admitted in the NICU, having hypoglycemia with blood sugar of 28, requiring a high glucose infusion rate of 14 milligram per kg per minute, non-ketotic with insulin of 4.2. The child had a birth weight of 1.6 kg. So, Dr. Lokesh, how do we proceed in the evaluation of this case?
So in this case, definite hypoglycemia is there and very high GIR is required at 14 days of life. As we have already discussed now, GIR above at 8 or 10 to maintain glycemia, it is more or less pathognomic for hyperinsulinemia only, because all other things we will only require maintenance glucose, that is 4 to 6 milligram per kg per minute. If it is child is requiring more than 8 or 10, it is conjunctive hypoglycemia, because insulin is consuming that dextrose. That's why child is having hypoglycemia. So we are already tilted towards hyperinsulinemia, and now we have reports ketone less than 2, like definitely low ketones, high insulin. And now we have few other clues in this case. Child has stormy course in the NICU. He had birth asphyxia and he was SGA also, short for gestational age. So these are the two things when they are prone for hyperinsulinism, and that is mostly transient hyperinsulinism, not genetic hyperinsulinism. In this case, our prognosis will depend on these things, because if we are dealing with the case of transient hyperinsulinism, dose of diazoxide will be less, and severity of the disease, when time will pass, severity of disease will also be less. So they will have a course of 3 or 6 months or so, and then we'll be able to stop diazoxide. So this is how we'll go in this case.
On follow-up, the child was on diazoxide of 10 milligram per kg per minute
10.
and had a reduced GIR requirement, showed weight gain and edema, clinical edema.
So when we are starting diazoxide, we should know what are the side effects, what are the adverse effects we are going to expect. So whenever we are planning to start a child on diazoxide, first we should go get an echo, 2D echo, because one thing is that diazoxide, that diazoxide will cause fluid overload, and this is more like complications of CCF will be more in the children who have congenital cardiac defects. And the children we are dealing in this category, hyperinsulinism, they have higher chances of, they have a higher proportion of cardiac defects. So we should do an echo, we should document any cardiac defects and pulmonary artery pressure, because pulmonary artery hypertension is another thing, another complication of dioxide. And if we do have anything in echo present, then we will start chlorothiazide in addition to dioxide at very onset. And like these are like two schools of thoughts are there. Many places in globe, like Children's Hospital of Philadelphia, which is the largest center of hyperinsulinemia, they will start all children with dioxide straight away with thyroid also. But many centers, they will practice, they will do a 2D echo. If it is normal, then we will watch for the symptoms of fluid overload. And if the fluid overload is there, we will start on thiazide, otherwise we will not. So one thing is that, another what are the things? Neutropenia, hyperuricemia, and thrombocytopenia are other complications we should be looking for.
Passages here about that prolonged hyperinsulinism may be expected in an SGA child, and one may consider diazoxide therapy here.
I think one big message which Dr. Shalini probably you can also give is that we were thinking earlier, maybe 10, 20 years ago, that this hypoglycemia in SGA was because of low substrat. Everybody was talking about low glycogen. But now actually insulin excess is a major cause. What's your experience in the NICU setting, Dr. Shalini?
Yeah, so in majority of the cases, we think SGA is taught that it is hypoglycemia because of the reserves.
Yeah.
But then we have also seen many cases, and 3 to 5 cases, not much, which we put on diazoxide and later led to in the follow-up of the pediatric endocrinologist, which were off diazoxide in 2 to 3 months.
Yeah, I think
Gradually,
that's a very important. Prolonged hyperinsulinism is in fact the most common cause of hyperinsulinism. You have got the transient like IDM and all, which will go in a week. This will go up to 3 months, 4 months. It may smolder, but don't worry, they will go normal. However, if you have a child who is severely macrosomic, GIR is very high, he has got hairy pinna, everything, mother's HbA1c is normal, that is not that picture, that is a genetic form of hyperinsulinism. There you should go for diazoxide trial. If the diazoxide trial is not there, go for a genetic study. Then you can think of, okay, diazoxide partial or a complete focal lesion. So that's a different thing which we are not discussing, but that is the third group of hyperinsulinism which is there.
Next, we have a 6-month-old boy with lethargy and blood sugar of 36 at 6 months of age. So, Arpita ma'am.
Okay, so this baby is presenting now in infancy. He's a 6-month-old baby and he's having symptomatic hypoglycemia. And first, we need to understand the basic physiology. If the mechanism of glycogenolysis and gluconeogenesis, ketogenesis, and lipolysis are intact, this baby should have sustained a starvation of about 6 to 12 hours. In this situation, the baby is having hypoglycemia, so there is something wrong in any of these mechanisms. So first thing, we need to see the ketones. So here, the ketones are present. The next thing we need to see is for the lactate levels. So the lactate levels are high in this case, and we need to strongly consider the glycogen storage disease, and we need to see whether there is any organomegaly present in this child or not. So here in this baby, we found a hepatomegaly. So that was conclusive of glycogen storage disease. And as the name suggests, it is a glycogen. The glycogen is getting deposited in the liver and the muscles. So there is no glucose available to this baby, and he will not be able to sustain starvation for prolonged period of time. So what we can do in such babies is we can advise frequent feeding to these babies, and especially emphasize on nighttime feeding, which can be ensured by nasogastric tube insertion also. And even cornstarch can be added in the diet of this baby so that hypoglycemia can be avoided and other neurodevelopmental defects associated with hypoglycemia can be avoided.
So GSD is like demonetization. All your money is in the bank. You cannot take it out. That is the problem. If you have stored it, it doesn't come out. Next case quickly.
3-week-old boy with failure to thrive had low blood sugar on GIR6. Clinically had hepatomegaly. Shalini ma'am.
So this is a 3-week-old. So there is a liver and GIR is 6. So the ketone is not there and reducing substance is positive. So I think with the whole discussion, all of us, we know that this is a case of galactosemia. So neonatal period, hepatomegaly, GALT assay is the test of choice. and there is no ketone and there is no reducing substance, non-glucose reducing substances positive, then we have to consider this diagnosis. And cataract can be also a clue towards it.
Moving on to the next case, 1-year-old girl came with not waking up in the morning, had low blood sugar, no hepatomegaly on clinical examination. Lokesh sir,
In this case, an infant who is going towards toddlerhood has hypoglycemia and with high ketones, normal lactate. And we do not have any clue on examination. So we should think towards ketotic hypoglycemia. Ketotic hypoglycemia has another name of accelerated starvation, and that is a diagnosis of exclusion. So we should do all we will require a fasting test, a critical sample during spontaneous fast or a diagnostic fast. And after that, we have got all the normal reports, normal cortisol, normal growth hormone, and high ketones, no lactate, normal blood gas, and then there is no clue on examination also. No ergonomically development is normal, no cataract. Then we should think about this diagnosis. That is accelerated starvation. What is accelerated starvation? This is I will say everything is normal except that tolerance of fasting is less than normal individuals. So a normal child can tolerate a fast of 18 or 24 hours. This child will not tolerate a fast of more than 10 to 12 hours. That's it. So the children will require frequent feedings to prevent hypoglycemia.
During illnesses. So often during intercurrent illnesses, give them juices, more liquids, nighttime feed. That is very, very important.
we have a 2-year-old boy with failure to thrive, presenting with vomiting, lethargy, had a blood sugar of 28 at presentation, ketosis with ketones of 3.2, lactate 1 millimole per liter, was diagnosed as accelerated starvation. Arpita ma'am?
So this boy at 2 years presented with symptomatic hypoglycemia and it was ketotic and was labeled as accelerated starvation. But as explained beautifully by Dr. Lokesh, we should not establish the diagnosis of accelerated starvation before clinically evaluating the baby thoroughly. So we need to take a proper history in this child. History of alacrimia is important. History of vomiting with stale food material and pigmentation in such babies should be thoroughly examined. And in this baby, the pigmentation was there. Then we need to see for the cortisol and growth hormone levels, which were deficient in this case. And there was even hyponatremia. So with this, we can come to the diagnosis of AAA syndrome, which is achalasia, alacrimia, and Addison's disease. And we need to manage such patients accordingly. So with this case, we need to we can have the key message that accelerated starvation is a diagnosis of exclusion. It should be established after ruling out all the other possible diagnoses.
So that's why we don't use the term ketotic hypoglycemia, because every hypoglycemia is ketotic unless you have high insulin or fatty acid oxidation defect. So I think it was a wonderful discussion. I'd like to thank Dr. Shalini, Dr. Arpita, and Dr. Lokesh for this nice interaction covering all the cases, and Dr. Dhwani as well for the nice presentation. I think we're running a bit late, so we can quickly move to the next session on calcium. So you've got the...
Can we please have a huge round of applause for all our speakers and panelists? I would like to request our residents to please give away the mementos. We're giving our first memento to Dr. Shalini Tripathi, Additional Professor, Department of Pediatrics, KGMU. Second memento to Dr. Arpita. And third memento to Dr. Lokesh from Medanta Hospital, Lucknow. I would also request our resident to please felicitate Dr. Anurag Bajpai sir with a memento. Thank you, ma'am, and thank you, sir. Your insights, expertise, and contribution have set the tone for this program, and we are all very grateful for this opportunity to learn from you. Can we please have a thunderous round of applause for all our speakers and panelists once again? Please join me in welcoming our next speaker, Dr. Aisha Ahmed from Aligarh Muslim University for the next session on calcium metabolism. The expert panelists for this sessions are two of the most renowned pediatricians in Lucknow, Dr. Anurag Katiyar, President of the Lucknow Academy of Pediatrics, and Dr. Utkarsh Bansal from Lucknow Academy of Pediatrics. Dr. Aisha Ahmed will also be the panelist for this session.
Dr. Anurag Katiyar is not there, so Dr. Nitin has joined as the other panelist. He's a pediatrician in there. So Dr. Utkarsh, Dr. Nitin.
I would also invite Dr. Vibha for the case presentation.
Again, is that we are trying to cover three important causes of hypocalcemia, rickets, and hypercalcemia. So Dr. Aisha will be discussing the overview, and then from there you will have the presentation which will happen, and then we'll have the case discussions coming up one by one. Dr. Aisha doesn't need any introduction. She is a very eminent pediatric endocrinologist working in AMU Aligarh, and she has been involved in academic activities with Grow Society, Mediclasses for now over a decade. And we have been implementing these programs. So give a big round of applause. She's come all the way from Aligarh. So welcome, Dr. Aisha.
Good morning, everyone, and thank you, Anurag sir, and thank you, Arpita, for giving me this opportunity today. So here we move on to another invigorating topic, that is calcium. So in the beginning, to begin with, so to begin with, I'll talk about we'll have a quick recap and revision of what you already know. How does calcium circulate in the body? So as you all know, most of the calcium, about 90% of the calcium is stored in the bones and teeth in the form of calcium hydroxyapatite. And it's only 1% of calcium which is available for exerting its physiological actions. So out of this 1% calcium that is available, again, about roughly 40% of calcium is present in the circulation bound to albumin, which we call as bound calcium, whereas about roughly 10% is available bound to serum phosphate levels, and it's only about 50% of calcium which is available as ionized calcium, or this is the free calcium, which is again available and it exerts its physiological action. Now, there is a close two-way traffic between ionized calcium and the bound form of calcium, between the bound form and the free form of calcium, and that depends a lot of factors, and pH being one of them. So, how does pH affect? In condition where there is an increase in pH or alkalosis, so there is a less of hydrogen ions which compete less with the bound form of calcium. So it leads to increase in the proportion of calcium which is bound to albumin. So the bound level increases, which reduces the ionized form or the free form of the calcium. So so that leads to reduction in the ionized form of calcium. So this thing always has to be interpreted with caution. You always have to look for serum albumin levels always before interpreting about the serum calcium levels. So in conditions like alkalosis, or in conditions like you may have features of hypocalcemia. So always be wary of conditions which might cause alkalosis, because they might lead to increase in the bound form of calcium and reduce ionized calcium, and the patient may have features of hypocalcemia. So in conditions like hyperventilation or increase in the sodium bicarbonate level, there is bound to be hypocalcemia. So always look for that and always anticipate in such a situation. So talking about calcium homeostasis, so how does calcium is affected and it's metabolized and it circulates in the body? So for maintaining ideal homeostasis, the three main organs for calcium are the bones, which is the main storage form, and the calcium can circulate in the bloodstream and in and out of the bones depending upon different hormones. Then we have another organs like intestine, which again regulates calcium by absorbing and filtering and secreting calcium levels. And also the third important organ is kidney. So these organs, they work together, closely together, along with presence of other hormones like parathormone, very important hormone for maintaining serum calcium levels. and also calcitonin, which helps in again regulating by decreasing the amount of serum calcium by sending the calcium into the bones, and also the calcitriol, which is the activated form of vitamin D. So they all close together help in maintaining homeostasis of calcium. So the calcium thus formed, it exerts its action by acting on the calcium receptors which are present in different organs of the body. So this is all that you know. So talking about reduction in calcium levels or hypocalcemia. So when do you suspect and how can a child with hypocalcemia present? So the manifestations could be seizures, which is the most common manifestation apart from hypoglycemia, which makes us think about calcium as a culprit. Then it could be cardiomyopathy. So the patient might present with features of cardiac failure. There might also be intracranial calcification. So always suspect there is some abnormality with the calcium. If the child presents with the intracranial calcification, then you can have features of raised intracranial pressure. You can have a child, especially a young child who presents with stridor. So these are all the conditions which should make us think about hypocalcemia as the reason, or there may be a presence of cataract. So who are the children? These are the main manifestation, and who are the children who are at high risk, where we should always think about calcium and screen for them before these even presenting complaints happen. So in children who are born preterm, so preterm babies who are born with a low birth weight, preterm babies, low birth weight babies, who have got any other associated cardiac abnormality. So always suspect and always anticipate that they might have hypocalcemia in the future, and always screen for them. So talking about how to assess, how to look for calcium biochemically. So calcium is best assessed in the serum sample. Serum sample is needed for assessing calcium, and ideally it should be taken and collected in the fasting state. So this is the ideal situation. So there are some pitfalls because again, calcium has not to be interpreted in isolation. So there are certain pitfalls, as I had already said, that most of the calcium is present in the circulation bound to albumin. So obviously, if there are any conditions which affect this albumin levels, so there are bound to be alteration or interpretation of serum calcium levels. So always look for serum albumin levels before making any conclusion. So in conditions where the proteins would be high, obviously it's going to affect your result. So how to rectify that? How to correct for that? So here you can see one formula, like for sodium that we talked about in DKA. So you always have to calculate corrected sodium, corrected calcium levels in patients with hypocalcemia. So how do you calculate that? So the corrected calcium is calculated as measured calcium, what is given in your lab values, plus 4 minus albumin into 0.8. This is for milligram percent. And if the values are in millimoles, then we have another form. So always check for corrected calcium before any intervention. And okay, so talking about this was about calcium. So talking about another hormone which works in another mineral which works in close liaison with the calcium is phosphorus. So never forget phosphorus, and phosphate is always something which should be interpreted and assessed along with calcium. So coming to the timing, how do you assess phosphate levels biochemically? Again, morning sample, serum sample, morning sample, and fasting state sample is the preferred test and the preferred way of assessing serum phosphate levels. Then the caution, the pitfall, what is the caution that is required here? So no tourniquet. So that is our habit that we always tend to, especially for small children, and we tend to put in a lot of pressure in squeezing the sample while drawing the sample, especially in newborns. So this is a process which is not warranted and should be avoided because it might lead to falsely elevated levels of serum phosphates. Always take a fresh sample. Do not apply any tourniquet, and you need to analyze it as soon as possible. Any delays might lead to false elevation of serum phosphate levels. And always remember, like for many things, like most of the things in pediatrics, we have age cutoff level. So for serum phosphate level, you should always check for age before calling it normal or abnormal. So we have different phosphate levels at different age group, and as the age advances, the normal levels decrease. So before making any impression, always check for the age of the patient before calling it either normal levels or abnormal levels. Okay, so this is a conversion. So talking about another important hormone, parathormone, the first thing that comes to our mind, apart from vitamin D, whenever we think of calcium, is obviously parathormone. So parathormone, is a compensatory response. It has inverse relationship with calcium. But again, this is one hormone, very, I would say, available in most of the labs these days, but has to be interpreted with caution because it's a thermolabile. So the sample should always be sent in on ice and should be analyzed as soon as possible. So you should not keep the sample at room temperature and wait for analysis to take place because that will again alter your results. Always, and parathormone, again, one thing which is never estimated, and decisions are not taken based on a single value of parathormone. So you have to check that in context of the calcium and phosphate. Okay. So suppose we have calcium and we have parathormone. So there is an interaction. If there is any reduction in the calcium, so that would lead to, as a compensation, increase in the level of parathormone. So suppose we have a situation or a condition, we have a hypocalcemia. So the levels of parathormone should always go high. This is a compensatory mechanism to bring the calcium levels back to normal range. So the parathormone levels would be high. So always look for the condition. So that could be either pseudohypoparathyroidism or it could be secondary. So hypocalcemia leading to increased production of the parathormone to compensate for this normocalcemia to be maintained. And in conditions where you have low parathormone levels, again, it has to be interpreted in association with the serum calcium levels. So in condition where the parathormone levels go low or normal, inappropriately normal in presence of low calcium, so always think of hypoparathyroidism as one of the situations. So parathormone should not be ever analyzed in isolation, but always in context with what the serum calcium and phosphate levels are. So coming to one condition where the calcium levels are hypo. Okay, so this is hypocalcemia. So talking about different disorders. So these are the most common disorders that we frequently encounter. So we can have vitamin D deficiency, you can have vitamin D dependent rickets, or you can have vitamin D resistant rickets. And also you can see hypocalcemia in conditions like where you have renal insufficiencies or hypoparathyroidism. So these are the conditions that we frequently encounter. So how to assess and how to make a differential diagnosis, so will depend upon the different minerals and different metabolites. So talking about phosphate first, so you can see whenever you have hypocalcemia, the phosphate levels would be low. Okay, in the common situations like in vitamin D deficiency or in vitamin D dependent rickets. But there are few exceptions which you always need to remember in kidney failure and in hypoparathyroidism and in also PHP, pseudohypoparathyroidism, the phosphate levels would be high. So always remember, whenever you see calcium, you expect phosphate levels would be low, except in these situations where the levels could be high. So in case of high phosphate, always think about kidney as the problem area, or always think about pseudohypoparathyroidism. So this is how we check for phosphate. Then the second important parameter is parathormone. As I said, the calcium levels are low, so the parathormone levels would go high to compensate for this hypocalcemia. So they would be high in most of the conditions, most of the common conditions that we encounter, except in certain conditions, obviously, like in hypoparathyroidism or in cases of calcium receptor sensing defect. In this situation, you may have parathormones that are inappropriately low for hypocalcemia. So coming to another, that is vitamin D levels, which we always tend to estimate whenever we see a patient with hypocalcemia. So the levels would be normal in all the situations. So don't be just misguided by that. But they can be low in obviously vitamin D deficiency. So you send for vitamin D levels, but in most of the conditions, the levels could be normal. So then coming to the another form of vitamin D, that is the activated vitamin D, 125 dihydroxycalciferol. So that is the calcitriol. So it will be low in most of the conditions that we encounter and listed here, except in conditions like vitamin D dependent rickets type 2 or vitamin D resistant rickets, where you can have the levels of the calcitriol, because again it's a receptor defect, so it might lead to increase in the levels of the 125 dihydroxy. So the levels would be high in one situation, in all other situations, the levels would be normal. And another parameter is urinary calcium. So you always check for what is the status of the urinary calcium excretion. So it will be low in all the situations, the listed situation, except in calcium sensing defect, in which there will be a hypercalciuria. This is a chart to help you people make a decision and just to boil down on your differentials. So how to approach a child who presents with hypocalcemia? So apart from calcium, you know, that is no, welcome. So calcium is low. So how do we approach a patient who presents with calcium in the lower range? So always check for the another metabolite, that is phosphorus level. So always check for phosphorus level. So okay. So how does it help? If the phosphate levels are high, so think of two situations. One is the renal, the kidney involvement. Another is the hypoparathyroidism. So what you can do is, in situation in which the conditions are relatively less common and lesser in number. So in situations where you have a high phosphate in the high range, so always think about go for creatinine. Think about renal disorders and go for creatinine first. So creatinine, if that comes out to be high, think of chronic kidney disease and it has to be managed accordingly. Whereas if the creatinine levels are normal, then parathormone is the second level of investigation that you should always order. So in cases of high phosphate, first creatinine, and if that comes out to be normal, then think about parathormone, and it could be low in cases of hypoparathyroidism. And if the levels are normal, parathormone levels are inappropriately high, which you do not expect. So it could be because of zero hypoparathyroidism, which is again a form of receptor defect, resistance at the level of receptor. So going to the another prong, if you have no low or inappropriately normal vitamin D phosphorus levels, if that levels comes out to be normal, then the second step should be check for vitamin D. So when it's high, you check for creatinine. If the levels are normal, always check for vitamin D levels, because again, it's a very common form of deficiency that we see in our population. So if that comes out to be low, then obviously it has to be taken and treated as vitamin D deficiency. Whereas if the level of 25 hydroxy come out to be normal, then go for the another part, that is the activated part, that is the calcitriol. Calcitriol levels, if they are low, that should make you think about vitamin D resistant rickets type 1. Whereas if the levels of this calcitriol are high, think of vitamin D dependent rickets type 2. And always just don't forget these small things here, the small metabolites. Whenever interpreting, again going for phosphorus, look for these things also, like albumin. As I said, albumin has also be always to be checked. Similarly, you should always check for magnesium levels before making any interpretation in patients with hypocalcemia. So can anybody say how magnesium, where does it fit? How does it help? How does it affect calcium metabolism? Where does magnesium come into play? This magnesium. How does it affect? PTH. It acts on PTH, uska secretion, and also action on its receptor. Okay, so always don't forget rather magnesium. So always check for magnesium levels also before again barging into starting any form of management in a child with hypocalcemia. So this is how we approach. So we go on to the case. So I'll call Dr. Vedant.
Because there's so thanks, Dr. Aisha, for really pointing out these important parts of magnesium, phosphorus, creatinine, PTH. Only 4 investigations will give you a clue. So Dr. Vibha, you can go to the cases.
Thank you, sir. So let's begin with the cases. We have this 4-month-old boy who was a diagnosed case of nephrotic syndrome, but he was referred to us for hypocalcemia. But there was no symptom. He didn't have any cramps, muscle cramps, tetany. So, Dr. Nitin, how should we approach? Does this patient require any further evaluation?
So as a dictum, we should treat the patient, not the report. And report is less, but we should also consider why it is less. So this is the algorithm, and before running any vehicle, we should also check that air is there or the fuel is there or not. So we should check the albumin. Before running this algorithm, we should also focus that albumin is normal or less. So if because the patient is nephrotic syndrome, albumin is less, and the formula is that each 1 gram decrease in albumin causes 0.8 degree 0.8 milligram per deciliter increase in the value of calcium. Okay, so 4 minus 2 means 2 into 0.8, 1.6. So we should add 1.6 into that. So we, after adding 1.6, the value becomes normal. 7.2 plus 1.6, 8.8. So this value is normal. So we don't have to treat the, and this is the message also, that before running the algorithm, we should also check the albumin level and correct for that albumin.
Very well said. Thank you. So we should always correct the albumin in the cases where the chances of albumin is low, like in the cases of nephrotic syndrome, liver diseases, and so and the ionic calcium is preferred rather than the total calcium. So moving towards the next case, we have this 4-year-old girl who was symptomatic as she had tympani. Her ionic calcium was 3.1 and she has high phosphate of 8.4. And PTH was also high, that is 130 picomole per liter. So she was diagnosed as pseudohypoparathyroidism. So Dr. Utkarsh, do you agree with the diagnosis?
So the approach which is given tells you how to move step by step, and that will not only save you from going into some severe type of diagnosis, but also will save money of the patient. So in this case, once we have looked at albumin and magnesium are not causing problem, we have looked at the phosphorus level, and when it is high, our first investigation should be looking at the creatinine level. And if we do creatinine, we have found that in this case, the creatinine levels are high. So this is a case of chronic kidney disease, and we should not label it as pseudohypoparathyroidism or hypoparathyroidism, which will create a lot of problem. We can manage this case as a renal case now.
Thank you, sir. So moving towards the next case, we have this 1-year-old boy who was referred to us for this neonatal seizure, and his calcium was 5.4, definitely low, and but his phosphate was also within the normal limit as far as the age, and his PTH was low. So IV calcium was given, but he showed no response. So Dr. Aisha, how should we approach in this?
Okay. So we have this 1-year-old boy who has obviously hypocalcemia, which is symptomatic. So you have managed it in the right direction. So you have given IV calcium, but there is no response. So I want answer from the audience. What do you people think? What should be the next step? You should always check magnesium. Okay, so going with the flow, whenever you have before embarking on any other expensive investigations, always check for serum magnesium levels, because always, obviously after checking the dosage of calcium, always check for albumin and also magnesium. This is one trend which should never be forgotten. What are the serum magnesium levels? They were low. So perhaps that was a case of hypomagnesemia, which you can see in receptor defects, congenital form, and maybe they require, and these are the conditions which require very supratherapeutic, supraphysiological doses of magnesium for its effect to take place. So giving IV calcium here won't suffice. So always check albumin, always check magnesium before going off for further investigation. I think this is what happened in this case also. So this was a
Very rightly said. And definitely in PRMPs, the effect we require very high dose of magnesium also.
and they will respond to high dose of
So ma'am, what key message would you like
key
to give?
message. The same key messages that always think of whenever you have a child who presents with hypocalcemia, always check for corrected calcium. And this child, he had symptomatic hypocalcemia. So always check for serum magnesium level, always.
So what are the two other conditions? Dr. Aisha said hypocalcemia, refractory, check for magnesium. What are the two other conditions when we will check for magnesium? Refractory, hypokalemia, metabolic alkalosis, hypophosphatemia. So if you have one intracellular ion less, the other two will also go down. So if your potassium is low, your magnesium will go down, your phosphorus will go down.
So we have this 3-month-old girl, and we got a reference from the PICU as she was having seizure. And when the calcium was measured, it was 3.2, which was low. Even her phosphate was low. And when the PTH level was done, it came out to be 3.4. So she was diagnosed as hypoparathyroidism. So Dr. Nitin, what do you think?
So in this case, the calcium is low and phosphorus is also low. But we have read that if there is problem of PTH, there will be inverse relationship between calcium and phosphorus. Calcium will be low and phosphorus will be high. So, but they are going in hand in hand. So that is not showing that PTH response is responsible for this. And in this chart, we are seeing the log linear relationship, inverse log linear. When calcium is low, the PTH should be high. So we should do contextual assessment. Means we should simultaneously measure calcium and PTH. And because PTH in the report was even low, and it may be due to the inappropriate processing or sampling, or the transport was not good. Transport was not in the ice. Because of that, that problem may arise.
Very rightly said. So, what key messages would you like to give from this case?
The message that the PTH should be done in the transport should be done on ice, and in the algorithm, if we see the vitamin D level is less, and because both are in hand, calcium is also low, phosphorus is also low. So it is showing that it is due to vitamin D deficiency, not due to the PTH problem.
This is a very common problem. We send PTH and it is reported as low. So it is not low. It is actually normal. So always send it on ice or send the child to the lab. A lot of these processing labs and these collection centers, they take the sample, keep it there, and your PTH will come low. This is the message that we are trying to give. Through this, I think Dr. Nitin said very nicely. So always transport on ice, that becomes important. And as he said, if the phosphorus is low, it is unlikely, it's not hypoparathyroidism.
Thank you, sir. So we have this next case. We have this one weak boy. So we got a reference from the NICU for seizures, and his this ionic calcium was low. So further evaluation was done, and his phosphate was very high, like 10.1, and his creatinine was normal. So Dr. Utkarsh, how should we approach in this case?
Like the previous case which I was talking, if we are looking at hypocalcemia with a high phosphorus, we will look for creatinine. If the creatinine is normal, then we have to do the parathormone. And we look at the parathormone level, and in this case, it is 2. So it is a case of hypoparathyroidism. And once we have a case of hypoparathyroidism, we should look for the cardiac defects also in these cases, because it is commonly associated with DiGeorge syndrome.
Definitely, sir. So what key messages would you like to give?
So the key messages are, if you have a high phosphate level, then only you have to think of parathormone defect. As in the previous case, Dr. Nitin has told, parathormone levels will not be low in cases of low phosphates, and cardiac evaluation should be done when you suspect hypoparathyroidism.
Thank you, sir. So moving towards the next case, this 10-year-old boy who came to us as he was having seizures, he also had hypocalcemia, and when his parents show us the CT report, it shows basal ganglia calcification. So Dr. Aisha, what do you think about this case?
So here we have an adolescent boy who again presented with hypocalcemic seizures. And here we have something which should make us clinch the diagnosis, that is basal ganglia calcification. So can somebody say what should be? Welcome to it. So look for it, because this could be because intracranial calcification, especially basal ganglia calcification, should make you think about parathormone problem at the parathormone level. So always look for other markers, other stigmata in the child. So as we can see here, this child has round face. So it might be indicator of underlying syndrome. So he has, what can you see in the second slide, the second picture? The knuckles that are being shown. What can you see in the picture? Can you see the dimpling in the knuckle? Brachymetacarpia. This is shortening of the metacarpal, especially third and fourth metacarpal. So once you make the child make his fist, so you'll see dimpling. Rather than presence of knuckle, you will see dimpling. Physiognomic of a condition. And in the third picture, as you can see here, you can see the presence of subcutaneous nodules. it should make you think about pseudo-hypoparathyroidism. So these are the pathognomic markers. Whenever you have a child who presents with basal ganglia calcification, always think about parathyroid defect. So look for other features. And as you can see in the flow chart,
Yes, ma'am.
so you
Um,
went for
phosphate
levels
was high
So again, going in features of parathormone defect.
and creatinine was normal.
So parathormone phosphate levels high, always go for creatinine levels. Always exclude CKD first. So the creatinine levels were normal.
And
So the
PTH
second
level
step would be go for parathormone levels which were high.
high, 200.
So okay, then next. So this would be a case of hypoparathyroidism. So the clinching, the catch here was the intracranial calcification. So it could happen both in pseudohypopara and hypoparathyroidism, but the high parathormone levels are going in favor of pseudohypopara. This is the key message that you are supposed to take from here.
Thank you very much, ma'am.
Quickly go to rickets. We have time. You want to start the inauguration now? We can do rickets. Yeah. Yes. So we will do rickets, and as and when we stop our because we already done hypocalcemia and rickets, our calcium will pretty much be over with that. You can continue with the rickets. We'll stop as and when we like. So we'll now move forward towards please come on rickets. So Dr. Aisha will give an overview first.
I'm here again talking about another aspect, that is rickets. Again, very important from clinical point of view. So talking about rickets, so whenever we have a child who comes with a difficulty in walking or any physical pathognomic features, so this is the first investigation that we tend to order, or most of the time the patient comes with X-ray of the wrist. So what are the features which make us think about rickets? So again, a revision of what happens. So actually problem happens because of the failure of mineralization at the metaphyseal end. So you may have features because of that. So the pathognomic features will be cupping, the cupping of the metaphyseal end of the radius and also ulna later. And then you can have a fraying. Fraying means there the margin of the metaphysis, it's not very distinct. You say haziness among the end of the long bones, especially in the upper limb. And also you may have splaying, which means there is widening, called widening of the wrist, which happens when the child begins to bear weight. So because of the pressure, there is widening of the wrist. So these are the characteristic features that we tend to see in a child who presents with rickets. So coming to the guidelines, the recommendation, the recent 2021 guidelines, they say that daily administration in children who have rickets is better. Oral administration is better. IM is reserved only for those who cannot tolerate or if there are any features of malabsorption. Oral 3000 international units for 12 weeks recommended treatment, and you should keep monitoring. So how do you monitor? You detect the child as having rickets, you start him on treatment, then how do you monitor? So how do you monitor response for therapy? So just remember that you cannot monitor it by checking for calcium levels, because the levels might decrease initially. Rather than coming back to normal, they might decrease initially because of increase in the bone turnover. Similarly, for alkaline phosphatase, we always see alkaline phosphatase levels are high at the point of initiation, but don't be misguided by that, because they also tend to falsely elevate, especially with the initiation of therapy. So they might be falsely normal or high after you start child on treatment. And as far as clinical features are concerned, so they might be increase in the bone. So these features might present. So how to check for optimum response? So the gold standard remains the line of healing. So always go for check X-ray, and this line of healing takes place about 4 to 6 weeks for its effect. But if it's not present by 6 weeks, think there is some problem. By 6 weeks, we expect this line of healing to be present in a child who initially presented with rickets. So what do you call as refractory rickets? When do you think or suspect that the things are not normal? So in the patients who have predominantly metaphyseal involvement, in children who have received adequate treatment, you have given 1 dose or even second dose. Some might require even a second dose, and still they are not showing good response. And lack of response means there is no line of healing by even 6 weeks of adequate therapy, given you have provided with adequate dosage of not only vitamin D, but also calcium. And also there is no line of healing, and there is also no clinical improvement. So, and in association, if there are certain features, any pointers in the history which will make you think that this is perhaps a case of refractory rickets. So any child who has polyuria, because that is not a normal presentation, any child who has seizures because of hypocalcemia, if he has fractures because of that, or if a child has growth failure or failure to. So always think of other causes, refractory rickets, and there might be some pseudo diagnosis, false diagnosis also, like predominant metaphyseal involvement. You might have skeletal dysplasia as the culprits. Always don't confine your thoughts to rickets. Always think of other causes. It's not every cupping, every splaying, or every like bony deformities because of rickets. So low dose, though the child has received adequate dosage of vitamin D, but this is very common scenario that the child is not receiving adequate dose of calcium. Always check that the child is receiving calcium or not, and always look for increase in the biochemical parameters. So talking about rickets, you can classify rickets as deficiency, which is the most common form that we encounter, which could be because of calcium deficiency, which could be because of vitamin D deficiency. So you start the child on treatment and you look for therapeutic response, which could be clinical improvement and line of healing that we see radiologically. If the child does not respond, despite taking all the steps and precautions, then you might think about refractory rickets. So what comes under refractory rickets? So it could be because of low calcium reserves or calcipenic rickets. And the conditions are vitamin D deficient, dependent rickets type 1 and 2. It could be because of renal failure or malabsorption. So these classify under calcipenic forms of refractory rickets. So what will be the clinical manifestation? How will the child present in such situations? So it will be early onset rickets, early in infancy. You'll have high PTH, which is expected in such scenario, and they'll have low calcium. Okay? So this is the situation where you think about refractory rickets, which is because of calciopenia. Then another could be if you have acidosis along with hypocalcemia and features of rickets. So always think about renal tubular acidosis. Always think about RTAs. How do patients present with refractory rickets because of underlying RTA? So they have polyuria, very commonly seen, and they have failure to thrive. And they also may have nephrocalcinosis. Always check for abdominal ultrasound to look for nephrocalcinosis. So this is what makes us think. And rickets could be because of even phosphate deficiency. So it's not confined to just calcium and vitamin D. Also, it could be because of phosphate deficiency, which could be in hereditary phosphopenic rickets or in Fanconi syndrome or malabsorption. So what will be the characteristic feature or the pointer again in the history, which should make you think about phosphopenic rickets as the reason? So it will have a late onset. So the onset will be in like adolescent or 10 to 12 years of age. And the involvement is more of the lower limb. So if you have a young adult and having involvement predominantly of the lower limb, and you have normal calcium and also normal parathormone. So these are the clinchers which should make you think that perhaps it's because of phosphate deficiency. So coming to, is it refractory? The first question you have to confirm whenever a child comes with bowed legs and the physical features, always confirm whether that is rickets or not. So be wary of the false diagnosis and other conditions which might mimic rickets. Once you are confirmed, is it refractory? Is it responsive rickets because of calcium, which can be amenable to treatment with vitamin D and calcium, or is it refractory rickets? And if it's refractory, so check for underlying cause. Why there is so much of refraction? Why the child is not responding? So because the management will definitely depend upon the cause that you know. So as far as investigations are concerned, the first line of investigation should always be phosphorus. You should also given the same amount of importance to phosphorus as the calcium. So high, again, I would say high phosphate levels, always think about kidney. That could be because of chronic kidney disease or pseudohypoparathyroidism. So parathyroid involvement or renal involvement in cases the phosphorus levels are high. If they are then the next step should be check for urine calcium. So these are certain exceptions you can say, which can again help you in coming to a point, because every other thing would be normal. The exception you can say urinary calcium low in all the case except in cases of RTA. Okay, so again that will help you in arriving at a diagnosis. Similarly, parathormone levels, they would be high in most of the cases except in cases of phosphopenic rickets where they can be inappropriately normal. And talking of alkaline phosphatase, they are in most of the cases, the alkaline phosphatase levels would be high in patients of rickets, but they can be normal in cases of renal tubular acidosis, or in cases of chronic kidney disease, or on the contrary, they can be low in cases of hypophosphatemia. Okay. So again, another thing is acidosis. We always check for acidosis in patients with calcium. For if there is presence of acidosis along with that, so always think about renal involvement, either in the form of renal tubular acidosis or in the form of chronic kidney. So how do you classify rickets? So the disorders, the same repetitions we have most commonly because of vitamin D deficiency. Then we can have vitamin D dependent rickets, which could be type 1 or type 2. You can have hypophosphatemic rickets. You can have rickets because of RTA. You can have because of renal failure, or you can have pseudohypoparathyroidism. So how do different biochemical markers differ between the different categories? Phosphate levels would be low, again, the repetition, low in most of the common causes of rickets, except in cases of either kidney involvement or pseudohypoparathyroidism. Parathormone axis is affected. So they would be normal in two conditions. Then talking about calcium levels, they will be obviously normal in all the cases except for hypophosphatemic rickets, where the serum phosphate levels would be normal. So this should make you think about these conditions. The parathormone level, because it's a compensation because of hypocalcemia, so it will be elevated in most of the conditions except in cases of, again, hypophosphatemic rickets. Coming to the next parameters, urinary calcium would be normal in all the cases, most of the cases, except in cases of RTA, distal RTA, the urinary calcium levels would be high. And talking about pH levels, so it will be normal in all the situations except for RTA and when there is kidney failure, CKD. Okay, so this is a chart to help you people come to your differentials. So how do you approach? So apart from checking for calcium and vitamin D levels, because they are in the common form and which require treatment, and you can always look for therapeutic response, then the second step should be checking for phosphorus. So if the phosphorus level high, next step should be check for creatinine for renal disorders. If the creatinine levels are high, then you have to go for parathormone. Whereas in the different direction, if the levels are low, you should check for blood gas analysis always, and you have to look for acidosis. If that is confirmed, if the person has acidosis, then you think of RDA. And if it's normal, then you have to check for calcium and parathormone levels. If the levels of normal parathormone, calcium and parathormone, remember here, both are normal. So that should make you think about hypophosphatemic, hereditary phosphopenic rickets. Or if the levels are low, but parathormone levels are high, so think about the activated form, that is calcitriol, because that will be useful in differentiating the type of vitamin D dependent rickets type 1 and 2. If the levels are low, that indicates vitamin D dependent rickets type 1. And if the levels are high, which is because of the problem at the level of receptors, so the levels of calcitriol would be high. So I think we'll go back.
So just to, while Dr. Aisha joins the panel, just a key message in endocrinology, always look at the investigations which are abnormal. Everybody who is hypoglycemic should have a ketone. If your ketone is not there, think of hyperinsulinism. Everybody who has rickets should have low phosphorus. If the phosphorus is high, you start thinking of a possibility of something unusual. So this will give you a clue to algorithm. So Vibha, you can now carry on.
Thank you, sir. So moving towards the next case, we have this 3-year-old boy who was diagnosed as rickets. So he was given 3 doses of 60,000 unit of vitamin D, but his parents were very much concerned about his bone pain and increased alkaline phosphatase level. Even though his calcium level was normal, so he went to another physician and who diagnosed it as a refractory rickets. So Dr. Nitin, what is your opinion in this case?
So this is 3-year boy. He has received 3 doses. As ma'am has already said that the best marker for the healing of rickets is we have to see X-ray and see the translucent line has developed or not. Because once we are giving vitamin D, bones are hungry, there will be more take up, so alkaline phosphatase can go high. So that will falsely give impression that everything is not normal. So we should rely on the correct investigation, that is X-ray. Okay.
So very correctly said. And as you all can see, we can definitely see a line of healing in the X-ray. So definitely it is not a refractive rickets. And it is a bone pain, and the increased alkaline phosphatase is a normal response to the treatment of vitamin this rickets. So the key message is, as I've already given, the bone pain and the alkaline phosphatase increases as vitamin D, and line of healing is the best marker to see the response. So moving toward the next case, we have this 4-year-old girl who was diagnosed with rickets. So she was given osteocal with 5 ml twice a day, but she showed no response. Even after 30 days, she showed no response, and the X-ray shows no line of healing. And again, she was diagnosed as refractory rickets. So Dr. Utkarsh, what is your opinion?
So again, in this case, we have to look whether we have treated the patient properly or not. When there is a nutritional deficiency, the patient requires both vitamin D and calcium. And calcium, if we are giving it as osteocalcium, it is containing very low amount of calcium and phosphorus. So we have to increase the dose of calcium in this case. And I don't see vitamin D had been supplemented or not in this case. So both have to be supplemented in the proper dose. Then only the response will come. And we should not label it as refractory ricket.
Definitely, sir. She was not supplemented with vitamin D, and the rickets is not treated with the calcium and phosphate only. And as we can all see in this case, the parental vitamin D is only given for the malabsorption. And in the most of the cases, we see if there is a vitamin D, some of the people also prescribe the iron calcitriol stat. So it should not be given. And this the key messages from this case is that it is not a refractory, it is just an improper treatment. So we have this very interesting case of 5-year-old girl who was diagnosed with rickets, but she was also having polyuria and growth failure. As his height was 88 centimeter at 5 years of age, when we did this blood test, we found mild acidosis, and there was this alkaline urine. So, being a first year in the endocrine, so I think it is definitely a case of distal RTA. So, I diagnosed it as a distal RTA. So, Dr. Aisha, do you agree with this diagnosis?
Students, we have a 5-year-old girl. Patients clinching, acidosis, filled, or there is something which go back and
Sure.
thing apart from, don't forget albumin, don't forget magnesium, that the next serum,
Yeah.
phosphate levels. Before embarking on a not so common diagnosis, always think of common things first. So if you go for phosphate levels, this is 29.
Yes, ma'am.
So that
Was
is
high.
elevated.
Yeah.
Phosphate levels are high. So now you should change your direction of thinking towards either renal involvement or parathyroid, PTH involvement, axis affection. So here we have creatinine, which is on the higher side. So actually this was a girl with CKD. So don't be misguided by the facts. Always check, because all these findings you can find in a child with CKD as well. So always check for serum phosphate levels also before labeling as RTA or something. Always check for serum creatinine levels, provided the phosphate levels are high. Always.
Thank you so much, ma'am. Moving to the next case, we have this 12-year-old girl who was referred to us with a bone pain and this multiple bony deformities. And when the parent showed us the X-ray, it showed multiple fractures in the X-ray. And she was diagnosed as osteogenesis imperfecta, as there was multiple fractures in the X-ray. And she also complained of polyuria and myopathy, and there was failure to thrive too. So, Dr. Nitin, what do you think? What we are dealing with here?
She is adolescent girl, and at the outset, if we are getting fractures and the growth failure, polyuria, then we should think that this is refractory rickets. So we should work up for refractory rickets. So in this case, phosphorus is low, creatinine is normal, pH is acidic. So acidic pH, so we will go through in this direction RTA, renal tubular acidosis. Then
Definitely,
most of
sir.
the time distal, because if we see urine pH, that is 7.4, that is alkaline, because 5.5, more than 5.5 urine pH is alkaline pH. So if blood is acidic and urine is alkaline, so this is there is problem. So distal in distal artery, there is a problem of secretion of acid into the tubule, and because of that, and because of acid, bones are eluting. So the problem is this.
One important point, if you look at Western textbooks, they say proximal RTA is a major cause of rickets, but that is early onset phosphorus deficiency. In India, distal RTA is diagnosed very late. That is why it presents to us with rickets and fractures. There they will diagnose with failure to thrive. So again, big message, late onset fractures, 100% distal RTA would be there in most cases. Very early onset, low phosphorus, think of proximal.
Thank you, sir. So moving towards the next case, we have this 14-year-old girl who came to us with this lower limb deformity, and he was diagnosed as a case of refractory rickets. So Dr. Utkarsh, what do you think about the diagnosis and how should we approach in this case?
So again, the approach will remain the same. We will first look at the phosphorus level of this child, and the phosphorus level in this case are low.
Yes.
So we will look at whether the blood gas is showing acidosis or not. And in this case, there is no acidosis. So we will look at the calcium and the parathormone levels, and they are normal in this case. So this is a case of hypophosphatemic rickets.
Definitely, sir. So what key messages would you like to give?
So very important message is that in hypophosphatemic rickets, the lower extremities are more involved. So if you look in a case and you find that the lower extremities are involved, you may think of this type of rickets.
Thank you so much, sir. So moving towards the next case, that's all.
What do you plan, Dr. Arpita? We have 10 minutes. So we'll finish off the calcium session then. So you discussed about rickets. Now we'll talk about a rarer form of hypercalcemia. Dr. Ayesha.
Okay, thank you, sir. So here we move on to another extreme, that is in excessive calcium hypercalcemia. So what are the manifestations? When do we suspect child is having hypercalcemia? So in the neonates, a newborn may manifest in the form of dehydration. So you may have a newborn who presents with dehydration. He may have a grown-up child and beyond neonatal period, you may have features of polyuria, a person who presents with polyuria and hypotonia, and also irritability and features of encephalopathy. So these are all, you can see in the neonatal periods, the findings are so non-specific, as in all the cases. Always suspect and think of hypercalcemia, but again, you have to think of the clinical condition first. A good history has no substitute, but because the clinical presentations may be varied and they may be very subtle. So always look for calcium as one of the basal. Glucose, always check for calcium level because they can go haywire in both the directions. So in children, they may present with abdominal pain, child who has hypercalcemia, abdominal moans. They can have hypertension, the blood pressure could be on the high side, and they may have intracranial or calcification, especially in the kidneys. So they may have these presentations and in children who have hypercalcemia, and they may also have bone disease because of deposition, abnormal deposition of the calcium at the wrong place. So how do you approach a child with hypercalcemia? So talking about the disorders first. So the more common disorders are calcium receptor defects, which might lead to hypercalcemia. You may have parathormone, opposite extreme, that is hyperparathyroidism. You can have Jensen's disease, which is a form of metaphyseal dysplasia. You may have hypophosphatasia granulomatous disease, which might lead to hypercalcemia. And the etiology might be, there is postulated that there is more conversion of 25 hydroxy calcitriol to the 125 dihydroxy vitamin D because of the increase in the activity of alpha-1 hydroxylase, which might lead to hypercalcemia. Or you can have vitamin D given high doses of vitamin D, which is again not a very uncommon scenario. So how do different biochemical markers they differ? So talking about hypercalcemia, as I said, the phosphate levels would be low in calcium receptor defects and hyperparathyroidism, whereas the phosphate levels would be high in hypophosphatasia, granulomatous disease, and vitamin D excess. In these situations, the phosphate levels would be high. Coming to another parameter, perith hormone. So the levels will be low because it's like negative feedback sort of thing. Calcium levels are high. So you expect perith hormone levels to be low in most of the situations, except again, you have exceptions, hyperparathyroidism, obviously, because that is the culprit itself, and also calcium receptor defect. You'll have high perith hormone levels. Talking about urinary calcium, because the calcium levels are high, so there will be hypercalciuria. So you are bound to get increased urinary calcium in most of the cases, except for calcium receptor defects. So these are, you can say, clinching or pointers, which might point to a specific and not so common diagnosis. What is not commonly seen. Talking about vitamin D levels, you will have normal in all the situations except in vitamin D excess. So this is one parameter which should make you think about vitamin D excess as the cause of hypercalcemia. And the calcitriol, so levels would be high because the vitamin D levels are more, so there is more conversion, except in cases of hypophosphatasia where you'll have low levels of calcium. So this is to help you guide and think about a particular diagnosis. So coming back to the perith hormone interpretation. So as I said, it has to be interpreted along with calcium and phosphate levels. So always think like okay. So coming to the perith hormone levels, if the levels are high, so this is a guide to help you again make a diagnosis. So levels are more than 20, think of parathyroid as the reason. So it could be because of hyperparathyroidism, whereas high calcium with low perith hormone levels, less than the value of 20, think of pathways independent of perith hormone, which is responsible for hypercalcemia. How to approach. So we talked about phosphate levels, we talked about magnesium and all levels while thinking of hypocalcemia. In a child who presents with hypercalcemia, first line should be perith hormone. You have to, it was coming later down in the flow chart as we talked about hypo, but hyperpara mein, you have to think about hypercalcemia mein, you always have to go for perith hormone levels because that will help you the next step, what should be the next step. So if the levels are 20, you have to check for vitamin D levels because it's not the reason. Why perith hormone levels are low, so that's not the reason. Go for vitamin D levels. If the vitamin D levels are high, obviously it's because of vitamin D excess. Whereas in conditions where it comes out to be normal, vitamin D levels 25 hydroxy, जो normally karate hain, so that comes out to be normal. So think about the 125, the activated part, calcitriol, go for its estimation. If the levels are high, think of granulomatous disorder, as I said, because it's because of the increased conversion of 25 to 125 hydroxy. So the levels of calcitriol would be high in such a situation. And obviously, you have to think of and you have to see the patient in toto. You have to look for clinical markers and the history of the patient always. And if the levels are normal, then hypophosphatasia could be the reason for having hypercalcemia. And we come to the different prongs when the levels of perith hormone are high. Obviously, it's because of perith hormones. You have to, next step should be check for fractional excretion of calcium. If the levels are high, more than 1%, it's because of hyperparathyroidism. But if the levels are less, the fractional excretion of calcium less than 1%, think of it. So this is how you approach. So just remember, in hypercalcemia, perith hormone is the first line of investigation which you always should order. So again, coming back to the cases.
Thank you, ma'am. So moving towards the next case of hypocalcemia, we have this 12-day girl who we got a reference from the NIC for this girl because she was having irritability and dehydration. Yeah, sure.
Generally, we see when there is hypercalcemia and high vitamin D levels, the infants and young children usually have very, very specific anorexia for milk. I have seen these children just refusing. As soon as you take a cup of milk or a katori of milk towards the mouth of the child, they just don't like to accept it. Is it seen in all types of hypercalcemia or only because of vitamin D deficiency? That was my question.
A very, very interesting point ma'am has raised. And this is basically the body itself knows what it doesn't want. So if you look at CA children, they will eat salt all the time. They will take salt from everywhere. If you talk about patients who have fructose intolerance, I saw they will never eat fructose they will eat other parts of the fruit, not that part. This is a very, very good observation, ma'am, that you have made. And we've also seen with somebody with hypercalcemia. Also, the body tends to avoid, like wheat intolerance, they also don't like to take wheat. So this is an automatic mechanism.
Okay. No. Okay. So she was having irritability and dehydration, and when her calcium level was measured, it was 18. Definitely hypercalcemia. So, Dr. Aisha, how should we approach in this case?
So we have a 12-day-old girl who presents with irritability, and we have hypercalcemia as, in the finding. So the next step should be, while investigating and approaching a case with hypercalcemia, as I said, should be estimation of PTH. Okay, so we went for PTH, and what did PTH level said? High,
120.
borderline.
120.
Okay, so the second step should be, you can see high or normal. So you should go for,
It was low, ma'am.
it was low. Can't see, I'm sorry, from here.
It was low, ma'am.
It
Urinary
was low.
calcium
So
creatinine
the
ratio
second step
was
should
low.
be check for urinary calcium. So secretion came out to be low. Okay, so
Yes.
that came out to be low. So you have to think of receptor defect. So this was perhaps a case of neonatal severe hyper calcium receptor defect, I should say.
Definitely, ma'am.
Calcium receptor.
And this is a very, very dangerous and missed condition. Often these children will be misdiagnosed as diarrhea, sepsis, failure to thrive. So they will come to you with dehydration predominantly. Pain and all, no, but neonate will complain. So check calcium. That is a very big method. Check calcium. And then this will require immediate management.
Ma'am, what key messages would you like to give?
As sir has already pointed very well, so you have to always check for urinary calcium and always check for calcium levels to begin with in any child who presents with non-specific symptoms, especially newborn.
Thank you, ma'am. So now we have a 2-year-old girl who was having a on and off abdominal pain, and she was brought to us by her parents. And when the USG was done, it showed nephrocalcinosis. And her serum calcium was 13.6, which definitely going towards the hypercalcemia. And her phosphate level was high, was normal for this 2-year-old girl. So, Dr. Nitin, what is your opinion in this case?
From this slide, calcium level is high, and in ultrasound nephrocalcinosis it's there, and phosphorus is not high. It is phosphorus is not low. So PTH, we'll do PTH obviously. PTH came low.
Definitely, sir.
So we are basically dealing with vitamin D problem, because both are going hand in hand. That is, calcium is also high and phosphorus is also. So the
And so 25 hydroxy was 200.
too high. It is up to 100. We consider normal, and it is 200. So over enthusiastic prescription of vitamin D or non-compliance, someone has taken more extra doses because of that.
Definitely, sir. Later on, when we asked, her parents said they have been given vitamin D sachet weekly, not weekly, every day.
Every day.
That's why this condition has raised. So definitely, this is a case of vitamin D toxication. So, what key messages would you like to give?
So we do phosphorus and calcium, and we'll see if both are high, then it is due to vitamin D.
Definitely.
Because vitamin D goes hand in hand, in low also, in high also.
The big message is that these children, the PTH is low. So the PTH does not conserve the urinary calcium excretion. So you will have more hypercalciuria. They will develop nephrocalcinosis earlier. So this is a big message. So whenever you see high vitamin D, get an ultrasound to check for nephrocalcinosis. And how will you treat Vibha quickly?
You have to give the saline diuresis and steroids. Yes, sir. So moving towards the next case, we have this 15-day girl, And we got a reference from the NIs. She was preterm, 28-week gestation, and she has hypercalcemia, and her phosphate level was low for this 15-day, and her PTH level was also low. So, Dr. Utkarsh, how should we approach this case?
So again, this is a case of hypercalcemia, and as we have looked at the parathormone levels, they are low. So we move towards the right side of the panel, and we look at the vitamin D levels. They are normal. So we do the calcitrol levels, and as the calcitrol levels are also normal in this case, this is the case of hypophosphatemia. So this was a preterm child put on total parenteral nutrition, so has not received phosphorus properly in this case.
Definitely, sir. Due to the low phosphorus content in the parental nutrition, this patient, the serum calcium has raised. So the hypophosphatemia is due to the total parental nutrition. So the key messages would be, if the PTH is low and we have high calcium, you should definitely exclude the hyperparathyroidism and consider low phosphorus in hypercalcemia. So moving towards the next case, we have this 4-day-old boy who was having multiple episodes of seizure, and his birth weight was 3.2 kg. And he has a very evident history of birth asphyxia, and his calcium was 18 and low phosphate for his age. So, and his PTH was also low. So, Dr. Aisha, how should we approach this case?
So again, here we have a newborn who presents with seizures because of hypercalcemia. And as you can see, going for parathormone as the first line, it comes out to be normal. Okay, so this is not very common. So you exclude at least hyperpara as the reason. And then you have to look for other pointers in the history and examination, which might give you a clue. So going by other, did we have any other biochemistry?
It was PTH was low, then we look for the calcium.
Calcitrol. Okay, so you look for calcitrol. You have the level of that.
Yes, calcitrol was 250.
That was 250. Vitamin D levels were normal. So the next would be, you have to look for granulomatous disease and
on the examination we found there was some purplish
Palpable.
palpable nodule.
This is a relatively uncommon condition seen with hypercalcemia seen in newborns. You always have to look for some clues and some findings in the examination. So this baby had palpable nodules. Actually, this was case of fat necrosis, not very commonly. And again, the catch was this baby had asphyxia.
Definitely.
These are more commonly seen in babies who are small, who are born small, and who have asphyxia as one of the reasons. You should always think about the level, the flow chart would remain the same. You'll always try and include parathormone. Right? So take home message would be here again, go for parathormone level and always suspect uncommon conditions, provided that common conditions have been excluded.
Thank you so much, ma'am.
I think thanks, Dr. Aisha, Dr. Utkarsh, and Dr. Nitin for a wonderful discussion. Dr. Vibha, Dr. Utkarsh, yeah.
I just wanted to say that
Yes. So as I said, in hyperparathyroidism, nephrocalcinosis will take time to develop, but if it's excessive vitamin D or PTH is low, PTH actually conserves urinary calcium. So in the absence of PTH, your urinary calcium becomes high. So we have seen within a couple of months, 6 weeks, 8 weeks also, nephrocalcinosis can develop. So we are very cautious if somebody has a high vitamin D. Yes, ma'am. Yes. Yeah. Yeah. So yeah. So ma'am, basically the axis, the placenta is a very good sieve as far as the vitamin D levels are concerned. So although there will be some reflection of maternal vitamin D levels, generally if the mother's vitamin D levels are very high, it will not really translate. It's the calcium which is actively transported from the mother, and the PTH axis is independent. So giving too much in the mother will not cause a problem. However, if mother's calcium are high, fetus's calcium becomes high and the PTH becomes low. So once the child is born, they will develop hypocalcemia, transient hypocalcemia. Like an infant of diabetes mother, sugars are high, baby sugars are high, insulin is high, glucose becomes low. If the mother's calcium is high, after some time they may develop hypocalcemia, which is transient. If mother's calcium is low, baby may develop transient hypercalcemia. We did not go into that because this was beyond the scope there, but this is a very, very important point, ma'am. Dr. Utkarsh.
In babies, we prescribe vitamin D drops which contain 400 IU, and we should check always what they are getting, because we had a case in which the baby received the drop which is the 60,000 IU 5 ml, that is 0.5 ml contains 6,000 IU, and the baby was taking 6,000 IU for many days, and then the baby developed all the symptoms of vitamin D toxicity. So we should always check what preparation they are taking, because
think I-
parents won't know. They were giving 0.5 ml.
The therapeutic index of vitamin D is very good. So it's very unlikely that you will develop hypercalcemia, but like these cases, or taking daily sachets, injectable preparations, these are the causes which cause hypercalcemia and toxicity. So I think we'll close the calcium session. Dr. Arpita, we can felicitate speakers.
Thank you, sir. Thank you, ma'am. Thank you for igniting our minds with wisdom and knowledge. I would again like to request our residents to please give away the mementos. Dr. Aisha Ahmed from Aligarh Muslim University. Dr. Utkarsh Bansal from Lucknow Academy of Pediatrics. And Dr. Nitin. Can we please have a hearty round of applause for all our speakers and panelists? The capacity to learn is a gift. The ability to learn is a skill, and willingness to learn is a choice. Honorable Vice Chancellor, sir, respected faculty members, speakers, panelists, teachers, seniors, delegates, and my dear colleagues, a very pleasant good afternoon to one and all. I once again take the pleasure to welcome you all to the 11th Practical Pediatric course being organized under the auspices of Department of Pediatrics, King George's Medical University, Grow Society, and the Med-E classes. The modules in this course include a combination of didactic lectures, case-based discussions, and practical exercises to ensure active participation of the delegates, and it aims to cover all the key areas of pediatric endocrinology, which includes glucose and calcium metabolism, electrolytes, growth, thyroid disorders, and puberty. The module was first implemented in Kanpur in 2012 by our eminent speaker, Dr. Anurag Bajpai, and is now being implemented in different parts of the country. I encourage you all to actively participate in these sessions and make the most of this unique opportunity to enhance your knowledge and skills. I wish you all a very productive and enjoyable learning experience. It is believed that the light of the lamp dispels the darkness, illuminating the path ahead, paving the way for success and prosperity. As we light the lamp, let us all take a moment to reflect on the importance of knowledge and wisdom in our lives. Let us remember the great scholars, the thinkers, and the leaders who have illuminated our paths and inspired us to be our best selves. I would now like to request Honorable Vice Chancellor, sir, and respected HOD, ma'am, to please light the lamp. I would also like to invite all the dignified guests on the stage, Dr. Madhuri Kulkarni, ma'am, Dr. Anurag Bajpai, sir, and Dr. Arpita, ma'am, to please accompany them.
शुभ्रवस्त्रावृता या वीणा वरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा
May this light remind us of the power of, okay, can we please have a huge round of applause? May this light remind us of the power of knowledge and the strength of human spirit. May it inspire us to continue to strive for excellence and make a positive difference in the world. Thank you, ma'am, and thank you, sir. On this auspicious occasion of Ambedkar Jayanti, I would now like to request Dr. Arpita ma'am to please pay tribute to Dr. B.R. Ambedkar and honor his legacy.
Today, as we all know, we are celebrating the birth anniversary of one of the most remarkable figures in the Indian history, Dr. B.R. Ambedkar. This day is celebrated as Ambedkar Jayanti across the country to honor his contribution towards the betterment of society. Dr. Ambedkar was a visionary, a social reformer, and a statesman. He was a chief architect of Indian Constitution and played a pivotal role in shaping modern India. He fought tirelessly for the rights of the marginalized sections of society, including Dalits, women, and the underprivileged. On this day, let us remember Dr. Ambedkar's vision of a just and equal society where every individual has the opportunity to thrive and reach their full potential. His message of social justice, equality, and freedom is more relevant today than ever before. We must strive to uphold his ideals and work towards building a more inclusive and equitable society. On this Ambedkar Jayanti, let us renew our commitment to creating a better future for ourselves and for our generations to come. I would now like to request Honorable Vice Chancellor Sir, Professor Madhuri Kulkarni ma'am, Professor Shelly Avasti ma'am, and Dr. Bajpayee sir to pay floral tribute to him.
Thank you, ma'am, and thank you, sir. Our respected HOD ma'am is a clinician with unmatchable proficiency, a teacher with extraordinary expertise in her subject who goes out of her way to help her students, and a benevolent and human person who will leave no stones unturned to help her patients. Throughout her distinguished career, our Honorable HOD ma'am has demonstrated an unwavering commitment to excellence and a tireless dedication to advancing the cause of education. Her charismatic personality, humility, and cordial nature is an inspiration for all of us at the department. It is my pleasure to welcome our esteemed head of the department, Professor Dr. Shelly Avasthi ma'am, to deliver the welcome address. Can we please have a huge round of applause for her?
Thank you very much, Dr. Nikita Diwan, for such lovely words. I don't know if I deserve them or not. Honorable Vice Chancellor, Lieutenant General Puri, Professor Madhuri Kulkarni, former head of department, Sion Hospital, Dr. Anurag Bajpai, Dr. Arpita, Dr. S.N. Singh, Dr. Alisha, my seniors, students, Dr. Pyali Bhattacharya, dignitaries, and IAP stalwarts present in this hall. It's indeed a pleasure to see that the legacy of pediatrics, which is growth and development, is being carried forward by the able hands of Arpita, who is in her growth, and she has a lot of growth potential. So I'm very happy to see that. And indeed, with all of you here, there's going to be a nice academic session. As you know, right from the fetus and thereafter, every step of growth and development involves endocrinology. It involves metabolism. Every time we see patients of endocrine disorders like type 1 diabetes, hypothyroidism, short stature, sex differentiation problems. And then we see a lot of metabolic disorders, as is being talked today, like calcium, magnesium, glucose. These come in day in and day out. And it was the right time that the subspecialty of pediatric endocrinology come up, because without a thorough training in pediatric endocrinology, you do not do justice to the newborns as well as to other constituencies of pediatric patients. Now, with Dr. Madhuri Kulkarni here, I go back to 1995 when I was a very young faculty, returned from US with epidemiology training. And madam called me to Sion Hospital. And I mean, that time I was so young. 3 days I gave non-stop training to all the faculty of BMC, that is Sion, Nair, and KGMU. And ma'am, now after so many years, 1995 and now it's 2023, I meet some of them quite senior. They say, ma'am, you taught me. I mean, it's really very humbling. Research methodology, 3 days non-stop in Sion Hospital. Single-handed, madam, she trusted me. She trusted me that time and we did it. And even now people come and say, Aapne padhaya. I don't know how I did it. If she asks me now, I will go with the team. In 1995, it was a one-man army. But remember, that time there were no PowerPoints. We did it through transparencies, as you would call them. And as I was seeing my stuff, those transparencies were there. And I tried converting them into PowerPoints. So that is about Dr. Madhuri Kulkarni. Our Vice Chancellor, General Puri, is actually a motivator and an inspirational personality. We learn so much from him every day. Every day when I meet him in some form, I don't meet him every day. I'm not that lucky. But whenever I meet him, I take back something. Today's learning lesson from Sir. And he's an avid listener, a person who respects all human beings and promotes everyone to their best capability. Dr. Anurag, I heard a lot about him. He's an AIMSonian. I know that. He's done his endocrinology from AIMS, and hats off to you. He holds pediatric endocrinology courses, and Arpita has participated in one such course for, I think, 1 year duration. The course is still ongoing. So with these few words, let me say that my research journey, fortunately or unfortunately, started with a project given by UP Science and Technology. And believe me, that time, way back, Dr. Anurag, the topic was growth hormone changes in cases of tuberculous basal meningitis. I don't know how I conceived it. I wrote it. I got funding. A girl got PhD. It was published. That time we did growth hormone estimations in the department. I would never allow anyone to do that now without close monitoring. But see, so many things happen, how you evolve. So be lucky. You all are very lucky that you have people to handhold you, to tell you how it should be done. It's not optimal that you begin the journey all alone and have catastrophes and learn by serendipity or by mistakes. So that is the advantage of being in an institution or with a group of people who can help you. So that was not ideal. It went through, the journey continued. All pediatric endocrine lecture came to me, whether it was type 1 diabetes, whether it was short stature, whether it was inborn errors, whether it was cortisol, name it, till NMC decided to reduce the number of lectures. Everything endocrine came to me. Even though I was going in the line of pulmonology and epidemiology, yet I did that till Arpita has come to help me. So with these few words, I'm indeed very pleased and happy to see the subspecialty of pediatric endocrinology grow under the guidance and support of our Honorable Vice Chancellor. And Dr. Madhuri Kulkarni could be here. It's really immense pleasure. Ma'am has come for a dissemination meeting we are having tomorrow as a part of pediatric pulmonology. But ma'am, thank you so much. She doesn't travel now. She said, "Hame mat bulao." But I said, "Ma'am, please come." I really hold you in tremendous respect. And way back in 1995, if someone could trust me. Thank you, ma'am. Thank you all.
Thank you so much, ma'am. Dr. Anurag Bajpai is one of the key speakers for today's CME. He is currently associated with Regency Hospital as a consultant in endocrinology. Apart from being a renowned clinician, Anurag sir is also an exemplary teacher and an academician par excellence. Dr. Anurag sir completed his MBBS and MD from AIIMS, New Delhi, and did a fellowship in pediatric endocrinology from Australia. He is also the General Secretary of Grow India, Regional Coordinator of the Disha program for increasing awareness about childhood obesity, founding secretary of Celiac Society Kanpur, and a member writing committee for ISAPE guidelines in type 1 diabetes management and childhood obesity. Throughout his career, Dr. Anurag sir has demonstrated a deep commitment to excellence and a passion for sharing his expertise with others. His dedication and commitment to helping others achieve their goals makes him a valuable asset to our community. With great pleasure, I would like to welcome our esteemed speaker, Dr. Anurag Bajpai, to the stage. Can we please have a huge round of applause for him?
Thanks a lot for the wonderful words of introduction. I would really thank Shelly ma'am for allowing us to conduct this program here. As we discussed, this has been done across the country, and it's a pleasure to be part with KGMU as well. Thanks a lot, Puri sir and Kulkarni ma'am, to give us kind words of introduction and kind words and overall encouragement, and Arpita also for doing all the hard work to make this possible on that. So why do we have this practical pediatric endocrinology courses? It goes down when I came back from Australia around 14, 15 years ago. I used to see patients who were coming at a very, very late stage for short stature with the complaints of diabetes, who were coming to be very sick, and a lot of these problems were getting missed. So we tried to see how we can improve the care on that. So we started thinking that the most important target would be the pediatricians who would need a more sensitization to pick it up at the right time, make the diagnosis and refer at the right time. The key concepts about pediatric endocrinology, people used to say that, okay, this is a rare disorder, this is a disorder which we don't see, very difficult to evaluate, very complicated to evaluate. So why do we really bother about that condition? So from there, we started doing a lot of programs. In fact, I would have done over 100 workshops across the country, 12 such full day programs and so many other programs. And then I realized it's going to be very difficult to keep on doing it continuously because you have to do other things as well. And in that perspective, we then gradually move on. Maybe around 7-8 years ago, we started putting up videos on the YouTube. And now we have got around 400 videos on each and every talk that you're seeing is already on the YouTube. So you don't need to make notes here, just think and you can go back to have a look at that YouTube channel, which will give us information. Then we thought that we need to go the next level. So we started with online courses, which include a combination of didactic lecture, resource material, books, which are available outside as well, along with on-site visits to get a good exposure. So we have got a full 2-year fellowship program, which Dr.
Arpita is continuing, and a lot of faculty from across the country are part of that. We have got programs for postgraduates, for pediatric fellows, for endocrinologists. All sorts of programs are there online, which you can easily access at your own time. We then went on and thought that, okay, people have learned the courses, but how do they apply? So we developed a mobile application which basically guides around 60 approach and 40 management pathways, which cover each and every aspect of management, including bone age assessment, DKA management, electrolyte management, which is available on the common stores. And we have validated already. Around 6 publications have come out from validation on DKA in terms of bone age, in terms of growth assessment. So based upon those inputs, it is giving us a value of around 96 to 98% accuracy in providing diagnosis as in terms of expert diagnosis. So that is something to make it easier. We are now going a level further to create virtual intelligent EMRs. Based upon the inputs that the physicians will give, it will make the likely diagnosis, suggested thing that we're doing in a validation process along with the nutritional plan. So this is something which are going on. The main aim of this is to ensure that across each and every part of the country, we are able to provide state-of-the-art validated care, which is based upon the latest recommendations. It's not that somebody living in a remote village would not have access to good care. So if you have connected clinics which go in a pyramidal fashion, we'll be able to achieve that goal. That will be the plan that we are thinking of. Once again, I have to thank the faculty who has come from different parts of the state. Dr. Ayesha, who has come from Aligarh. We have got Dr. Manisha, who's going to come up, I think, soon from Allahabad. We've got people, Dr. Lokesh is there, Dr. Utkarsh Bansal, Dr. Nitin, Dr. Vikrant, who are there as part of the faculty. For the entire organizing team, I thank again. And hopefully it will be interactive and you will have more interest in the field of pediatric endocrinology. You want to sensitize, that's the main thing. You can't learn everything in 6 hours, but it's more of sensitization, which the aim is. Thank you.
Thank you, sir. Our next guest, Professor Dr. Madhuri Kulkarni, is ex-professor and HOD, LTM General Hospital, Mumbai. At LTM Hospital, Dr. Kulkarni started the early intervention clinic for developmentally subnormal children in 1985, pediatric neurology clinic in 1992, and learning disability clinic in 1996. In a career spanning over several years, she has many presentations in both national and international conferences. For the past 15 years, Dr. Kulkarni has been a founder, trustee of Child Welfare Trust at Bhuj. She was also awarded the top 10 women of the city by the Junior Chamber International India Zone 11 Mumbai in 2009. It is a great honor to have such a dynamic lady with us today, and I request ma'am to please come up on the stage and deliver an address for us. Can we please have a huge round of applause for our guest?
Namaskar. Thank you so much for all those good words. I was wondering, where did you get them from? Respected Honorable Vice Chancellor, respected Professor and Head of the Department of Pediatrics, Dr. Shaili Avasti, Dr. Anurag, Dr. Arpita, distinguished pediatric endocrinologists from different parts of our country, and my dear friends, the postgraduates who are so enthusiastically attending this practical pediatric endocrinology course. It is indeed, I can't express, I don't have words to say how delighted I feel to come here this afternoon and sit on the first bench listening to the various aspects of endocrine problems in children. I feel the God has plan for everybody, and this must be the God's plan for me to come here. Otherwise, I would not have even dreamt of attending practical pediatric endocrinology course at age of 73. I was almost retiring from all the pediatric medical field, but I think I still need to learn more on endocrinology.
Thank you very much, Shaili, for inviting me here and giving me chance to address the postgraduates. I was also the Dean of Sion Medical College in the last year of my retirement, and I felt most enjoyable time that I had during my Dean's post. Of course, leave aside the pediatric professorship and HODship and lecturership. The most interesting and enjoyable period in the deanship was interacting with undergraduate and postgraduate students. I really felt at home because it was too much to take up administrative issues, and the worst thing was to take up and tackle the labor union issues. I don't want to even dream of them now. But this is such a great opportunity for me to be with you all, learning about pediatric endocrinology problems. I remember that during my chairmanship of IAP Growth, Development and Behavioral Pediatrics chapter, we had developed the modules on growth monitoring, developmental disorders, and behavioral pediatrics. And if I remember, I think we had conducted some growth monitoring workshop here a few years ago. So I'm very much attached to this institution right from when previous HOD, senior, even before, Dr. P.K. Mishra, yes. Dr. P.K. Mishra and myself, we used to be DNB examiners going to various places, and I have come here first time as DNB examiner way back, I think probably 1998 or so. And since then, I always enjoy coming to KGMC, and now it has become KGMU. And Shaili, I am extremely thankful to you for including me in this program. Thank you so much. And wish you all the best. All the postgraduates and the consultant pediatrics will definitely learn a lot from these very, very intricate but very interesting cases of pediatric endocrinology. And we have so many experts to give comments along with Dr. Anurag for enlightening all of us on these various issues. Thank you very much, and all the best for each and every one of you. Thank you.
Thank you so much, ma'am. It is our honor to introduce our chief guest for today, Honorable Vice Chancellor, Sir, Lieutenant General Bipin Puri. He retired from the Armed Forces Medical Services from the apex position of Director General. He has been a member of the Governing Council of the ICMR and NBE, and also the chairperson of the International Congress of Military Medicine. Under the formidable leadership of our esteemed Vice Chancellor, Sir, our institution has thrived, growing in stature and prestige, and earning a reputation as a center of academic excellence. It is my distinct pleasure to welcome our esteemed Vice Chancellor, Sir, to address the gathering. Can we please have a huge round of applause?
Professor Shelly Avasti, Head of Department of Pediatrics at KGMU, but I acknowledge more of Professor Shelly as my Dean Research of KGMU. Professor Anurag Bajpai, the brain behind this workshop, and Professor Madhuri Kulkarni, Dr. Arpita, faculty members who have come in for this pediatric endocrine course, friends, delegates who are here attending this, the PGs, plus I'm told there are as many private practitioners as well. I'm told there are about 70 people have registered offline and as many numbers online. So that's a fantastic number of people attending this workshop. And on behalf of the King George Medical University, I take great pleasure to welcoming each and every one of you this afternoon for this very interesting, very fascinating, um, and a very important facet of our academic information, which is integral to our training. And I think we cannot thank not only the Department of KGMU, which is actually hosting it, but more importantly, the Grow Society and the Med E classes. And thank you, Professor Anurag Bajpai, for doing whatever you are, doing it all over the country, and including us in your charter, we're very happy to. I'm very happy to see the program, the way it is been thought of, and the way it is being conceptualized. Of course, you have the entire spectrum of endocrine issues, but more importantly, the way you're doing it by case studies. Because when you do it by a case study, it becomes more, you connect a little better and you try and understand the nuances a little better. So I think that to me is very, very fascinating. Also, the fact that you covered most of the things, but I was just wondering a couple of things from the pediatric surgeon's perspective. Let me say this, that I'll talk of two or three things. One, of course, is disorders of sexual differentiation continues to be a very, very important thing that we keep getting into our outpatients. And sometimes they can really be a diagnostic conundrum. So that is one. The second is something which is becoming a pandemic-like situation in the West, but I'm sure I'll ask you to talk about it. Obesity in pediatrics is also catching up for whatever reasons. And friends, ladies and gentlemen, let me say this, and I say this to the young residents, the young pediatricians. You are the people who are going to actually treat them in the times to come, because morbid obesity in children is actually becoming a problem. And as much as it is in the adult setting, it is going to be a problem in children as well. So I also would talk about in pediatric practice, we do a fair amount of tumors, especially the adrenal tumors and neuroblastomas, etc., with huge amount of endocrine manifestations. Nishant would bear me out all that we keep doing from time to time. But I think when we look at on a larger perspective, I would want you'd also to take in a pediatric surgeon's perspective, because for us, this is very, very important. And indoctrinate these thoughts in the young pediatricians, I think would be as important. Once again, I congratulate Professor Anurag, the department, for organizing this very fascinating workshop, this meeting. I congratulate all of you for being here this afternoon. Congratulations and God bless.
Thank you, sir, for your words of wisdom. Your guidance and presence is a constant source of motivation for all of us. As a token of appreciation, we have prepared mementos for each of our speakers and panelists. These mementos are a symbol of our gratitude and recognition for the time and effort that you've invested in sharing your knowledge and experience with us. I would like to request the audience to please join me in congratulating and thanking Dr. Anurag Bajpai, who's the eminent speaker for today, as we present him with the memento. We would like to present the next memento to Dr. Madhuri Kulkarni. Can we please have a huge round of applause? We would also like to present a memento to our Honorable Vice Chancellor, sir. I would now like to request Arpita ma'am to please present the memento to Dr. Shelly Avasthi ma'am. We hope these mementos will serve as a lasting reminder of your time here, and we look forward to the possibility of working with you again in future. Concluding the inauguration, I would like to invite Dr. Arpita ma'am to please deliver the vote of thanks.
Respected Honorable Vice Chancellor, Sir, Professor Madhuri Kulkarni ma'am, our guest of honor, Professor Shelly Avasthi ma'am, Dean Research and HOD Pediatrics, Dr. Anurag Bajpayee, sir, Dr. Piyali Bhattacharya ma'am, Vice President Central IAP, Professor S.N. Singh, sir, esteemed faculty guests, colleagues, and dear participants. On behalf of the organizing committee, I would like to extend my heartfelt gratitude to all of you for attending this continued medical education event. It has been a great privilege and honor to have such an esteemed gathering of medical professionals from various fields and backgrounds. Firstly, I would like to express my heartfelt thanks to Honorable Vice Chancellor, Sir, for constantly guiding us to strive for better. My head of the department, Professor Shelly Avasthi ma'am, who has been instrumental in driving me to this enigmatic field of pediatric endocrinology. Without her support, this program would not have been possible. I would like to thank Dr. Anurag Bajpayee, sir, for being such an exemplary mentor and guide to me. I would like to express my sincere gratitude to all the keynote speakers who have generously shared their expertise and knowledge in their respective fields. Your valuable insights and innovative ideas have provided all of us with a deep understanding of the latest advancement in the field of pediatric endocrinology. I also want to express my gratitude to all the moderators, the panelists, and presenters who will contribute to the success of this event. Your passion, dedication, and hard work will definitely make this CME more informative and engaging for all the participants. I would like to thank our sponsors and exhibitors for their support and valuable contributions who have helped me to make this event a grand success. Your partnership is much appreciated. Lastly, I would like to acknowledge the tireless efforts of my organizing committee, my residents, my staff, who have worked hard to ensure the smooth execution of the CME. Without your dedication and teamwork, this event would not have been possible. Once again, thank you all for attending this event and for your active participation. We hope that the knowledge and insights which you will gain from this event will be valuable to your practice and research further on. Thank you so much. I would like to ask all the faculty members to come forward for a group photograph.
So we are running a bit late. How many of you are hungry? So do you want to have the electrolyte session before and then we break for lunch as it was planned? Dr. Arpita, what do you think? They are looking for lunch. Okay. Yeah. So we can have a so we can have a smaller break.
I request all of you to please go to room number 106 for the lunch, and we return by 2 p.m. for
Before that, 150.
we return by 1:50 p.m. for a third session. I would like to invite our next speaker, Dr. Thakur Vikrant Anand sir from Lucknow for the next session on electrolytes. The expert panelists for the sessions are Dr. Thakur Vikrant Anand, Dr. Nishant Verma sir, Additional Professor, Department of Pediatrics, KGMU, and Dr. Nitin Pandey sir.
It is indeed a pleasure to introduce Dr. Vikrant, who is very close to me and has been involved in so many programs related to pediatric endocrinology. Dr. Vikrant did his training under Dr. Raghupati, who is considered to be the grandfather of pediatric endocrinology in India. And since then, he has been working in the field of pediatric endocrinology and currently working as the head of department of Mayo Institute of Medical Sciences. So Dr. Vikrant will be talking about this aspect of electrolytes. And this is a very interesting and a wide array of disorders. So we'll try to keep it simple and use cases as a discussion. So over to you, Dr. Vikrant.
Thank you so much, sir. Thank you for the time. So thank you so much, sir. Thanks for the kind introduction. So today we are going to deal with a very important aspect of pediatric endocrinology, that is the electrolytes. As all of us know, when we think of electrolytes, we think of sodium, we think of potassium. When we think of calcium on one hand, we think of phosphorus on the other hand. So they go hand in hand with each other. As all of us know that most of the intracellular potassium, calcium, magnesium, phosphorus, they are intracellular ions, and sodium, chloride, bicarbonate, they are chiefly the extracellular ions. So first of all, we are going to take up sodium. So when we think of sodium, we always think of tonicity, and tonicity or osmolality is one of the most regulated phenomenon that is present in the human body. So whenever our body senses, there is an increase in tonicity. The very first, it is sensed by the osmotic sensors, and they lead to the production of antidiuretic hormone. So tonicity is directly related to antidiuretic hormone. And the second thing is volume. So volume is related to the RAS axis. So basically, we are going to learn the interplay of ADH, AVP, and RAS axis. So when we talk of sodium levels, it is not the absolute levels of sodium that are important in deciding the status of the electrolytes in the body. It is actually the free water. It is the free water excess that leads to hyponatremia. It is the free water deficit that leads to hypernatremia. So basically, there are two mechanisms. So whenever our osmoreceptors, they are going to sense that the body is having the tonicity has increased, the third mechanism is going to predominate, and that is leads to the secretion of antidiuretic hormone. So there will be gain of free water, and as a result, the tonicity will remain at a normal level. So one thing is very important to understand here, that mere lowering of the sodium level is not going to cause any harm until and unless there is increased secretion of ADH, whether it is appropriate or inappropriate. ADH has to be increased for hypotonia, for hyponatremia to persist. In a similar manner, for hypernatremia to persist, the main mechanism is free water. Okay. So whenever there is volume contraction, so the signals are being sent to the RAS axis, renin, angiotensin, aldosterone pathway, that they are going to work at the epithelial sodium channels at the cortical collecting duct. That is the main site where the whole of the sodium and potassium interaction is going to take place, and as a result going to affect the whole milieu as a whole. So it is going to lead to the gain of sodium ions, and as a result the potassium ions will be excluded. So if there is RAS excess, this is going to lead to hypernatremia. If there is RAS defect, and hypokalemia, if there is a RAS defect, so vice versa is going to happen. The opposite situation is going to predominate. There will be hyponatremia and there will be hyperkalemia. So for hyperkalemia to sustain, the most important thing is RAS defect. Then and only then, if we are going to put a lot of potassium into the body, the hyperkalemia, that is going to be transient, but that is not going to persist. For it to be persistent, there has to be defect in the RAS axis. So now the RAS axis, the RAS is activated. So it is leading to the increase in sodium. With the sodium, the water is being dragged into, so the body is going to be overhydrated. So a third player comes into play, that is known as the ANP, atrial natriuretic peptide. So the stress receptors of the heart, they are going to sense that the body is overloaded. So ANP will come into play. That is going to cause a lot of diuresis. That is going to cause a lot of natriuresis. So we never, the clinical implication is we never encounter in RAS excess states, we never encounter hypernatremia. We always an edema. These are never seen in chronic RAS excess states. Okay. So a few words about potassium. So the main mechanism, as we have already talked about, potassium, calcium, magnesium, and phosphorus are the chief intracellular ions. So if the body is going to lose one potassium, simultaneously it is going to lose calcium, it is going to lose magnesium, as Sir has already talked about this. So that the chief enzyme, the gateway, is the sodium potassium ATPase. This is the enzyme that is responsible for exclusion of 3 moles of sodium, along with gain of the 3 potassium ions are going to be pushed into the cell. Now the important thing is this ATPase is responsible for pushing the potassium into the cell. The clinical implication is whenever there is insulin deficiency, we come across diabetic ketoacidosis. When we treat diabetic ketoacidosis, it is the insulin that is going to lead to the hypokalemia. Similarly, in case of nutritional recovery syndrome, in malnutrition, or in severe cases of anorexia nervosa, whenever there is a recovery state, similarly, the insulin levels are going to increase and they are going to push this potassium into the cells. So these are responsible for hypokalemia. So we have to be very, very meticulous in the management of potassium before embarking upon the insulin treatment or before embarking upon extensive management, a very vigorous management for nutritional recovery. So a few words about serum sodium. It is not affected by diurnal variation. The serum sodium levels can be taken at any time of the day. The levels are pretty much constant, as opposed to the potassium levels. They are throughout all the ages. The levels are pretty much constant, 135 to 145. Anything less than 130 is to be worried about. Anything more than 150 again is to be worried about. But one caution before taking the samples of sodium: after doing severe exercise or after a vigorous seizure activity, you should not take it from the arm that was scissoring. So it is going to take about 30 minutes for the sodium levels to take normal. So the one message is, after severe extraneous exercise or after a seizure episode, do not take the sample immediately. At least wait for 30 minutes. So similarly, there are false values. So whenever we encounter hyponatremia, we have to look it into whether this is true hyponatremia or it is a pseudo hyponatremia. So that is possible in case of proteins, in case of lipids. They will lead to falsely low levels of sodium. So with the invention of iron cathodes, this problem has been minimized, but it's still with hyperglycemia. There is a water drag. It drags the water into the intravascular space and it leads to the decrease in the sodium levels. So we have to be very cautious while looking at the sodium levels in case of diabetic ketoacidosis. So always we have to correct the sodium level by 1.6 to 2 depending upon the situation which we are dealing with. So this we have already talked about. So again, a few words about serum potassium, again can be taken at any time of the day. But the caution is you do not have to squeeze the samples because it is basically an intracellular ion. So this this concept holds true not only for potassium, but also for phosphorus, but also for calcium, but also for magnesium. You do not have to squeeze the samples, no tourniquet, and the samples do not have to be made to stent. Immediately it has to be processed, because what is going to happen if there are a lot of leukocyte counts, if the platelets are increased, they are going to eat up the potassium and they are going to lead to lower values of potassium. Okay, one more thing, word of caution: the blood gas analyzers now we are using, they underestimate the potassium levels by 0.4 millimoles per liter. And okay, so this interplay of sodium and potassium is very important, and this is a 2x2 table that is very important to understand the different aspects. Okay, so we have already talked about, because of the presence of sodium potassium exchanger, if the sodium is up, the potassium has to go down. So this is RAS axis. If sodium is low because of ROS defect, the potassium has to go up. So this is in the case of ROS defect. If there is high sodium and there are high potassium, then this is a red herring, that your eyes should pop out of your head and you should think of this is something different taking place. So this is possible only in one situation, that is the Gordon syndrome. That is the sodium chloride symporter defect, and that is practically the only situation in which we have this rare combination. If there are low sodium with low potassium, think of diuretic use or tubulopathies. So hyponatremia, as we have already talked about, it is basically the excess of free water that is going to cause hyponatremia. So the very first thing, whenever we encounter a patient of hyponatremia, we have to look at whether it is pseudo hyponatremia or it is true hyponatremia. The next important thing is the volume status. So the volume status, sometimes it is very difficult to estimate the true volume deficit or volume status of a child. So if there is X, so it can be three ways. Either it could be euvolemic, it could be hypovolemic, or it could be hypervolemic. So hypervolemic situations are if you are having congestive cardiac failure, if you are having nephrotic syndrome, if you are having chronic liver disease, then there is going to be a third space lossing, and ultimately there will be the effective intravascular volume will decrease, and it is going to activate the RAS axis. So in this case, if you are going to do a urinary sodium, so apart from this, apart from the volume status, the next important thing comes is urine sodium levels. So for urine sodium levels, the dictum is if anybody is hyponatremic, his urine is going to have low sodium. If there is high sodium in the context of hyponatremia, we are dealing with sodium wasting through some renal pathway. It can be tubulopathies, or it could be some electrolyte, it could be some diuretic use. So in case of hyponatremia, because of excess of water in the cardiac overload state, we are going to have urine sodium less than 25. Now we talk about the euvolemic state. It is in fact the most common label diagnosis is syndrome of inappropriate secretion of antidiuretic hormone, SIADH. But basically, I would like to mention here, it is always the diagnosis of exclusion, because it is the, how does the cortisol affect this AVP pathway? This cortisol inhibits the CRH. This cortisol is going to inhibit the CRH, and as a result, this AVP is going to be decreased. If there is deficiency of cortisol, this AVP is going to be more. It is going to come more, and it is going to lead to some hypervolemic like condition. So that will be inappropriate to the situation, but it will always be high SIADH level. So always remember, before diagnosing SIADH, you have to rule out cortisol deficiency and you have to rule out thyroid deficiency. So hypothyroidism, to label any person as SIADH, they should be normal thyroid, he should have normal cortisol functions, and diuretic use should be ruled out. Then and only then you have to label the person as SIADH. So what is going to happen in SIADH? Again, contrary to the popular belief, the sodium is going to be high in the urine, so urinary sodium will be high. This is first situation where urinary sodium is going to be high in case of hyponatremia. Now we talk of sodium loss. So sodium loss can be in the form of the extrarenal losses, or it can be in the form of the renal losses. When we talk about extrarenal losses, we talk about sweating, excessive sweating, cystic fibrosis. When we talk about renal causes, it is basically the diuretic use or the tubulopathy, or it could be something, a defect of RAS. So in those cases, the urinary sodium is going to be more. So basically, we have got three things. The first thing is the volume. First thing, we have to confirm the diagnosis of hyponatremia. If it is true hyponatremia, look at the volume status. After looking at the volume status, you look at the urinary sodium levels. If it is less, diagnose accordingly, and then we will proceed. Okay. So if we talk in a nutshell, what is going to happen? It is the first, the fluid overload state like congestive cardiac failure, chronic liver disease, nephrotic syndrome, SIADH, diuretic, RAS. The first thing is the hydration status. In children, it is always very difficult to estimate the volume status. So the rule of thumb is the only thing, substance in the blood that goes according to the level of the blood flow is the serum uric acid. If the blood volume increases, the more of the serum uric acid is going to be excreted in the urine. It is going to have falsely low value. It is going to have low values of uric acid. If it is hypervolemia, it will be low uric acid. If it is hypovolemia, it will be higher uric acid. So uric acid less than 4, or I say less than 2, that is a pretty much important marker to distinguish exactly the hydration status of the body, apart from the other clinical things. So this uric acid, these are the two situations in which uric acid is going to be low. In all the other situations, because there is dehydration, so though it is going to be high. Okay, when we talk about the urinary sodium, we have already talked about any patient of hyponatremia has to have decreased urinary sodium levels except SIADH and tubulopathies. When we talk about potassium, it goes again hand in hand. That interplay we have already discussed about, and other is the hematocrit. Same rule applies for hematocrit. If the state is hypovolemic, that is going to increase the hematocrit. If it is hypervolemic, the hematocrit is going to fall down. Okay, so now the approach, this we have already talked about. So I think we are done with the sodium levels. Hyponatremia, we have talked about how to approach a case of hyponatremia. The same logic holds true for hypernatremia. If it has to be hypernatremia, the free water deficit has to be there. The free water that is present in the body, that has to go down. And the situation in which we most often encounter is the diabetes insipidus. So I think we are ready to take up the cases.
Take for the hypo. Volemia. If you have hypervolemia, you're dealing with cardiac failure, liver disease, or fluid overload. If it's euvolemic, always exclude the possibility of cortisol deficiency. If it's hypovolemia, you can be dealing with a RAS defect or a GI loss where urinary sodium will give you a clue. So the most important investigation is uric acid. Most important investigation in the setting is urinary sodium, which will classify. So now I think, Dhwani, you can start off with the cases and go from there. I'm really pleased to have Dr. Nishant, who has spared his time to come up for this session, along with Dr. Nitin Pandey, and we'll start with the cases.
Like to ask Dr. Nitin, is this worrisome? Is the sodium worrisome? Would you like to intervene here?
As we are seeing that blood sugar level is very high, so we have to correct for the blood sugar level. So before running the algorithm, we should always check the blood sugar, lipids, proteins. So the formula is that every 100 milligram per deciliter increase in the blood sugar will cause the change of 1.6 milli equivalent per liter of sodium. So 100 minus 700 minus 100 means 6. So every 6 into 1.6. So that is coming 9.6. So 9.6 plus 126, that is coming 135.6. So our corrected sodium is coming in the normal range. So we don't have to bother about that. That is normal. So the key message here is that we have to correct the sodium for the sugar level, and also lipids if they are high, and protein if they are high.
Thank you, sir. Moving on to the next case, we have a 1-week-old child who was 1-week-old boy who was brought with poor feeding lethargy. On investigation had sodium of 128 with potassium 3.6. So this question is for Dr. Nishan. Clinically, the child had no dehydration. So yeah, how would you like to approach this child?
Hello. Yeah, thank you, Dhwani. So as this child does not have dehydration, so it's a euvolemic hyponatremia. And as was pointed out by Dr. Vikrant, that we should not jump to a diagnosis of SIADH for all euvolemic hyponatremias. It is always that we should first rule out is it something like deficiency of thyroid or hypocortisolism, which can cause this euvolemic hyponatremia. So we would first investigate for these two conditions, and if they are normal, we may consider the diagnosis of SIADH.
Yes, so very rightly pointed out, on examination, this child had micropenis with bilateral descended testes, had ketotic hypoglycemia. In a euvolemic child, when you have hypoglycemia micropenis, you're thinking of an MPHD. cortisol
Is low.
cortisol and growth hormone levels were low in the setting of hypoglycemia.
Would like to add something here. When we talk about adrenal insufficiency, we often look at the potassium levels along with sodium. So that is going to be affected only if RAS is affected. So there is primary adrenal insufficiency, then sodium will be down, potassium will go up.
I think that's a very, very important message with Dr. Vikrant is saying that we say that, okay, potassium to normal hai, why are we thinking of adrenal insufficiency? That is for a adrenocortical insufficiency. But if you have a ACTH problem, remember ACTH does not control your renin axis. So if your ACTH is low, ACTH is not working, your potassium will be normal. So isolated hyponatremia in a child who is euvolemic can be central cortisol deficiency or very rarely a familial glucocorticoid deficiency. The difference between the two will be pigmentation. So these children will be non-pigmented. So of course, this for the same case we discussed for hypoglycemia, but again the same message, hyponatremia with hypoglycemia, think cortisol. That would be the message.
Next, we have a 14-year-old boy who was brought with drowsiness and a sodium of 116 at admission. He was euvolemic, had high urinary sodium and urine osmolarity of high urine osmolality. He was labeled as SIADH and was advised fluid restriction. So I would like to ask Dr. Vikrant, do you agree with this management here?
Before we go to Dr. Vikrant, anybody agrees with SIADH here? How many of you think this is SIADH? You can raise hand. There is a euvolemic hyponatremia. Euvolemic hyponatremia is SIADH. Dr. Vikrant, now over to you.
Now we are going to look for the cortisol levels. We are going to look for the thyroid hormone levels, and then we are going to decide whether it is. So first thing, with fluid status we have already talked about. Then we are going to look at the this pre-T4 was low, and the cortisol was also low. So this was probably a case of multiple pituitary hormone deficiency, which could have been missed and labeled as SIADH, and had we done fluid restriction in this case, it would have caused a catastrophic to happen.
And this is actually a real life case scenario because this was the case who was referred to us as SIADH and the patient crashed because they actually restricted fluids further. So again, the big message with Dr. Vikrant was saying, always measure cortisol and thyroid in anybody who has hyponatremia and is euvolemic. That will be the key scenario from there.
3-week-old child with failure to thrive had a sodium of 110 at admission. The child had only gained 100 grams weight in the since birth, was dehydrated clinically with an increased hematocrit. Urine sodium was high with a serum potassium level of 8.4. So I would like Dr. Nitin to take up this case.
Thanks, Dhoni. Remain in the previous slide, please.
Okay. So this was a 3-week-old child.
Please. So all the points, the first point is saying that there is failure to thrive. The second point is saying that there is dehydration, means hypovolemia. So, and the urine sodium is increased, and blood potassium level is more. So hyponatremia and hyperkalemia. So we have the case where failure to thrive, dehydrated baby with hyponatremia, hyperkalemia. So we will go to that limb, and in that, such low level of the sodium can be possible when there is combined cortisol and adrenal, both are deficient. So aldosterone, cortisol and aldosterone both are deficient. And as we are seeing the picture that the baby also has the DSD. So this is the case of 21 hydroxylase deficiency.
Yes, so 17 OHP level was done, and that was high.
I think the big message here is that if you have hyponatremia and hyperkalemia, there are two possibilities, renal versus adrenal. Especially if you have a dehydrated child, renal is out because renal causes dilutional hyponatremia. So now you have adrenal cause. And as Dr. Nitin really pointed out that if you have such low level of sodium, it cannot be because of an aldosterone problem. Because unless you have an associated cortisol deficiency, you will not have severe hyponatremia. So 110 and 8 or something like that, this picture is a combined glucoaminocorticoid. The most common cause at this age group will be CAH. Yeah.
Yes, another important thing that I skipped out was CAH may not present with any clinical features in male, like DSD will be seen only in female. So even in male, suspect CAH. Next case is a 6-month-old girl who was diagnosed as cystic fibrosis. She had failure to thrive with repeated chest infections. Sweat chloride level was high, 120. However, she had no history of steatorrhea. On investigation, she had hyponatremia with hyperkalemia. So, Dr. Nishant, do you agree with the diagnosis here?
Okay, so again, the message is you should not go with the pre-decided diagnosis. Always work up a case with your open mind. Why should a cystic fibrosis have hyperkalemia? So again, it's a big message here. If you have hyponatremia with hyperkalemia, go back to your algorithm and see what the algorithm is showing. It's probably something related to the, again, renin-angiotensin pathway, or it could be something like aldosterone resistance, because this child is having hyponatremia with hyperkalemia, which is a feature of aldosterone resistance. So child should be worked up for that. Her urine sodium should be checked, which again is high here, 120. And then we should test this child for the aldosterone levels, which in this child, the aldosterone
Very
levels are
high.
high, which means aldosterone is not working, although it levels are high. So it's probably a case of pseudo hypoaldosteronism, which this case PHA1. It's a genetic disorder which can have, again, recurrent chest infections as well. So it's a closed differential of cystic fibrosis.
Yeah, so these patients will be losing a lot of salt and their chest secretions will be very thick, just like cystic fibrosis. That's why they will have recurrent infection. So again, will cause more hyperkalemia, less hyponatremia. We talked about 3 situations, if you remember. Cortisol deficiency, mainly sodium is low, potassium is normal. Both defects, sodium is very low, potassium is high. If you have only aldosterone problem, potassium is very high, sodium is not that low. This will be an important thing.
Moving on to the next case, we have a 1-month-old boy who was brought with reduced poor feeding. He had a poor birth weight gain of 100 grams in 1 month. Sodium was 124 with hyperkalemia 6.8. 17 OHP level was normal. Cortisol levels were in the normal range. Both renin activity and aldosterone levels were very high. So, Dr. Vikrant, do you think we are looking at pseudo hypoaldosteronism again, or is there something else we need to rule out here?
The biochemical picture is that the patient hasn't gained much of weight. He is dehydrated. The potassium is sodium is 120.
Potassium is 6.8.
Potassium is low, and the 6.8 of course it is high. This is hyponatremia and hyperkalemia, and both of them I definitely we are going to have some problem like adrenal insufficiency or something like that. It may be congenital.
So very important point which Dhwani noticed, that you should always get a 17 OHP in a male child. They will have no clinical features. Female may have DSD, that was normal. Cortisol is also high, so there's no glucocorticoid deficiency per se. So this looks like pseudo hypoaldosteronism. But what is the big catch? What is the most common cause, I would say, of PHA at this age, Dr. Vikrant?
Obstruction, in fact, or urinary tract infection. That happens to be the most common cause of hyponatremia, most common cause of pseudo hypoaldosteronism, and that should probably be ruled out before embarking upon a diagnosis and stepping for lifelong treatment.
So, as very well pointed out, the child had obstruction on ultrasound with urine routine showing more than 100 WBC. So consider transient PHA in UTI, and this PHA improves with treatment.
So, Dr. Vikrant, you'll quickly go through hyponatremia. So the key message on hyponatremia is your most important thing is your volume status, your potassium status, and your urinary sodium. If your volume is less and potassium is high, you're mostly dealing with an adrenal problem. If your volume is more and urinary sodium is high, you're dealing with SIADS. These are the 2 most common causes from an endocrine perspective.
Quick words about hypernatremia. As we have talked in the context of hyponatremia, it is because of free water access. So same way the reciprocity exists here also, there is going to be a free water deficit in this case. So if there is free water deficit, it can be because of reduced intake. That may be in the case of neonates, some small children, or some mentally unstable children. There can be some problem with the adipsia, or it could be because of increased losses. So increased losses can be in the form of sweating and diarrhea, that is extrarenal losses, and it could be in the form of renal losses. So that there we have to talk about diabetes insipidus. So here again the catch is, if the urinary sodium is less, this is dehydration. If urinary sodium is more, it is going to be diabetes insipidus. Similarly, sodium overload, it can be because of endogenous hyperaldosteronism, or it could be exogenous load. But for hypernatremia to persist, the defect has to be exogenous. The defect has to be in the RAS axis. So then and only then it can persist. So in this case, sodium load, so it is the urinary sodium that is going to discriminate in the two states. In the first limb, the urinary sodium is going to be less. So if the urinary sodium is going to be less, we are having sodium losses extrarenal. If their serum sodium is more than 25 millimoles per liter, then we are probably going to have fluid overload. So the approaches, the first thing is salt load, mannitol, and diabetes. This you have to rule out, and then you have to look at the urine osmolality. So when as we have talked about, it is the tonicity that matters the most. If the tonicity increases, so the osmoreceptors are going to give the signals to the ADH. The ADH has to be released. So if this regulation is very tight, even if 1% or 2% increase in tonicity or osmolality, that is going to be a big boost for the antidiuretic hormone to release. So when the serum urine osmolality is more, as in this case, or suppose 146 serum sodium level is 146, we presume it to be around more than 300. So at more than 300 osmolality of blood, the maximum concentration of urine should take place. That is not happening in this case. Urine sodium is going down, and as a result, osmolality is going down. So any case, more than 200 serum osmolality, less than 600 urine osmolality, this is virtually diagnostic of diabetes insipidus. Now we have to do a vasopressin test to look for whether it is ADH deficiency or it is ADH resistance or the nephrogenic diabetes insipidus. If we give it 0.1 units per kilogram subcutaneously, if there is more than 50% increase in the urine osmolality at 2 hours or 4 hours, then it is virtually diagnostic of central diabetes insipidus. If it is less than that, then we are dealing with particular nephrogenic diabetes. So now if the urine sodium is more, that means one thing is urine osmolality is more than 600, maximum concentration ability is present in the body, ADH is sufficient for this. So then either it is either this is loss of sodium in the form of extrarenal losses, GI losses or sweating, or it could be sodium load. So that we are going to differentiate on the basis of the urinary sodium. So I think we are going.
I think the big message is that if you have a concentrated blood and you have a dilute urine, this is concentrated blood, dilute urine, this is diabetes insipidus. Dilute blood and concentrated urine is SIADH. So this is the context. So we are talking about low calcium and low PTH, or normal PTH will also be abnormal. Same thing here. If you have hypernatremia, your urine should be concentrated. That is what is very important. So I think we'll go forward on the cases.
So we have this 3-month-old girl with altered sensorium with sodium of 170 and a dilute urine in presence of hypernatremia. This child was advised a water deprivation test. Dr. Nitin, do you agree with this?
In the definition only, we have been told that if sodium is more than 145 or osmolality is more than 300 and urine osmolality is less than 300, that is already diagnosed case. So water deprivation will further increase the sodium level and we will harm the baby. So we don't have to do water deprivation test when it is already diagnosed.
So here on doing a water deprivation test, the child developed seizures.
Yeah, so that should not be done. Actually, we should have treated hypernatremia.
So this is actually a case report which was sent for review, in which they said that we did water deprivation test and developed seizures. So this is like a criminal act that you're doing water deprivation in already deprived child. So just to give a message that never ever think. The role of water deprivation is to dehydrate. He's already dehydrated. So that is the message, I think.
Moving on, we had a 14-day-old girl with failure to thrive who had a weight loss of 300 grams since birth. She was exclusively breastfed and had a sodium of 182 at presentation with a very high urine osmolality. So Dr. Nishant, how would you like to take up this case?
So first, looking at the child's weight, the baby has lost around 300 grams, which is more than 10% weight. And even on day by day 14, the child has not gained weight. So probably child is losing weight. It's an exclusively breastfed baby. So the thing which should first come to your mind is the baby fed properly? Maybe the child is not being fed properly. There's free water deficit, which is causing hypernatremia. That is the most plausible reason which we think and should first investigate on that line. Should take a proper feeding history, how long the mother is feeding, is the mother well trained about the feeding, and then we should go about other endocrinological evaluation in this.
Yes, so as sir has already explained, the urine osmolarity was high, sodium load in urine was high. This was a breast milk related hypernatremia.
So what is the cause, Dhwani, of breast milk related hypernatremia?
Underfeeding as well as in primigravida mother, they may have a concentrated urine, concentrated milk with
high sodium
So it's predominantly the underfeeding. It's a dehydration state basically. And the mothers don't recognize. They feel the child is sleeping. That's what they're very happy child is sleeping. And this is why the measurement of weight again at 14 days becomes important. So that's why many countries, they do a re-weight at 14 days. If the weight is not regained, they start thinking whether the feed is adequate or not. But this is one of the most catastrophic diagnoses. I'm sure you would have seen patients whose sodiums have gone up to 170, 180. And if you do not do urgent dialysis, they will die. This is a very, very dire situation on that case.
Can the reason be other way if there is decrease towards lactation failure, if there is decrease in lactose, so probably the sodium load is going to be raised?
Because the amount of breast milk is so little, how much sodium will you be able to give from there? Like we were the first ones who reported from AIMS on that, and I postulated that this was because of high breast milk sodium. But then the discussion comes out that even if the sodium is high, the volume is so less. So even if you give full salt, how much will you be able to give to the child in a way? So it's mainly because of dehydration. As you yourself said, the major determinant of serum sodium is the volume. It's not the sodium content. So it's mainly free water deficit, I would say.
Moving on to the next case, we have a 13-year-old boy with encephalitis, critically ill on mechanical ventilation, suddenly developed polyuria with urine output of 10 ml per kg per hour, had hypernatremia with a low urine osmolarity. And post AVP, the osmolarity improved to 200, so about 60% improvement in urine osmolarity. So, Dr. Vikrant, what are we dealing with here?
So probably we are dealing with the brain death associated diabetic insipidus. So this is a very ominous sign if a patient on ventilator. So this is presumed to be the brain death has occurred or it is impending brain death.
Yes, very well explained. Thank you, sir.
Because the AVP neurons are very widely separated. They are like 3-4 centimeters. If your complete DI has happened, then your whole hypothalamus is gone, which means that this patient is going to die and this becomes a big of a challenge. So I think that will be the message from there. So now I'll just quickly go through hypothalemia and then we'll have the cases discussion on that. So hypokalemia basically, because there's one more angle that it can be shifted to the cells. So if you have any situation in which somebody gets insulin, periodic paralysis or alkalosis, the potassium can go into the cells. That is one cause. Other could be a loss in the extrarenal side, which is largely through diarrhea, which is most common, in which the urinary potassium will be low. GI tract most commonly, rarely cystic fibrosis. And then you have urinary loss, in which you can have a high urinary potassium. This could be combined via a RAS-dependent process in which you will have hypertension or hyperaldosteronism and other scenarios, or rare disorders like Liddle syndrome or 11-hydroxylase deficiency, where you will have low aldosterone. And finally, you will have disorders in which you have got tubulopathies, which will have this problem, which is RAS independent. In this situation, you will have alkalosis or RTA, wherein you will have acidosis. So if you now look at hypokalemia, all you have to look at is first whether there is acidosis or alkalosis. Anybody with hypokalemia should have alkalosis. If you have acidosis, there is only two causes. It's diarrhea or renal tubular acidosis. There you go for urinary anion gap. If it's alkalosis, whether you have normal blood pressure or high blood pressure. If your blood pressure is high, you're dealing with a rare aldosterone excess. If your blood pressure is normal, then your Bartter's, Gitelman, tubulopathy, all those things come into the picture. So remember, acidosis, blood pressure. These two things will be sufficient to make a diagnosis from that perspective and identify that. So this is what I want to discuss. That importantly would be that if you have acidosis with hypokalemia, there are only two causes, RTA and diarrhea. So the most important investigation, as I said, most important investigation in hypocalcemia is phosphorus. Most important investigation in hypoglycemia is ketone. The most important investigation in a setting of hypokalemia is pH. That will give you the diagnosis. And magnesium also, anybody with refractory hypokalemia do get a magnesium level. That becomes important in blood pressure. So if you exclude the common causes and blood gas shows acidosis, do a urinary anion gap. If it's positive, it is RTA. If it's negative, it's GI loss. If there is alkalosis, look at blood pressure, and then you identify Bartter syndrome, Gentleman syndrome, and then you have got these rare causes which are there. So we'll run through the cases to go to the algorithm. So mainly to look at blood gas, blood pressure, and then go forward. You will get the diagnosis. So I think you can go now from there.
So we have this 2-month-old boy with hypokalemia, with metabolic acidosis, bicarb of 40 and base deficit of 16. Anion gap was normal anion gap. So how do we decide whether it is diarrhea or RTA, Dr. Nitin?
As sir has already told that we have to see the urinary anion gap in this case. So if urinary anion gap is negative, then it will be diarrhea. If it is positive, then it will be RTA.
Yes, so the urine anion gap was negative here.
Yeah. So this is the case of diarrhea, not RTA. The key message: RTA and diarrhea, in both cases, there will be acidosis and low potassium. So urinary anion gap will decide that what we are dealing with.
Moving on to the next case. A 3-month-old girl with failure to thrive had hypokalemia. She had a weight gain of 700 grams in 3 months period. She had metabolic alkalosis with a bicarb of 33 and normotensive BP record for age. So Dr. Nishant, how would you like to proceed here?
Now here we are dealing with the second subset of cases where you have alkalosis with hypokalemia, which is the more common setting. So in alkalosis with hypokalemia and normotensive, you need to check the urine calcium for these babies. This could be Gentleman or Bartter syndrome. If there is hypercalciuria or nephrocalcinosis in this child, it is probably a case of Bartter syndrome vis-a-vis a Gentleman.
Yes, so very well pointed out. Thank you. Moving on to the next case, we had an 8-year-old boy who was presented with early puberty. He had a height of 134 centimeter with pubic hair stage 4, had metabolic alkalosis with hypokalemia and a urine chloride of 100, and had BP on the higher side for age and height. So Dr. Vikrant, how would you like to proceed in this
So
case?
now we are dealing with the case of 8-year-old boy who has got a pretty good height. So he has probably landed into precocious puberty. Here the pubic hair is a stage 4. So I would first of all like to know the status of testicular volume, whether testes are present, testes are absent, their volume is commensurate with the pubertal status. So
Yes,
I
so this
think
child had bilateral cryptorchidism.
bilateral cryptorchidism. So probably we are dealing with a XX disorder. So it could be in these circumstances alkalosis with hypertension. So I think this is something like 11 hydroxylase deficiency, in which we are dealing with androgen excess that is leading to a pretty male-like appearance, and as a result aldosterone is low in 11 hydroxylase deficiency, but it is the penultimate metabolites like deoxycortisol, they are causing this hypertension to occur, and they are probably acting on the RAS axis and leading to hyperkalemia and a hyponatremia. Like
this was a very, very interesting patient, actually came from Afghanistan. He was reared as male, and apparently the karyotype was mentioned as XY also there. But when the child came to us, he had no palpable gonads. He had all the development, bones were fused and very, very short. And then, of course, when we did the ultrasound, there was a uterus which was present. So this is a very unusual scenario. So remember, when you talk about CAH, the most common we talk about is 21, where you have deficiency of both glucocorticoid and mineralocorticoid. So salt wasting with virilization. That is the most common scenario. But then if you talk about the next scenario of what Dr. Vikrant is saying, 11 hydroxylase, here you have got virilization with hypertension. So this is the second scenario. The third scenario is 17 hydroxylase deficiency, where you will have under virilization, you will have XY DSD with hypertension. So, and the fourth final scenario is 3 beta HSD, in which you will have DSD in both with salt wasting. So here what we're talking about is hypokalemia, means aldosterone excess. But this aldosterone excess is because of precursors. Because this child is actually producing too much androgens, this girl has actually become a boy. If you talk in a very crude fashion, which is not appropriate, I would say this is a XX DSD, in the sense that there is a 11 hydroxylase deficiency. So I think that was a very, very interesting case, an important case that you pointed out on that. So I think we will close the session at that. So Dr. Arpita, we can felicitate the chairpersons and the.
Thank you for the very motivating and inspiring session, sir. I would now like to request our residents to please give away the mementos to the panelists. Dr. Thakur Vikrant Anand, sir. Can we please have a resounding round of applause for all our panelists? Dr. Nishant Verma, sir. And Dr. Nitin Pandey, sir. Continuing with the next session on growth, please join me in welcoming our next speaker, Dr. Anurag Bajpai, sir. And the expert panelists for this session are Dr. Arpita Briguvanshi, Associate Professor, Department of Pediatrics, KGMU, Dr. Piali Bhattacharya, ma'am, Vice President, Central IAP, and Dr. Ajay Srivastav, sir.
Growth disorders are something which are very common, and this is something which differentiates children from adults in terms of pediatric practice. And I'm really honored to have Dr. Piali, Dr. Ajay, and Dr. Arpita as the panelists for this. This is an extremely interesting topic. So we'll start off initially with a basic discussion. So this is a very common presentation that we see as pediatricians. We have a 12-year-old girl whose height is 132, weight is 20 kgs. Now what to do? Now remember that growth failure is common. Around 1 in 40 children will have a height which is below the third centile. Let's put it in a very simple fashion. 80% of this will be physiological. Now, as a pediatrician, 80% of what you see is either TDGP or familial, and 20% or 10 to 20% will have a pathological cause. Now, the big question is what really is physiology and what is pathology? And you don't want to do too much workup in these cases of physiological causes while you don't want to miss the pathology. That's the basic message that I'll try to do to this perspective. Now, if you talk about growth failure, broadly speaking, this is physiological, where you have constitutional delay and familial. Then you have pathological causes. The pathology could be in the growth plate. So this is the primary problem. So your growth plate is not growing. Either the child is SGA, or there is a syndromic cause, or there is a skeletal dysplasia. And then you have a secondary cause in which you have either a nutritional cause or an endocrine cause. So these are the major classifications. So questions are, is it really short stature? The next question is, if it is short stature, is it physiological or pathological? Next, is it primary or secondary? And finally, if it is nutritional versus endocrine. Now, if you want to answer about the question about whether it is pathological or whether it is significant, as the severity of growth failure goes up, the chances of pathology go up. So what we found is that if your height is below -3 standard deviation score, the likelihood of having a pathology is around 80%. If your height standard deviation score is between -2 to -3, it's around 40%. Less than -2 is only 2.5%. So if you have somebody who is below -3, don't wait anymore, do a workup. -2 to -3, you can follow up. Less than -2, there is no need of workup. That is what the recommendations would be. So more than -2, you can say, okay, green light, you can go. -2 to -3 is caution. And if it is less than -3, this is an urgent evaluation which is there. Now, what really is -3 standard deviation score? That will be somewhere around 0.1 percentile. So 1 in 1000, that is what I'm talking about. While third percentile will be like 1 in 33 individuals. So the chance of having -3 standard deviation score is 30 times less. So it's not just it's like Richter scale. You don't talk about SBS simply that, okay, 2 and 3 are same. 2 and 3 is huge difference in terms of their severity. So if you see like this, that if you look at which chart to follow, studies have clearly shown that IAP charts are superior to the WHO charts in terms of not identifying unnecessary cases. We have shown that if you use the WHO chart, you will be labeling a lot of children as pathological, while you will be labeling a lot of children short as well. While IAP will have lesser number of children whom you are identifying, and they are more likely to be having a disease. So choose IAP charts. That's what I would recommend very clearly. So if you have this child who is very short, you would need definite evaluation. If you have a child who is just below the line, maybe you can follow up. So if you have a child, you follow up, and in the next 6 months, if the child is not growing, you would say you need evaluation. So very short and not growing. But do you think this child who is just in that line requires evaluation or not? He is just in the normal range, 10th percentile. Parents are very, very concerned. Yes, no? I said no. But remember, there is also a story as to what has been happening over time. So this child was not growing at all for the last 2 years. So if the child is crossing 2 or more percentile lines between 2 years and puberty, that also is very significant. So there are 3 situations: very short, short and growing, short and not growing at all. And this not growing at all may be the most serious condition. They may have craniopharyngioma for all you know. They may have hypothyroidism or whatever, but this is an important pathology to identify. Next question is it physiological or pathological? To answer that question, you have to look at 3 things. What is the status of the growth chart? What is the status of puberty? And what is the status of bone age? And only then you can say it is physiological or pathological. So when we talk about growth chart, you look at 3 things. The first thing is, what is the absolute status compared to the population? Is the child short for the population or not? For that, you can use either percentile or you can use standard deviation score. The next question is the child short for the family or not? Now, for this, you can use the target height. We all know how to calculate target height. Parents' height divided by 2 at 6.5 for boys, subtract 6.5 for girls, and then plus minus 8 centimeters or 1.5 standard deviation score for the range. This we'll talk a bit later as well. So this will give you whether the child is short for the family or not. Once you have said, okay, the child is really short, the next question is it nutritional or endocrine? For this, height, age, and weightage will give you a picture. So a child who has a predominant effect on the weight, his weightage is more affected, is likely to be which form? Nutritional cause of growth failure. While if your height is more affected and weight is preserved, this will be an endocrine pattern. So if your weightage is less, you think of celiac, renal tubular acidosis, infections, other scenarios. Otherwise, you start thinking of endocrine. And we'll use cases to illustrate this as well. So as we were discussing, that we have developed a growth interpreter which allows accurate interpretation of growth as part of our mobile application, which is available. Now, what about puberty? So often we don't tend to assess puberty well. All you need to remember in girls is 2 stages which are very, very important for growth. Stage 2. So stage 2 is papilla elevation. And remember, from here, growth spurt will happen. From here, the girl will grow around 20 centimeters from stage 2 to final height. So all you have to do is to approximate your thumb and finger and palpate for it. Why? Because lipomastia is very common. A lot of obese girls comes to us with precocious puberty who actually have fat. So you palpate, and if there is a tissue there, that is significant, stage 2. The second stage I'll be worried about is the stage 4, which basically means that you are very close to menarche. From stage 4 to menarche is around 8 to 10 centimeters, not more than that. And once you have a menarche, the growth is 5 to 8 centimeters. So if a girl comes to you with a height of 130 centimeters at stage 2, she will reach around 150. Stage 4 around 140. Menarche around 135. So this is how you can prognosticate in a very simple fashion. This much pubertal assessment you should be able to assess from that perspective. What about boys? The most important thing to look at is the testicular volume. So if the testicular volume goes beyond 4 ml, this is the time your spurt will start, but the massive growth will happen when it is testicular volume of 10 ml. So if you have a short boy with a testicular volume of 4 ml, wait. If it's 10 ml, say, okay, next 6 months is crucial. If he grows, it's okay. Otherwise, I'll have an issue. If it is already adult or 15 ml, 20 ml, you are already late. The happening of cracking of voice is equivalent to menarche. So that is also a sign you can take in that regard. The third thing is bone age assessment. And often most people don't do a bone age assessment. If you send to the radiologist, they will say there is bone age is 4 to 18 years. There is no evidence of fracture or rickets. You will get lots of report, but you won't get an accurate estimation of bone age. So problem is you need to understand that maturation happens from proximal to distal, and the fusion happens from distal to proximal. So if you want to assess bone age, this is the most important area you would like to focus. The carpal bones. Anybody has a different idea other than the endocrinologist? The least important areas are actually the carpal bones because there's huge variability there. So the most important bones are these short bones, the phalanges, where you will be able to identify a better idea for bone age. So typically the distal part are more important. Carpals are mainly for infancy, early age group, you can get some idea. And radius and ulna more for fusion. So this is not going to give you much pictures, and girls have higher estrogen. So they will tend to have more advanced bone age, definitely. The most important thing is to compare the size of epiphysis to metaphysis. So this is the epiphysis and this is the metaphysis. If the epiphysis is very, very small compared to the metaphysis, you have around 4 to 6, 7 years. It becomes equal by around 8 to 10 years. Beyond 10 years, it becomes bigger, caps by around 12 to 14 years. And that's how you make a diagnosis of bone age. And this is very simplistic. We have a whole 1-hour lecture, which is there on the YouTube. So you can go and have a look at that on bone age assessment, which becomes easy to assess. So this is what you need to full hand. Half the time they will cut the fingers. These are the most important. So ask them to get the full hand. Finger should be spread and there should be a good exposure. Now this is a very simplified way. For younger children, you can go for carpal bones, but that is up to 2 years. You don't need much bone age assessment by 2 years. For most cases between 3 to 12 years, it is the epiphysis and metaphysis difference, which I was saying, whether it is smaller, equal, capping or fusing, that becomes important. And fusion is usually large bones. So this is a simplistic way of doing the bone age assessment. There are complicated methods like GP method, Tanner-Whitehouse, which are there, which endocrinologists use for more precise assessments, but they require time and often they are not available. We also have a bone expert which provides automated tools, but again, it's a costly affair. So we have developed a novel way of assessing bone age, which has been validated against the standard ways of bone age assessment, in which all you have to do is to compare the 5 sites, basically. We found the most important is the middle finger, the middle phalanx, the proximal phalanx, the thumb, radius and ulna. And these 5 sites will be able to judge by around 2 to 3 minutes with a good level of accuracy. So it's part of our app and it's been validated as well. So now as I said, you have to look at 3 things: growth chart, puberty, and bone age. That will tell you whether it is physiological or pathological. Next question is it primary or is it secondary? So for that, look at the faces, examine the face well, look at the body proportion, and you will say whether there's skeletal dysplasia or not. You won't miss it. The final question is nutritional versus endocrine. And for that, again, as I said, if your weight is more affected, this is nutritional. That means it could be celiac, cystic fibrosis, tuberculosis, malabsorption, infection, any of those. If you have a predominant effect of the height, you are dealing with an endocrine cause in that regards. And we have shown that if your BMI SBS is less than -1, this is a more objective measure. It will be more like a nutritional cause rather than an endocrine cause from that perspective. So now what test to do? So the basic test I said for physiological is growth chart, puberty and bone age. For primary, it's facies and body proportion. For SG, of course, birth weight will give you a clue. For Turner's, get karyotype. So every short girl, if the basic cause is excluded, do a karyotype. That's a big message that we're giving. You look at genetics then, skeletal survey, ALT, creatinine, and TTG, and blood gas. Now, whether you do blood gas for everybody, we have shown that if somebody is more than 3 years and he does not have any features of RTA, you don't need to do a blood gas. So less than 3 years blood gas is essential. After that, only if you have rickets, polyuria, other symptoms. Fecal calprotectin for IBD generally beyond 10 years of age is what is recommended by most of the guidelines. Now, thyroid profile, everybody, we have shown that you can have whatever pattern, thyroid you should not miss, but growth hormone testing only after you have worked up for every cause. It's not recommended in a routine fashion. So all investigations include CBC, ALT, creatinine, TTG, I think is also important along with thyroid profile. If needed, you can do karyotype in girls, blood gas below 3 years, and calprotectin about 10 years. This is the summary of what you want to do in terms of workup from that regards. Now, growth hormone IGF-1 only when you have final diagnosis. Remember, growth hormone level is affected by large number of things. The other thing to remember is growth hormone is a pulsatile hormone. So if you want to waste money, a basal growth hormone, otherwise never recommend basal growth hormone. We have got hundreds of patients who come to us, growth hormone 0.1 hai, isko growth hormone chalu kariye. So this is not the case. This is classically just that it's a pulsatile hormone. Basal level has no value. So you need to do a cautiously done stimulation test, ideally under the care of a pediatric endocrinologist, because you have to look at cortisol axis, thyroid axis. Sometimes you may have to do priming in a prepubertal child. So it's a complicated issue. So then only growth hormone stimulation test should be done. We often get results of IGF-1 and IGF-BP3, which are markers of growth hormone action. Remember, they depend upon the nutritional status. So malnourished, IGF-1 level will be low. You have to interpret that. Less than 5 years, IGF-1 is not reliable. So you have to be cautious in assessing those tests as well in that regard. So what is the final approach? This is our algorithm, which we have validated, and this is going to cut a lot of cost of not doing too much investigations. The first question, is the child short? Height SDS above -2, nothing to be done. Next question, child is short, is he short for the family? To answer that question, you go for corrected height SDS. If the child is short for the family, then evaluate, otherwise it is familial, you follow up. Next question, is the child short for bone age? If the child is not short for bone age, this is constitutional delay of puberty and growth, follow up. So your 80% cases will come in the first 3 paragraphs. Child is either not short for the population, not short for the family, not short for the bone age, nothing to worry. But if everything has been done, then you go for systemic screening, which we already discussed, the various investigations, including the liver, kidney, TTG, thyroid. If all that is normal, follow up for 6 months. And if the growth velocity is less, look for syndromic features, look for body proportion, then do a karyotype. So don't do karyotype right at the beginning. You can do, but you're increasing the cost unnecessarily. So if all the basic workup is normal, then go for that. If of course there are features of Turner's, you can do karyotype right away. After that, you look at growth hormone stimulation, diagnose GHD, and IGF-1. I'm not a big fan because there are a lot of issues, and for IGF-1, it's a screening test. So this algorithm has been shown to be cost effective and precise and accurate in identifying the cause of growth failure. And we'll see how this algorithm works. So this is the study which we published. And very simplistically, all you have to enter is the height, weight, mother's height, father's height. You will get exact diagnosis. And we are making it even simpler by incorporating bone age and puberty also. In that, it will give you accurate diagnosis as well. And there was 99% concordance in this scenario. So I'm really honored to have Dr. Piali and Dr. Arpita and Dr. Ajay. We'll start with the cases.
Yes. Okay. So we have this 12-year-old girl whose height was 132 centimeters and weight was 28 kg. Her father's height was 164 centimeters and mother's height was 151 centimeter. And when we So this question is for you, Dr. Arpita. And when we plotted her height and weight on the growth chart, we found out that both height and weight is below the third centile.
What do you think?
So this child is short for the population as such, but we need to know the genetic potential of this child, and we need to calculate the mid-parental height first. So audience, please help me out here. What will be the mid-parental height and the target height in this child?
This is not going.
So mother plus father's height
So
divided by 2.
mid-parental height is 151 centimeters.
Okay. Okay. So the mid-parental height is 151 and the target height is between 145 to 157. So if we plot that target height and we trace it backwards, this height of the child falls within the genetic potential of this child. So this child is small for the population as such, but not short for the genetic potential according to the family. So this child seems to be having familial short stature. Also, one thing more we need to consider here, we need to calculate the weightage and the height age. So if we calculate the weightage,
It is 9, ma'am. Weightage and height age both is 9 years.
okay, so both are corroborating with each other, which further establishes our diagnosis as familial short stature. But we definitely need to monitor the height of the child and follow up this child with the height velocity.
So, and when we followed the child for 6 months,
Okay, so the child has gained about
7 centimeter per year.
3.5 centimeter in 6 months, which comes out to be 7 centimeters per year. And if we plot it against the height velocity chart, it falls at the 50th centile, which
Right,
is
ma'am.
normal for the
Definitely.
child. Further, we need to just monitor the child and observe the child. No need for any active treatment in this child.
Thank you very much, ma'am. As this was the case of familial short stature, we do not require any further evaluation. So moving towards the next case, we have this 13-year-old boy whose height was 135 centimeter and weight was 30 kg. His father's height was 169 centimeter and mother had 156 centimeter. So Dr. Piali, this case is for you, ma'am. And when we plotted her height and weight on the growth chart, we found out that both height and weight was falling below the third percentile. And his bone age was delayed. So what would you like to say in this case? How should we proceed?
Hello. So when you talk about this child, the first thing which I would have wanted to know was the bone age. And
Yes.
The bone age seems to be all right as you've charted over there. And if we had previous heights, we could have done a potential comparison of how much growth potential is there and how the child is growing. When you say the standard deviations, then between 2 and 2.5 or say moderate delay, we would rather go for a CDPA rather than endocrine cause. So the further assessment, if you ask, would be like Dr. Anurag already said, we would like to do a blood count. We'd like to do for the renal, the liver, and so there, of course, we would like to do the CBCs. We would like to do the SGPTs, and of course, if we can, then the albumins as well. And then the creatinine is also a very good indicator. And then the TSH, TTGs, of course, the sodium, potassium. The whole morning we've been doing sodium and potassium, so that too. And these would give us a clear indicator whether any system is involved. So basal GH, you say 0.1. But why was the basal GH done at all?
Definitely, ma'am. This is the question why it was done. It shouldn't be done, right?
Yeah. So number one is that it should not be done. And if you say what message goes with this, you do a stimulation also, and you get a peak of this. So the stimulation should have been done priorly to find out.
Yes, ma'am. It was
And-
done, and the growth hormone levels was 6.2, which is low if we take the cutoff of 7 nanogram per ml.
Okay. So fine. So did you do a priming?
No, ma'am. This is the most important thing that I have missed during assessing this case, that I have missed priming, because if this is the cause that in the growth hormone stimulation, the level comes so low.
I think the big message here is that this child is just below the growth chart.
Correct.
If you look at GHD, the child will be much shorter. This is just below the child chart. So 99% would actually be in a scenario of a CDGP picture rather than a growth hormone deficiency. So here you should not have done a growth hormone testing. If at all done, it should have been after priming. That is the big message which Dr. Piali was saying. So we are talking about physiological cases, largely 3 cases we talked about: familial, CDGP, as well as the third case was in the scenario of the one who was SGA with cash down growth. So this children will keep on growing normally. So if you have a child who is short for the population, short for the family, but if you look at the yellow dot, not short for the bone age, this is CDGP. That will be the message, I think, very importantly, which was being given.
Thank you so much, sir. Thank you so much, ma'am. So moving towards the next case, we have this 15-month-old girl whose birth weight was 4 kg, and her mid-parental height was 150 centimeter, and she was referred to as she was not gaining weight. So she was diagnosed as renal tubular acidosis. So this question is for you, Dr. Ajay. Now let me.
Here we see that birth weight is quite good. The basic thing first, while evaluating any growth case, we have to come to the basic thing, that is plotting on growth chart. So at birth, both weight and length, both are above 95th percentile, and over the time, it is crossing percentiles, coming to about 25th percentile. So it can be a cause of concern, so we have to evaluate. But when there are tests like RFT, LFT, CBC, all are normal. Best access is well, it's also, you can say, is normal. Then further evaluation, this was diagnosed as RTA.
Yes.
Only on this point, this is not good, because even for this is very mild acidosis, and this requires further evaluation. So we would like to go further for exploring further history, please.
But Vibha, the parents were very concerned, and the pediatrician was concerned that you have crossed 2 or more percentile lines.
Yes, but at the same time, if we know that this 4,000 gram, we would like to know that IDM, that diabetic. If it was diabetic mother, then initially it will be that slow down, catch down growth. No.
So if you remember what I said very carefully was, I said between the ages of 2 years and puberty.
Yeah.
In the first 2 years, you may have catch up and catch down. Carry on. Let me see, you can carry on.
So in first 2 years, the changeover period is 2 years. We have to take that.
So definitely the history of diabetes in the mother is important. So we cannot just judge on the basis that the patient is not gaining weight, because this is the normal trend that that the patient will follow in the IDM babies.
So this child was actually supposed to be short because parents were short. He was accidentally born large because he was infant or diabetic mother.
That depends on so many environmental factors, no?
Yes.
Like maternal nutrition or different metabolic factors.
Yeah.
So adult height is determined by genetics.
Yeah.
So we have to keep in mind both of these.
So as we said that this switch from environment to genetics happens by 2 years. So you may catch up or catch down. So don't unnecessarily work up in the first 2 years. That's the message.
Thank you so much, sir. So in the next case, we have this 10-year-old old girl who was referred to us as a short stature, and she was diagnosed as even the growth hormone deficient condition. So, Dr. Arpita, this question is for you. So, ma'am, if such kind of patient with short stature, so what kind of evaluation should we go for?
Okay. So definitely this girl is height is below the 3rd centile, but first we need to plot the weight age and the height age. In this
Definitely, ma'am.
case, the weight age seems to be more affected than the height age, as shown in the growth chart. The blue line is the weight age is more affected than the height age. So accordingly, as explained by Anurag sir, when weight age is more affected than the height age, nutritional cause should be our first differential. However, in this case, the TTG was found to be okay, is in the normal range, and even the initial investigations to rule out chronic diseases were normal, and even the karyotype was normal. Here in this case, IGF levels were done, which is just a screening test for growth hormone deficiency. It is not a diagnostic tool, and it has its own limitation. Same is true for the basal growth hormone assay, because growth hormone is secreted in a pulsatile fashion, and it also has a diurnal variation. So a single basal growth hormone assay has no value.
So this
it
pattern
actually-
clearly doesn't fit into a GHD diagnosis. And I've said IGF-1 depends upon nutrition. So if you have malnutrition, your IGF-1 will be low.
Right. So definitely, ma'am, due to the low basal GH1, based on a single reading and low IGF-1, this patient was diagnosed as growth hormone deficiency and was referred to us for growth hormone therapy.
And I think total IgA levels were not done in this case, which should have been done upfront with the
Yes,
IgA
ma'am.
TTG.
And when we evaluated further in our OPD, we found out that there was an IgA deficiency. The IgA levels were undetectable.
Right. So it led to the false interpretation of what IgA TTG.
Definitely.
So in this child, the child should have been ideally be subjected to endoscopy, and duodenal biopsy should have been taken to establish a diagnosis of celiac disease, which will show Willis A2.
So when the gluten-free diet was prescribed to the patient, and she showed dramatic response in her height and weight. So definitely this was a case of celiac disease, not the growth hormone deficiency. So thank you very much, ma'am. So consider nutritional pattern if their weight is more affected, and IgA deficiency is common if weight is more affected, and so because this test is IgA based.
So 10% patients with celiac have IgA deficiency and TTG is IgA deficiency.
So moving towards the next case, we have this 8-year-old boy who have a height of just 100 centimeter, and his weight was 18 kg. He was diagnosed as celiac disease, and he was referred to us. So Dr. Piali, how would you like to proceed to this case?
So what is the growth? So you pointed out the growth chart. So in the growth chart, you can significantly see that the height is more affected than the weight. So, and what were these TTG levels? Why was he diagnosed as this thing? Okay, 32, that's slightly higher. So what else was done? Only a single TTG would not have helped. So even, so you say that even if the gluten-free diet, there was no growth in the child. So was a biopsy done in this case?
It showed normal. There was no any abnormal.
So then this was misdiagnosed as a celiac disease. Not done.
Yeah. So we are actually seeing a big circle. Earlier, people were missing celiac. Now, everybody with a slightly high TTG is diagnosed as celiac. So this was referred as celiac without any biopsy. So I think that's the point that you're making, Dr. Piali.
Yeah. So sole TTG doesn't help.
Yeah.
We go ahead with the other pointers like a biopsy to prove that it is a thing. So as Dr. Anurag had pointed it out, this is the difference between a nutritional versus an endocrine etiology. You know, you can see in the nutritional part that the weight is significantly affected, whereas in the endocrine part, you can see the height is significantly affected. So this is a pointer, whether it is an endocrine or whether it is a nutritional disorder.
So, ma'am, in this case, the height is more affected than the.
Yes. So we are not thinking about a nutritional thing in this case. Etiology is something else. So further workup would actually prove what it is.
When we did the biopsy, it came out to be normal.
Correct. So if the biopsy is normal, then we must think that it is not a celiac disease, 100% proof that it is not celiac. Then what is it? So then we go for other endocrine disorders. and we go for a GH simulation test. Okay, fine. What did you find in that?
When the peak GH level was just 1 to 2 grams.
Okay, anything else was done other than this?
And then with this low GH level, we further moved ahead and we ordered the MRI head.
So was there a finding in the MRI head? So there goes your diagnosis.
So again, the big message is that this is a short and plump child. The most important thing to look at in a short child is the weight, not the height. If your weight is less, that is nutritional. If your weight is more, this is endocrine. That is the big message. So I think this will be a very important point, Dr. Piali, regarding TTG. How do we interpret?
Yeah. So if you're doing a TTG, and you're finding that it is, see, the normal values that the cutoffs we take is usually greater than 20. So if you're doing a TTG test and with a negative IgA, so you can have a normal one. If it is, you simply exclude the diagnosis of celiac. And then you have a low, you go for a GI referral. Don't rest till you get a proper diagnosis in this case. Then if it is 1 to 10 times the upper limit, you do a biopsy. A biopsy again, you do a MASH. This is 0 or 1, you get a celiac excluded. If it is 2 or 3, you think of a celiac again. Above 10 times, then an EMA antibody, and that would be a clincher as well. If it is a negative, go for biopsy. If it is a positive, it is a definitely celiac disease.
Definitely, ma'am. And any key messages would you like to give? Yes.
As Dr. Anurag has already said, the practice points will be that growth monitoring is very, very essential. There are 3 things, as Dr. Anurag has said: the chart, the bone age, and of course, if you have any other pointers towards the weight and the height, which one is affected more, that would tell us whether it is an endocrine problem or whether it is a nutritional problem. And the practice point is never diagnose a celiac without a biopsy.
Definitely. So thank you very much, ma'am. So moving towards the next case, we have this 6-year-old boy who had a height of 90 centimeter, and he was referred to as a case of nutritional rickets. As you can see, the boy has lower limb deformities, and he has received multiple doses of vitamin D, and his X-ray was also suggestive of rickets. And when we did the electrolyte profile, we found that calcium was normal, phosphate was also in the normal range, alkaline phosphate was normal, the calcium, but the potassium was slightly the lower side. So, Dr. Ajay, what is your opinion in this?
This boy is definitely having faltering in stature, and clinically looking like clear-cut nutritional rickets. Previous slide, please.
Yes.
So classically looking like rickets, but when you have given multiple doses of vitamin D, so this is coming out to be some refractory rickets or resistant rickets. And in case of any refractory rickets, you have to give the alternate diagnosis. The most common origin is from renal tubular origin. Okay, so it should be now investigated on that point. So next slide.
For the evaluation.
Yeah. So you found acidosis is there. Base access is not so much. Anion gap is normal. Urine anion gap is positive. So next. Urine pH is 6.8. Urine to blood CO2 difference -10. Okay. So you see, it's tubular acidosis. Now anion gap, normal anion gap acidosis is most likely of that origin. Now urine pH is 6.8. If it is less than 5.5, then we can think of it as proximal. So this is more likely in favor of distal tubular acidosis. Another point is that difference. Urine to blood CO2 difference, if it is negative, this is again in favor of distal. And urine anion gap is positive, this is also in favor of distal. So this is fits in distal renal tubular acidosis, and that scan shows patchy, you can say nephrocalcinosis. So it is it is distal RTA and should be managed accordingly. So in the previous case, that was it was misdiagnosed at RTA without any definite evidence, and in this case we are missing RTA. So once there is a refractory rickets, you have to think in this line, and it is very important, and it can be managed. If it managed in time, it gives very good results.
Very rightly said. Thank you very much, sir. So moving towards the next case, and while diagnosing the RTA, potassium level is very important. It has to
Potassium level is very important because in distal tubule, H plus ion is secreted in exchange for low potassium. If it's not there, bicarbonate is going to pass. So there is low potassium for that, and this is also very suggestive.
Yes. So now we have our next case. We have this 14-year-old girl who was referred to us for this short stature, and as we can see, she has this webbing of neck. So Dr. Arpita, she came with all these reports like normal CBC, LFT, RFT, heart profile, and even ETG. All were normal. So how should we deal with this patient?
So as we know, we have ruled out the chronic diseases by getting the basic investigations done, and the phenotype shows the webbing of neck. Any child, any girl presenting with short stature, a karyotype is a must. So in this case, a karyotype with 50 cell lines should be done to further.
And ma'am, what other clinical pointers should we look for?
So we can see the brachymetacarpia, wide carrying angle, widely spaced shield-like chest. So and FSH is high in these children with Turner syndrome. Also, there are associated cardiac and urinary problems. So we should be routinely subjecting these children to echo and USG-KUB to see for the associations.
Definitely, ma'am. As you have rightly said, the karyotype is must in every girl with the short stature, and even if the girl has all these stigmata signs, very specific of the Turner, like webbing of neck, brachymetacarpia, wide carrying angle, wide space nipple, so we should definitely go for the karyotype. Thank you, ma'am.
That is another big message that why karyotype is essential is the bi-cell line in gonadoblastoma,
Yes.
which we'll talk about later on. Yeah.
So we have our next case of this 5-year-old boy whose birth weight he was SJ by birth, and he came to us for failure to thrive, and his development was normal, and he gained of height just 90 centimeter with weight of 10 kg. When we plotted his height and weight against the growth chart, we found out that his height was much below than the 3rd percentile, and his weight was also below the 3rd percentile. So, Dr. Piali, how should we proceed in this case?
See, this case is an SGA case already. And for this case, I would like to follow up, because when we see these cases, they catch up by the age of 2 years mostly. But there are a few, which will continue to grow till the age of 8 years or so. 70% will catch up by, say, 2 years, but then 90% almost will catch up by the age of 8 years. So for these children, you've drawn up this thing, a middle line, which says the normal growth. So if they are tall and the weight becomes a little on the plumper side and they become tall, that is rather unhealthy, because these children are now predisposed to metabolic syndromes. But however, if there is slow growth, if the puberty comes a little early, and if the height is a little lesser, then relative to those who are growing tall, these children turn out to be healthier. And as I've said, you've already depicted in the bar diagram that the most catch up is till the age of 2 years, and thereafter too, they will grow. So this child, I would definitely like to follow up and see what his height and growth velocity is. So the velocity will guide us as to whether we need to do any further testing or whether we don't need to do any testing.
The other big thing is puberty also, because often these children have an early puberty. So SGA will be short and they will have early puberty, then you don't have any time to work. So look at puberty, bone age, as you have discussed very nicely. So if you have a child who is not growing by 2 or 4 or maximum 5, 6 and very short, start thinking of some intervention. And growth hormone therapy has been shown to be quite effective, even if your growth hormone levels are normal.
So thank you, ma'am. So we have this next case of 10-year-old girl who was referred to us for short stature, and we can see there were lower limb deformity, and all the screening tests were normal. So, Dr. Ajay, how should we proceed in this case?
So this case clearly looks like short stature, and when all parameters are normal, the basic thing we have missed is anthropometry. You have to get the upper segment, lower segment ratio. If it's upper segment is larger and lower segment is less, 1.5:1, this is again abnormal, and it points to some skeletal dysgenesis factors, maybe achondroplasia or that sort of thing. And if upper segment, lower segment ratio is normally 1:1 relatively, and if lower segment would be higher, then it is other endocrine causes. So in this case, USLS ratio is 1.5:1. So we can think of some skeletal dysplasia. So it may be due to mutation. There are many things like fibroblast, growth factor, receptor abnormality, or parathyroid type receptor abnormalities. So this type of thing. So in the initial algorithm, if you point out that the first question, whether it's short stature or not, then the second, whether it is physiological or pathological. When it is pathological, then it was clearly, if you go through the algorithm, it will not be very difficult to reach on this diagnosis in first round. Okay, and you will prevent the unnecessary investigations required.
I think that was the key message that we are trying to give, is that although there are so many causes of short stature, if you go by methodological one, the way Dr. Piali, Dr. Arpita and Dr. Ajay has also summarized very nicely, you would need minimal investigations and you will get less confused. If you get 100 investigations, 4 or 5 will be abnormal, because that's a normal variation which happens. So do investigations only once you have looked at the growth chart, puberty and bone age. That is the 3 fundamental thing. And then the next you can add the upper segment, lower segment ratio and the birth weight. This will be very important. So I think we have discussed a lot about growth. We will quickly go through about obesity. And obesity again is an important diagnosis that we are seeing. So again in obesity, it's a common finding, but 98% of children who are obese do not have a pathological cause. They are all physiological. If you have a short child with obesity, if a child has developmental delay, if they are abnormal facies, that will be the pathological cause. Otherwise, it will be a physiological cause. So obesity, as I discussed, physiological, 98%, normal growth, normal puberty, normal development, normal vision. So if that, nothing much to be done for etiology, what you have to work up is mainly in terms of complications. Now, pathological could be genetic, which is very early onset, 4S. Soon, severe, syndromic, and segregating. Very early, very severe, family history, and you have some syndromic feature, go for genetic causes like hyperphagia, visual abnormality, pubertal abnormalities. Hypothalamic causes and drugs, so steroids, valproate, these are the common drugs which cause obesity. And endocrine causes only if you have a growth or pubertal delay. Do not do unnecessary endocrine workup except hypothyroidism. We have found hypothyroidism even in children who have got less normal height also, which we'll discuss. So we have shown that you have to do thyroid also in everybody, which is not a big deal to do from that perspective. So this is our algorithm which we have developed. It says if you fit obesity criteria, no workup is required. If yes, and the child is below 5 years and the BMI standard deviation score is above 3. Now, a lot of people use weight for height. I think Dr. Lokesh was talking about weight for height ratio also. So that also above 3 SDS will be a good criteria. Think about a possibility of whether genetic study is required. Early onset severe obesity. If it's less than +3 SDS, if you have syndromic features like developmental problem, vision problem, dysmorphism, then you can go for genetic studies. You can go for either methylation study, the features of Prader-Willi syndrome are there, or you can go for NGS. Now the targeted panels are there, which we get the diagnosis quickly. If, however, they are not there and the height is short, go for an endocrine workup. If height is normal, no need for workup, go for complication screening, which is basically a glucose tolerance test, SGPT, and lipid profile. These are the three most important things to go. So look at the age, facial features, development, puberty, dysmorphism, vision. This will give you the diagnosis on that. And based on this, we have developed an algorithmic interpreter for obesity, which has again been found to be highly effective in identifying the cause. And see, 92% cases, even in our pediatric endocrine clinic, were nutritional. So it's not very common to have a lot of pathological obesity. It's mainly nutritional. So we'll take on the cases, Vibha.
Thank you, sir. We have this 12-year-old boy who was referred to us for the evaluation of obesity, as his height was 160 centimeter and his weight was 70 kg. His TSH was slightly high in the range of 7.91, and he was advised thyroxine for that, as he was diagnosed as hypothyroidism in this case. So, Dr. Arpita, do you agree with the treatment here?
Okay, so this is a 12-year-old boy with obesity with a good height. The height is 160 centimeters. It is not compromised. And the TSH is slightly elevated, 7.91. So it is the other way around actually. The obesity is causing the TSH elevation because obesity triggers the hypothalamic pituitary axis, causing the TSH to be elevated, whereas the thyroid remains normal. The thyroid functions remain normal. So it is actually the effect of obesity which is causing the TSH elevation. In this simple weight loss in this child, if suggested, will lead to normalization of these the TSH value, and no further treatment will be required.
Thank you, ma'am. So we are moving towards the next case. We have this 12-year-old girl, and her height was 130 centimeter, and she had a weight of 58 kg at 12 years. All the normal treating tests were done by the treating physician, and she was reassured, as this is just a nutritional obesity, but she was continuously gaining weight. So her parents brought this girl to us. So, ma'am, how should we proceed in this case?
So you see, this is a 12-year-old, definitely short and definitely overweight. So when we talk about an obese child with a short height, automatically our brain gets trained to think of an endocrine disorder. So had it been an obese child, but a tall child, we would have thought of some exogenous cause. However, in this case, we would definitely want to investigate further. And I would like to know what was her thyroid profile.
Yes, sir. And the thyroid profile was in a normal range.
So I would like to do something more in this child. That means it is not a hypothyroid. Oh, that photograph. Definitely. What was the cortisol?
Definitely, ma'am. And we did the overnight dexamethasone suppression test, and the cortisol level was not suppressed in this case.
This is very high, 154 is very, very high. This is a Cushing's rather than anything else. So reassurance about only the nutritional part would never do in this child. This child is an endocrine versus a nutritional one. So the message goes that whenever it is an obese child and it is a short child or a plump child, we think of endocrine causes.
Definitely, ma'am. Thank you very much. So moving towards the next case, we have this 3-year-old girl who was referred to us as she was gaining rapid weight gain. Her height was 84 centimeter and she had a weight of 26 kg at 3 years of age. And she had hypophagia since birth. She never had satiety. Her cortisol, thyroid profile, calcium, PTH, everything was normal. And even her vision, her normal development, and she had no history of recurrent infection. So, Dr. Ajay,
Yeah.
how should we proceed?
3-year baby, and this is grossly increased weight. That 3-year 26 kg obesity. So just focus on the algorithm. Okay, so it's obesity. That then comes to age. Age is 3 years. We come to the left part of this algorithm. If 3 years and it's more than 3 SDS, that's so we have to go for genetic study. In fact, before going for this endocrine assay, we could have think that this is syndromic. No, severe hyperphagia since birth, less than 3 years, with this much of weight gain. So genetic study should be planned. So genetic study, though most of the disease found, they are rare. So leptin deficiency is also very rare. But when you find it, you can at least treat. Okay, now you can have some treatment, whether the patient can afford it or not, that's a different thing. But now the patient will be saved from many other interventions which are not required. So again, the basic, my take home message is just follow the algorithm and do the best that you can.
Thank you very much, sir.
Thanks a lot, Dr. Piali, Dr. Arpita, Dr. Ajay, and Dr. Vibha for this wonderful discussion. It was very succinct and focused on key aspects of growth issues. We can have the felicitation of the faculty.
Thank you, sir, and thank you, ma'am. I would like to request our residents to please give away the mementos to Dr. Piali and Dr. Ajay, sir. Please give them a well-earned round of enthusiastic applause. I would now like to invite our next speaker, Dr. Manisha Maurya from Motilal Nehru Medical College, Prayagraj, for the next session on thyroid disorders. The expert panelists for the next session are Dr. Manisha ma'am, Dr. Shiv Madan sir from KGMU Lucknow, and Dr. Lokesh Sharma sir from Medanta Lucknow.
You can talk from here.
Yes. So very good afternoon. I am Dr. Manisha, from professor in Ambulant Medical College. I have done my MD from this department only, from KGMU. So I am very happy to be back here and with all of us. Today I will be speaking about the most commonly encountered endocrine disorder in our pediatric practice, that is thyroid disorders. So हमको सब लोग बहुत ज्यादा हम लोग ये ट्रीट भी करते हैं, तो मुझे लगता है कि आप लोग बहुत इंटरैक्टिव भी रहेंगे. तो let us go one by one. Now, if we see the hypothalamic pituitary thyroid axis, from hypothalamus, thyrotropin releasing hormone is produced, which go and stimulate the pituitary to produce thyroid stimulating hormone. And then this thyroid stimulating hormone go and act on the thyroid gland, which produces thyroxine, T4 and T3. The large amount of hormone which is secreted is T4, and it is only 20% is T3, but T3 is a active hormone. So this, for function to happen, the T4 has to be converted into T3. We know this. And how this T4 is converted to T3? We have a this monodeiodinase type 1. This monodeiodinase type 1 converts T4 to T3, and there is one more monodeiodinase, that is monodeiodinase type 3, which inactivates T4 to reverse T3. So for metabolism to happen, the areas where T3 is required, there MDI1 is in there, and if T3 is not required, then MDI3 increase. And one more monodeiodinase is there, it is in the brain, that is MDI2. So whenever in the intrauterine period, we know that for growth, thyroxine is not required, but brain growth is required. For that, MDI2 is there. And in premature and sickness, this, whenever the body tries to conserve energy, it decreases the conversion of T4 to T3, but the brain still requires thyroxine. For that, this MDI2 is there, which converts T4 to T3. So we have 3 MDI. Now, this is a large molecule, the thyroxine is large molecule, so it is bound to thyroxine, binding globulin. And this about 99.97% of T4 and 99.97% of the T3 is bound to TBG. So only a small amount of free hormone is there in the circulation, that is 0.03% of the T4 and 0.3% of T3 is there in the circulation, which can be measured. And it doesn't, when we will discuss about the screening, we will know what is the utility of this. Now, this T3 hormone to act on the cells require a transferring protein, transport protein, that is MCT8, and through which it goes inside the cells, and then various cyclic AMP pathway, the required agents which are required is produced. Now, let us see what happens in primary hypothyroidism. There is increase in TSH, we know. And then first to increase, whenever there is decrease in secretion of T4, there will be increase in TSH. So first to increase is increase in TSH, then it's decrease in T4, and in central fall in T3. Fall in T3 is the last one, because whenever there is decrease in thyroxine hormone, then there is increased activation of MDI1. This increased MDI1 tries to convert lot of T4 into T3. So T3 concentration is last to decrease. So this T3 is least important for diagnosing primary hypothyroidism. The two important ones are serum TSH and T4 levels. Now next is central hypothyroidism. What we do in central hypothyroidism? Again, whenever thyroxine hormone decreases, TSH, T4 will decrease, and then basically the problem is in the brain, that is in the pituitary or maybe in the hypothalamus. Then there is decrease in T4, and there may be decrease in TSH, or TSH may be normal also, because sometimes because of decrease in T4, there is production of TSH in the pituitary, which may be biologically inactive. So this may be the reason of normal TSH in a child of central hypothyroidism. So whenever we get decreased T4 with normal TSH, it can be a central hypothyroidism. And the upper limit is usually 20. We'll be discussing next in the coming slides. Now, the thyrotoxicosis, that is increased in thyroid hormones. It can be either because of increased production, or it can be either because of increased release because of the destruction of the gland. So what happens in this? We will have a fall in TSH and increase in T4. And in this, there is rise in T3. So all the three is done in thyrotoxicosis. In primary hypothyroidism, we will be doing TSH and T4. In central hypothyroidism, we will be doing TSH and T4. And in thyrotoxicosis, we will be requiring T3 also, because there is a condition which is called T3 toxicosis. It is found in endemic area where there is iodine deficiency. And in these conditions, there is increased production of, increased activation of MDI1. And this MDI1 causes increased conversion of T4 to T3. So there is increase in T3. So T3 increases, which suppresses TSH. And it gets a picture just similar to the thyrotoxicosis. So for differentiating this, because iodine deficiency is, although not very prevalent nowadays because of supplementation of iodine in salt, but in endemic areas in India, we may get a condition like this. Now, thyroid function test. The First to increase again is TSH in primary hypothyroidism, as we have discussed earlier also. Then T4, least important test to be done in primary hypothyroidism is T3. So we have to concentrate on this, TSH and T4. In thyrotoxicosis, there is decreased in, whenever there is increase in TSH, there will be a decrease in, whenever there is increase in thyroxine hormone, there will be decrease in TSH. So there is a log linear relationship between T4 and TSH. Whenever a slight increase in TSH will give a very rapid fall in TSH and T3. So this is thyrotoxicosis, T3, FT4 and TSH. T3, why T3? We are not using FT3. T3, we are using FT4, we are using not using FT3. Why? When we are doing a test, we should not order for FT3 because T3 is a very small molecule and the test results will not be reliable. So whenever we are doing T3, we should be doing total T3, not FT3. We should not do T3 as a free hormone. Now, if we see the variation in the body, a diurnal variation is seen as seen in the graph. We can see the peak is there at night and in the morning hours, it is low. So this is a peak at between 12 to 4 a.m. and we can see the nadir at 10 to 4. In the morning hours, it is opposite to the cortisol. Cortisol may we are getting high levels in the morning and night we are getting a low levels. So it is opposite to cortisol. In night, we are in the morning hours, the TSH is low and in the night it is high. So we are, if we want to do a test, when will we do the test? TSH? By seeing this graph? किस वक्त हम करना चाहेंगे? हाँ, morning में, क्योंकि TSH high हो जाता है. So we will be doing the test. But since the variation is very huge, the morning and evening variation is very huge. So if we want to do TSH, we can do any of the time because the variation is around 40 to 50%. So if we want to TSH for the first time, if we are thinking that this is a hypothyroid and the child is coming for the first time in the evening, if we want to test the TSH, we can do the TSH in the evening also because this variation is very high, around 40 to 50%. And in the morning, we can do T4, we will be doing in the morning. And if the child is on drugs, we have to do it in the morning before the child take the drug. Otherwise, for the first time, TSH can be done any time of the day because of the large variation in the values. And again, if we see the variation in the intra-individual and the inter-individual, which variation will be higher? Intra-individual मतलब हम लोग के अंदर ही होगा, that will be lower than the inter-individual. And what is the significance of this? That there is a set point of TSH in every individual. If mine TSH is 2.5 at present and it becomes 7 after some time, after 2 to 3 months, that it is a significant change in the TSH value. So this variation is significant. If I had a basal value lower and it changes to a higher level after some time, then it is significant. Okay. So we can see the intra-individual variation is only 0.5 milliunits per liter and inter-individual variation is around 2.5 milliunits per liter. Now TSH across the ages, just after birth, if we see this is a graph just after birth. Just after birth, what does happen? There is cold stress. So body tries to increase thermogenesis. For that, the hormone, the thyroxine hormone, there is a surge in thyroxine hormone along with the TSH. So the first 3 days is not good for doing the thyroid hormone evaluation because of the increase in, we can see the first 3 days, it is very high in the graph. So first 3 days, we should not try to do evaluate. If the discharge, if we want to discharge high, we have to take a higher cutoff for that. कभी-कभी after just normal delivery 24 to 48 hours में discharge हो जाता है. For that patients, we can take a higher cutoff for doing the TSH value. And it is recommended to screen every child who is born with thyroid hormone functions. So we have to do everything, and we can do cord blood also. Cord blood thyroid hormone evaluation भी हम कर सकते हैं, but it is not feasible most of the time. So the best time to do thyroid hormone evaluation in a newborn is at day 3. So if we see the upper age limit, upper limit of the TSH and the action level by in this chart, the first week, the upper limit of TSH is 20 and the action level is 40. Between 1 to 2 weeks is 10 and the action level is 20. 2 weeks to 1 year is 10 and action level is 10. 1 to 18 years is 4.5. For children up to 13 years, we can take up to 6 also. And the action level is 10. In elderly, this upper limit increases. Elderly patients, basically, we can take up to 8. The upper limit of TSH, we can 8, and the action level is around 12. And this is how we interpret. We can see in this graph that there is a log linear relationship between the FT4 and the TSH level. So whenever FT4 is decreased, the TSH should increase very high. Whenever the thyroid hormone decreases, TSH should increase very high. That is, it should be more than 20. But if it is less, if it is more than 20, then it is called primary hypothyroidism. And if it is less than 20, then it is central hypothyroidism. So this may be confusing. So we take a limit of 20. Whenever we get a FT4 of low, we should get a TSH of very high. It should be more than 20. Then it is primary. But if it is less than 20, we should always think that it may be central. We have to get the MRI for that. Now, again, when FT4 increases, TSH should decrease very low. It should be undetectable. So if it is the condition, then it is thyrotoxicosis. But if TSH is detectable, then a condition known as thyroid adenoma can be there. That is TSH dependent thyrotoxicosis. TSH adenoma. Okay. So this is the graph. This is very important, especially if we want to differentiate primary and central hypothyroidism. Now, let us see one by one the interpretation of thyroid function test. If TSH is low, FT4 is low, and FT3 is also low, then it is central hypothyroidism. If TSH is low, FT3 is normal, then also it is central hypothyroidism. If it is TSH is low and FT4 is low, then is central hypothyroidism. If it is high, then it may be T3 treatment. Again, if TSH is low and FT4 is high and FT3 is also high, it is thyrotoxicosis. That is, thyroid hormones are low and TSH is thyroid hormones are high and TSH is low. It is thyrotoxicosis. If we have discussed about T3 toxicosis in endemic areas where there is iodine deficiency, the monodiiodinase type 1 activity increases. This causes increased conversion of T4 to T3, and this causes very high value of T3. So we will be getting high T3 with normal FT4 and low TSH. So this is T3 toxicosis. Now, if TSH is normal, FT4 is high and FT3 is also high, this is TSH adenoma or resistance to thyroid hormone, TSH adenoma. So in this condition, we should always think that whenever thyroid hormone is high, TSH should be undetectable. It should be very low. If it is there, if it is normal, then it is TSH dependent. So TSH dependent, it can be a TSH adenoma, or it can be resistance to thyroid hormone at the end organ level. Now, another condition, if TSH is low and FT4 is low and FT3 is low, this is central hypothyroidism. As we discussed earlier, If TSH value is less than 20 and thyroid hormones are low, then it is central hypothyroidism. Now, if TSH is high and FT4 is normal and both the thyroid hormones are normal and TSH is high, this is subclinical. And the last, that is overt hypothyroidism, the thyroid hormones are normal and TSH is high. The most common condition which we get in our pediatric OPD. The overt hypothyroidism, the thyroid hormone, the FT4 is low, FT3 is low, and TSH is high. This is overt hypothyroidism. Any problem with this chart? Is it okay? Now, if this is a simple algorithm for neonatal screening, we have to screen the child. On day 3, we will be doing blood TSH. On day 3, if it is more than 40, and obviously we have to, in the previous chart we discussed, the upper limit in first week is 20 and the action is at the value of 40. So if it is 40, we will treat the child and we will do FT4 and we will start treating the child. We should not wait, because a central hypothyroidism, if treatment is delayed, then the child may have a severe CNS implications. Now, the second option is if TSH is low, that is, if it is less than 20, then it is normal in the first week. If it is less than 20, then it is normal. And if someone plans for early discharge, if it is less than 34, at 24 to 48 hours. So if mother is being discharged at before 72 hours in normal delivery, usually second day the mother is discharged. In that babies, we can do TSH. If TSH is less than 34, then it is no problem. If it is more than 34, then we have to repeat the test. Though less than 20, we don't have to do treatment. If it is between 20 to 40, then what to do? We have to repeat the test at 14 days. Now, if on 14 day, if TSH is more than 20, then this is the action time. We have to do FT4 and we have to treat. If it is less than 10, we are okay with that. No treatment is required. But if it is between 10 to 20, we have to repeat again at third week, that is at 21 days. Now, at 21 days, if it is more than 20, we have to treat the child. No confusion. Do FT4 and treat the child. If it is between 60 to 20, now this is a milder form of FT4, can be a transient form, can be milder, permanent form also. We have to investigate the child. We have to do FT4 level and we have to do the scan to rule out any milder form like hemithyroid or ectopic thyroid. And if we found something, we have to treat. And then also if FT4 is low, then we have to treat. If scan is not available, FT4 is low, we have to treat. If it is less than 6, no treatment, we can follow the child. Now, rescreening is required after 2 weeks in children with prematurity, because there is delayed rise of TSH in these children, and in trisomy 21, in same-sex twin, and in hospitalization. Now, the thyroid screening in preterm. First, we will be doing TSH at same time. TSH we will be doing at 2 to 4 days of age. If it is less than 10, let me discuss the pathophysiology in preterm. In preterm, when the baby is in the intrauterine period, the monodeiodinase 3 is more active than monodeiodinase 1. That is, reverse form of T3 is there in large amount. So the T3 is low, T4 is also low, but brain needs the thyroid hormone. MDI2, which is there in the brain, is active. This causes increased production of T3 in the brain. This T3 causes suppression of TSH. So TSH is also low. TSH further decreases T4. T4 is also low and T3 is also low. All the three is low in the intrauterine period. When the baby comes out before delivery, this type of thing is still present in that child. And in preterm, usually they are very sick. They are on corticosteroids. Corticosteroids also suppresses the production of TSH. This preterm may also be on dopamine. Dopamine also suppresses production of TSH. So all these things together, even the child may be sick. Sickness also decreases the production of T4 and increases T3, reverse T3 production more by MDI3 action. So all these things together causes decreased production of all the three. TSH is also decreased, T4 is also decreased, and T3 is also decreased. And there is delay in increase of this TSH, may take 4 weeks or 5 weeks also. So we in preterm, we are taking a lower cutoff. As we have seen in term babies, we are taking cutoff of around 40. But in this, we are taking a cutoff around 10. So if we screen the child, if TSH is less than 10, what will we be doing? We have to repeat. We don't have to, because there may be a delay increase in TSH. So we don't, ऐसे नहीं कि इसको छोड़ देना है. We have to follow the child at 2 weeks or at term and see whether there is no increase in TSH. Now, if it is more than 10, then we will be doing FT4 and TSH. And if FT4 is low or TSH is more than 10, then we will treat this child as primary congenital hypothyroidism. Now, if TSH is more than 10 and we are doing FT4, if it is, if TSH is more than 10, if repeat is normal, then FT4, if repeat is normal, and we will be doing TSH. If TSH is normal, then again we will be, because the child is small, we will be repeating at 2 weeks. If repeat, we are doing low T4 and TSH is less than 10, then it could be a central hypothyroidism. So we have to find out any marker of central hypothyroidism like cleft lip palate, micropenis, etc., hypoglycemia. Then if there is any marker of multiple pituitary hormone deficiency, then we will manage this child as central hypothyroidism and treat. We will be doing MRI also. But if FT4 is normal in this child, we will be doing FT4 by equilibrium dialysis method, which is the best method to do FT4. Normally, the labs don't use this equilibrium dialysis method, but if there is a doubt, we have to get it done by equilibrium dialysis. But now, if by doing this equilibrium dialysis method, we will do, if we are doing, if it is normal, we will again repeat the test at 2 weeks or 4 weeks or term. And if it is abnormal, we will manage the child as central hypothyroidism. So it is clear. The cutoff which we are taking here is 10, and we will always repeat at 2 weeks or term, 2 to 4 weeks or term. It is required. If it is more than 10, we will be doing FT4 and managing as primary hypothyroidism. If it is more than 10, and again repeat. If it is less than 10, we will repeat at 2 weeks. If it is low, TSH is also low, then it could be a central hypothyroidism. Okay. Now, if we are finding a child of congenital hypothyroidism, how do we approach? We will be doing thyroid scan. Thyroid scan, either we will be getting ectopic thyroid, or there will not be increased uptake, or there will not be any uptake. That is, no thyroid gland is seen in thyroid scan. The 3 scenarios can be there. Either it can be ectopic, which is can be a cause, which is a cause of permanent hypothyroidism. Some amount of hormone is produced, but it is not sufficient for the child metabolism. If it is increased production, then 2 conditions are there: dysharmonogenesis and iodine deficiency, and this can be differentiated by doing urinary iodine levels. And the third scenario is thyroid hormone is absent. That is, if there is no uptake, we don't get any thyroid gland, then we will be doing thyroid ultrasound. In ultrasound, if we are getting, if we are not getting any gland at birth, there is we will be getting a large, the thyroid gland is large, so it is easy to pick the thyroid gland at birth. So in ultrasound, if we are not seeing the gland, most likely it is agenesis. And if on scan it is negative, on ultrasound it is the gland is there, we have to do thyroid receptor blocking antibodies in the child and the mother. If thyroid receptor antibody is positive in the mother, then it is most likely because of the transfer of antibodies from the mother to the baby, which is suppressing the thyroid hormone axis and causing the hypothyroidism. And this is a transient condition, may wean off by 3 months. And if doesn't wean off, it could be a permanent cause. And the other cause, if thyroid receptor antibody blocking antibody is absent in mother, then the other cause would be the sodium iodine symporter defect or the TSH receptor defect. These are the, when we see the thyroid hormone production, this is the first stage where the iodine is taken up. So when iodine is not taken up, the thyroid scan will not be positive in this.
Thanks, Dr. Manisha, for kind words of summarizing the entire topic. Now I'll invite Dr. Dhwani to go over this presentation, and really honored to have Dr. Lokesh and Dr. Shiva. Dr. Shiva is an endocrinologist who is in KGMU, and Dr. Lokesh has already been there in the earlier panel. So we will like to get the wisdom on various cases and try to implement them from there. Dr. Dhwani.
Thank you, sir. Moving on to the case, we have a 20-year-old girl with a TSH of 28. So what do we go ahead with this in this child, Dr. Lokesh?
Like we already discussed, first 24 hours we cannot interpret, and 34 up to 48 hours is normal. So most likely it is normal TSH.
Yes, so the test was repeated and the levels were in the normal range. So the key message is that screening must be done after 72 hours, and when an early discharge is planned, the cutoff use is 34. Moving on to the next case, we have a day 4 child with TSH of 22. Because we know it lies in the 20 to 40 level, we repeated as per the algorithm. On day 14, the level was 12, again in the 10 to 20 range. So we went ahead in the algorithm, repeated the level at day 21, which was 9, again at 6 to 20, in the range of 6 to 20, with a normal free T4 value. So Dr. Shiva, I'd like to know, what do we go ahead? What do we do next?
As we know, TSS is day 4 is 22, is 20 to 40 range. Then we repeat it, as we know, day 14 is the 10 to 20 range, is 12. So we repeated as in day 21 is 9. So it is below the cutoff of, as a SPAD is 10. It is normal. It's nothing to worry. It is normalized.
So yes. Beyond day 4 of life, 6 to 20.
I will add a comment. Yes,
Yes.
One thought is that it is near normal, but like SPA guidelines, European guidelines differ from this. Like these are the cases which are not typically primary hypothyroidism, which we are worrying about that. Like primary hypothyroidism causing significant brain development issues and developmental delay are our main issue. And these are the mild, either they are normal or they are the milder variants, which in the cases we have hemiagenesis thyroid, or it may be ectopic also. So these are the cases which are compensated hypothyroidism, which may turn out to be normal or may turn out to be transient ones. So as European guidelines has suggested that we should work up for the children. Imaging should be done, whether thyroid is located in the normal place or whether it is by radionuclear scans. We should do function also, whether they are functioning normal also. If everything is normal, then we can take a call with when discussing with the parents. Like we can repeat also, or we can start and retest at 3 years of age also. So these are the both options we can give, and we can take a call in these cases.
I think that's very, very interesting. And now obviously there is a lot of discrepancy in terms of guidelines also, because there is no evidence per se. So this is a milder form of hypothyroidism, so to speak. Now what to do? So often parents are so worried, 3 times you already done the TSH by this time. So you need to get a closure. So often we get a scan and say, okay, scan is normal. We may actually not give a treatment or give a low dose on that. So it's a debate, but I think again, a very common case that we are seeing now because screening is being done. So both options are there, as you said, SPA as well as the other one.
Yes, so we went ahead with nuclear scan, and which showed hemiagenesis in this case. So the take-home message here is that TSH after 3 weeks of age at between 6 to 20 is definitely of concern and needs evaluation. Moving on to the next case, we have a day 10 child with TSH more than 100 with a low FT4. On nuclear scan, there was no thyroid tissue visualized.
So what is the plan in this case, Dr. Manisha?
Obviously, we are seeing that TSH is high, FT4 is low. We have to start treatment. We don't have to wait. So we have to hit early and hit hard. So the preparation which we use is LT4, that is thyroxine, thyronorm or altroxin. There is no role of T3. We have to stick to one brand because the brand to brand variation is there. So whenever you are prescribing, prescribe only one brand for the patient. And tablet form are more stable than the syrup form. Syrup form is not available in India. Dose is around 10 to a very high range. If it is agenesis, we try to give a higher. If it is hormonogenesis, we can start with 10. So the range is 10 to 15 microgram per kg per day. Timing is usually 4 hours after feed. The problem in babies usually is because their too early feeds are there. So we can try to give before feed, half an hour before feed in these babies. Crush the tablet and give with the thyroxine tablet to the baby.
So by rule, the like ma'am has explained that is also something we follow when we are suspecting an agenesis, we start at a higher dose. In dysharmonogenesis, we start at lower dose. Another criteria that may help us decide the dose here is free T4 less than 0.4, start at a higher dose of 12.5 to 15 mics per kg per day. Free T4 in the range of 0.4 to 0.8. Start at 10 to 12.5 mics per kg per day. And if free T4 is more than 0.8, start at 8 to 10 mics per kg per day. So this child subsequently developed high free T4 and the dose was subsequently reduced and had to be stopped. So Dr. Manisha, was there something we missed in this child that could have prevented?
In the previous approach section, we saw that every absent thyroid on scan may not be always agenesis. So whenever a scan is negative, we should do a ultrasound also for apparent athyrosis. So for that, we should be doing, if on ultrasound thyroid is not there, then it is permanent. If thyroid is there on ultrasound, we have to get the TRAB antibody, that is thyroid receptor antibody. If TRAB in the mother, if it is positive, most likely it may be transient, may go off by 3 months of age. We can gradually reduce and stop.
Yes.
And if it is absent, then it could be permanent cause like NIS or TSH receptor defect.
Yes, ma'am, very well explained. Moving on to the next case, we have a day 4 child with TSH more than 100. The nuclear scan showed an increased uptake suggestive of dysharmonogenesis. The child was started on LT4 at 50 mics per mics OD. At 4 weeks of the 4 weeks of age, the FT4 was 21 and TSH was high again at 24. So, Dr. Lokesh, what do we do next?
So we, this is we will repeat we repeat FT4 at 2 weeks. Like this is already 4 weeks. So by now we expect normalization of FT4, that is there. FT4 is normalized now, but TSS is not normalized. So what I will say that when TSS is very high in some children, it does not normalize. And if FT4 is in upper half of the normal range, then we should not target TSH. We should target FT4, because FT4 is the hormone which is going to help in everything, every function of the body, not TSH. So in these cases, we can say that there is a reset of pituitary hypothalamic axis at a higher level. So we cannot target in some cases of TSS. We should target FT4 in upper half of the normal range.
Yes, sir, very well explained. When starting on thyroxine therapy, one must target the FT4 level. So again, date 4 child with TSH more than 100, case of dysharmonogenesis, was started on treatment. So sir has already explained this part that the TSH will lag behind. What we need to focus on here is the FT4 levels.
Initially, 4 to 6 weeks, we should focus on FT4. After that, we can focus on TSH.
Yes. So Dr. Shiva, this child was found to have a delayed speech at 3 years of age. So do you think this dysharmonogenesis, congenital hypothyroidism, speech delay, do you think these things have an association?
That is due to hearing, sensory hearing loss can affect, because as you know, thyroid hormone also Pendant syndromes, annexins and epiphyseal dizziness. Thyroid hormone has multiple functions affected. So we have to screen always. Every congenital hypothyroidism should be screened for the hearing.
Yes, very well explained, sir. Thank you. So we've already seen that there is an HPT axis reset that one needs to look for instead of chasing TSH levels. Moving on to the next case, we have a 32-week-old neonate On routine screening found to have TSH of 7, a normal TSH and normal free T4 levels. So, Dr. Manisha, do we take these results as normal and let the child go home?
Since baby is a preterm baby, we have to repeat the test at 2 to 4 weeks of age. So going with this algorithm, if it is less than 10, we have to rescreen the baby at 2 to 4 weeks of age.
Yes, so at day 14 of life, the TSH was 14, which shows that a TSH rise may be delayed.
So
in
we will be
preterm.
treating, since it is more than 10, we will be treating the child as primary hypothyroidism.
Yes.
So I think we'll, because we are already running a bit late, we'll quickly go through this part and then we'll go into the cases. So hypothyroidism, we had already talked about congenital. The acquired hypothyroidism, we can have the slides, please. Acquired hypothyroidism can cause a lot of problems. So if you have a short child, somebody who has an early puberty, late puberty, cardiomyopathy also rarely, hyponatremia, motor delay, hyperandrogenism, these are all causes where you should think thyroid. So you should have a high index of suspicion of hypothyroidism. Always check for thyroid becomes very, very important from that regards. Very importantly, as we discussed, that do both FT4 as well as TSH. Don't just do TSH because you will often miss. And these are scenarios where thyroid function should be done from that perspective. And if your FT4 is low and your TSH is about 20, diagnosis is very simple, it's primary. If your FT4 is low and TSH is below 20, it may be central. So what I'm trying to say that it may rarely be primary, but you have to exclude MRI and the other hypothalamic cause. So again, this is inappropriately normal for the level of FT4 is what the message is. So this is a very, very important point to remember. If the FT4 is normal and TSH is below 6, it's normal. If it's above 10, it's primary. And between 6 to 10, you look at risk factors like having a goiter, TPO positivity, family history, sometimes even the female gender, you may consider whether treatment is required or not, and you can consider. So basically, look at both FT4 and TSH to get the right diagnosis in terms of treatment. This is the approach from that. And again, here you don't want to immediately start treatment. You want to build up dose gradually. If you give very rapid dose, you will cause more harm. Most children who come to us with acquired hypothyroidism are not bad in terms of school performance. They become worse once we start at a high dose because their brain suddenly becomes really, this very difficult to cope with those changes. So start at a low dose, and there are age-specific doses which are there, but we tend to start by around 25% of dose, gradually build up. Otherwise, they will develop benign intracranial hypertension and other scenarios as well. So rough 100 microgram per meter square per day is the dose which we consider. Definitely, if it's subclinical and very severe cases, start at a lower dose. Try to space thyroid from calcium and iron, at least 6 hours gap. So 40 minutes gap between thyroid and meals and 6 hours gap between calcium and iron. And of course, soya protein and other things will cause an issue. So we'll start off with the cases quickly. The first case, while Dhwani comes in, 12-year-old girl with obesity, a girl who is normal height, no clinical features, TSH is 6.4, very common referral to us as endocrinologists, advice treatment. Dr. Lokesh, what is your take?
Like if you remember, this case was like similar case was discussed in obesity also. So I like in simple one line, this TSH is this is because of obesity. This is not the cause of obesity. So that's how we will go. Like we don't treat, we will ask to reduce the weight, and that will be normalized in few months.
Yes, sir, very well explained. Subclinical hypothyroidism, in the absence of goiter and normal free T4 levels and a negative TPO, you may think you will not treat because obesity is often, high TSH is the effect and not cause of obesity. Yeah. Moving on to the next case, we have a 10-year-old girl with poor concentration, height at 136 centimeters, weight of 34 kgs. She had a TSH of 2.4, total T4 on the lower range of normal. And low T4 actually. So how do we go ahead in this case, Dr. Shiva?
As T4 is no, we confirm with the free T4 because possibility of central hypothyroidism, but we also consider other binding protein deficiency, TBC deficiency should be considered. So in this patient, we do the free T4 is normal. So maybe it is a deficiency of the protein.
Yes, thank you so much, sir. Moving on to the next case, we had a 12-year-old girl with lethargy, with a height of 140 centimeters, weight of 36 kgs, with low free T4 levels and a TSH of 12. She was diagnosed as central hypothyroidism and started on thyroxine therapy. Dr. And
We are seeing that obviously this is hypothyroidism. Height is also decreased. 12-year-old girl with 140 centimeter. FT4 is low and TSH is not that high as it should be for the level of FT4. So whenever thyroid hormones are decreased, TSH should increase very high because there is a log linear relationship. It should be at least more than 20. If it is less than 20, most likely it could be a central hypothyroidism. So before starting therapy, we have to get a MRI and serum cortisol level to rule out that it could be a central hypothyroidism. Then we have to proceed with the, if it is central hypothyroidism, we have to start with the steroids, and then we have to, after steroids, we have to start with the thyroxine therapy.
Very important, because if you start thyroxine, the child will crash. And we have seen so many cases in which this TSH is 12, 13. They say, okay, it's primary. Let's start thyroxine. Suddenly the cortisol gets metabolized. They go into shock. So this is a very, very important message. And this is what.
So like we've already seen, in a child with low free T4, we expect the TSH to be high. And if the TSH is not more than 20, we're looking at central hypothyroidism. And when you diagnose a central hypothyroidism, one must know that isolated central hypothyroidism is extremely uncommon. One must rule out other anterior pituitary hormone deficiencies here. Next, we have a 12-year-old girl with growth failure with TSH more than 100, free T4 in the lower at 6 picomoles per liter. Dr. Lokesh, how do we go ahead next in this case?
So like in this case, patient already had growth failure and very low FT4. So this is severe primary hypothyroidism. So we should know that severe primary hypothyroidism, we should start slow. And already discussed by Dr. Noor Vajpayee that we will go around 25% of the dose at the beginning, and after 2 weeks we'll increase to 50%, and then another after 2 weeks or so we'll bring it to 100% dose. So this is how we'll go. 4 to 6 weeks we will take to make it full dose. That is the message we want to give from this.
At follow-up of 1 year, her TSH was 24 and free T4 was on the higher side, 26 picomole per liter. So what do we do now? The TSH is high, so do we increase the dose, but the free T4 is on the higher side, so do we decrease the dose, Dr. Shiva?
We have to say first thing, the compliance patient is taking properly and how much gap is doing. If he's and test was done is before taking medicine or after 4-hour gap. These 3 things we have to ask. If all our things are okay, then we can think of increase. Until this, sometimes some patient having free T4 is higher range and TSH is with good compliance, then we have to increase. Some patient free T4 is higher range because of conversion defect, T4 to T3 conversion some defect. So we have to first ask for compliance is taking properly and how much gap, and this thing we have to consider.
Yes, so like sir has already mentioned, in the initial period, we look at free T4 levels to titrate the dose. But at 1 year of follow-up, if you have a TSH still in the higher side and free T4 is high, so ensure that a recent thyroxine tablet intake was not done. And after that, you ensure compliance. If the compliance was good, then you need to increase the dose. But if you feel that the compliance was faulty, then you need to just ensure a good compliance in these.
So often these adolescents would not be taking the tablets, and when they go to the hospital, they'll take 4 or 5 tablets in the last 5 days. That's why your FT4 is high. Its half-life is less. TSH takes longer time to come. So this will be the most common presentation Dhwani and we discuss.
So the key messages are, in severe primary hypothyroidism, you start with a gradual replacement, ensure an early morning sample, and adherence to medicine should be ensured before hiking doses. 6-year-old boy with meningitis with low TSH and low free T4 levels. So Dr. Manisha, how do you proceed in this case?
So we are seeing that TSH is also low and T4 is also low. It's looking like a central hypothyroidism, but the child is of meningitis. So whenever a child is sick, the child to conserve energy, the body wants to conserve energy. So what happens? The MDI3 action increases. So the T4 increases to reverse T3, that is the inactive form of T3. And that's why if T3 decreases, but the brain functioning, brain requires thyroxine. And in that, there is increased MDI2 action, which causes increased conversion of T4 to T3 in brain locally. The thyroid hormone is there in the brain because MDI2 action increases. And this increase in local T3 level in the brain suppresses the TSH in the brain, which causes a decrease in TSH. So all the three hormones are decreased. The T3 is also decreased, T4 is also decreased, and TSH is also decreased. So whenever a child is sick, either if we are very sure that it could be a hypothyroidism, then do. Otherwise, we should do the thyroid hormone testing after the child is improved, after 2 to 3 weeks of improvement.
So again, so sick child, do not do a thyroid function. That will be the key message, unless you have a high index of suspicion. Thyrotoxicosis is rare in children, but if you have a child who's losing weight, impaired concentration, tremors, having frequent defecation, then you do thyroid, again do a FT4 and TSH. And if you prove that there is thyrotoxicosis and there are eye signs and goiter, that may be a clue that this is most likely Graves. You may skip nuclear scan, otherwise you do a nuclear scan. If you have clear-cut features of very high FT4, goiter, eye signs, you may skip. Otherwise, nuclear scan, if shows increased uptake, it may be a solitary nodule, which in children requires surgery. There is no other treatment after stabilization. If it's a toxic MNG, very rare in children, it's more of an adult diagnosis, which we'll see. Graves, of course, is the most common that you will identify. Methimazole treatment is required. You can also have a possibility of thyroiditis in that the gland is damaged and the hormone is released. Here you will have no goiter, no eye signs. You may have tenderness. So in this situation, no need to do much. Just give them beta blockers and they will improve over time. And if there is pain, this is subacute, otherwise chronic lymphocytic. Most common in children will be Graves. I would have seen a couple of solitary nodules. Toxic MNG is not very common in children. Thyroiditis definitely you have to be aware of. So we'll take this couple of cases. 12-day-old child with irritability, birth weight was 2800, has lost a lot of weight, and there is proptosis, there is tachycardia, thyroid levels are hugely high. So we have this child whose mother had Graves' disease. Radioactive iodine was given 2 years ago. What do you think, Dr. Lokesh, was missed and how we could manage now and how can we salvage?
So this is thyrotoxicosis, most likely due to, we have now clear history that mother had Graves. And even after complete treatment also, mother may have persistent antibodies, TSI, thyroid stimulating immunoglobulins, so which may sit on the TSH receptor and keep activating that, which may cause all the features of thyrotoxicosis. So usually they are transient, like they may last up to 12 weeks or so, and after that it will subside. But in this case, when it already have symptomatic toxicosis, we have to treat by methimazole and beta blockers, steroid also, and good hydration. And gradually we titrate the dose according to symptoms and T4 levels.
Thank you, sir. Moving on to the next case, we had a 12-year-old girl with weight loss and tremor. On evaluation, she had high free T4 levels and a suppressed TSH level. She had thyroid swelling, but no eye signs. Clinically, she had tremor. So what is the plan in this case, Dr. Shiva?
As discussed in previously, we go for the thyroid scan, and if the mostly uptake is increased, then in suggestive of Graves, then we start for the methimazole 0.5 to 1 mg per kg and beta blocker.
Thank you, sir. Moving on to the next case. We had this 12-year-old boy with a thyroid swelling, as can be seen in the picture. Dr. Manisha, how do you go about evaluating this child?
So whenever we get a child of thyroid swelling, we have to differentiate whether it is malignant or benign, although very uncommon. But we have to differentiate whether it is attached to the underlying skin or there are lymph nodes or not. If they are not, if it is moving with deglutition or moving with protrusion of tongue or not. So what is the condition in this?
This swelling moved with tongue protrusion as well as with deglutition.
So in ectopic, the swelling move usually the benign condition basically are the ectopic thyroid adenoma. It can be adenoma or a thyroglossal cyst. And since it is moving with the protrusion of tongue, most likely it is thyroglossal cyst. The ectopic will only move with deglutition, not with protrusion of tongue. So thyroglossal cyst is the remnant of the thyroid gland. When it descends from the pharyngeal floor, it is the remnant and it is very prone to get infected. So the most important thing, we have to treat it by surgically. We have to remove it so that recurrent infections are not occurred.
Thank you, ma'am. Moving on to the next case. So we have this 10-year-old girl who had a thyroid. So I would like to ask Dr. Lokesh, what other features could have been evaluated at first presentation that could have given us a clue that this child may not be a normal goiter?
Solitary thyroid nodules are uncommon present in the pediatric endocrine department, but they come. So we need to do thyroid function. If TSS is normal, then we will go for scan. Actually, ultrasound can be also done. That depends on your setup. What setup do you have? So we'll go first for scan, and if it is an hot nodule, like usually hot nodules have low TSH, but if we have hot nodule, we do not need to go and malignancy. Malignancy is extremely unlikely. If nodule is cold, like normal thyroid function will already indicate that it is going to be cold nodule. Then scan shows cold nodule. Then we will go for ultrasound. Ultrasound we should ask or clearly what we want to see. The features of malignancy or suspected nodules those are like irregular margins and solid in the nodule and increased vascularity and calcification. These are some features which may indicate towards that it is a suspected nodule which may convert into malignancy. So in those cases, we will go for and we will evaluate further.
I think that's a very big message that there is a 8 to 10% chance of malignancy in a pediatric thyroid nodule. You cannot miss it, especially if it's more than 1 centimeter in size, fixed with cervical lymph node. Always think of an ultrasound followed by FNAC. That was a big message. I think this was a lot of cases were discussed quickly, but I think hopefully we all were able to get the message through. Thanks a lot, Dr. Manisha, Dr. Lokesh, Dr. Shiva for this wonderful discussion, and Dr. Dhwani for the nice presentation. I think, Dr. Arpita, we can have the felicitation followed by a quick tea before we have the final session, I think.
Thank you for sharing your brilliance and lighting up our minds. I would like the residents to please give the memento to Dr. Manisha, Dr. Lokesh sir, and Dr. Shiva. Let's please give them a roaring round of applause. So we'll quickly have the tea session before we return back for the last session. We shall have a quick tea session of 15 minutes and we begin with our last session after 15 minutes.
when we look at the pubertal staging and the uterine growth and the ovarian volume, at breast stage 1, don't have pointer in this? Okay. So at breast stage 1, if we do a ultrasound abdomen, we'll be missing uterus because it is a thin papery structure at breast stage 1. It will be of significant volume and will be detected on abdominal ultrasound when the breast stage is 2. So doing a abdominal ultrasound for uterine detection is an unnecessary investigation and will cause a great anxiety in the parents at breast stage 1 and should be avoided at all costs. This child is at 13 years of age, so it is not a cause of concern and we can just monitor this child to look for pubertal progression. So this was a normal physiology made into a pathology. That was the basic message of the first phase. Then a 16-year-old boy came with a pubertal concern. The onset was there to start with at 13 years of age. However, there was a stalled puberty. There was no pubertal progression for 2 years. The testicular volume is small, 3 ml, and it is soft, and the pubic hair is stage 3. The height here you can see is at 170 centimeter, which is high, towards higher side. And this child was diagnosed as CDGP. So in comparison to the case 1, this is a child where a pathology was made into a physiology. So definitely CDGP should not be considered in this case as the height of the child is towards higher side. And when we did the MRI head, there was a craniopharyngioma. If missed, it will lead to a catastrophic event in the child. So definitely this was something which we should not miss. Coming to precocious puberty, it is very common in the girls and mostly it is physiological in nature, whereas in males, it is less common, and if it is there, we should be taking all measures to find out the etiology. So what is the definition of precocious puberty in girls? When there is evidence of pubarchy and philarchy before the age of 8 years, and when there is a vaginal bleeding before 9.5 years of age. That's the basic definition of precocious puberty, and is a cause of concern, and we need to evaluate such girls. Coming to the etiology, the precocious puberty can be incomplete and complete. Incomplete where there is isolated signs such as philarchy is there only present, only pubarchy, or only menarche is present. That is incomplete precocious puberty, and then it may be complete precocious puberty. When there is complete precocious puberty, we need to differentiate whether it is a central cause or a peripheral cause. Central is more common in girls. So in central, 90% of it is idiopathic. So there are high chances we do not find any cause of precocious puberty in the girls. So that is idiopathic variant. And in certain cases, there may be some etiology. There may be CNS lesion, such as hematoma, glioma, hydrocephalus, arachnoid cyst. There may be genetic factors such as some imbalance between the stimulatory signals and the inhibitory signals like herceptin, NKRN3, and so on. And there may be history of CNS insult, such as low dose radiation infection, tuberculosis, such infections involving the CNS. Coming to the peripheral causes, which are less common in the girls, the peripheral may be the ovarian causes and the adrenal causes. Among the ovarian causes, it is McCune-Albright syndrome, which should not be missed in any case, and then hypothyroidism, cyst, and tumor. Among the adrenal, it is the tumor, and then there is excess of adrenal androgens due to the aromatase Peutz-Jeghers syndrome and so on, or due to exogenous administration of androgens. Let's talk about the puberty mimics, and we should not be labeling unnecessarily precocious puberty in such cases. So neonatal philarchy is very common due to the maternal transplacental hormonal influence. So neonatal thelarche should not be labeled as precocious puberty. Lipomastria, as we have already discussed in previous sessions, is very common in the obese girls. We can differentiate lipomastria with the true breast tissue by just approximating the thumb and the index finger. If we find any resistance, any breast tissue, it is a normal breast. If we do not find any resistance, it is a lipomastria, and it is not a cause of concern in that. And pubic hair of infancy is also a normal entity in which there is only solitary 1 or 2 pubic hair in the labial region, which can be a normal phenomena and nothing, it is not a cause of concern and it should be left on its own. So there is an interesting relationship between the breast development and the pubic hair development, and in most of the cases, we can have a clue towards the diagnosis. So if there are no breast development and there is a pubarchy, it is mostly a adrenarche or a peripheral cause. If there are no breast development and no pubic hair development, it is mostly a local cause, which can be foreign body or a trauma or an abuse inside. So we should look for the local causes. If there are breast development and no pubic hair, it is mostly due to hypothyroidism, where the bone age will also be delayed. Then if there are full breast development and pubic hair development, it is mostly a central cause. And this is the case where we have to start treatment so that the final height in the girl is not compromised. Coming to the hormonal progression, we need to see the interplay between FSH and LH. So as the puberty advances, the first hormone to rise is the FSH, and it continues to rise and remains at a level. So that is not a good marker when we are evaluating a child of precocious puberty. So that is a good marker for estimating the gonadal reserve. Whereas LH rises late around breast stage 2, and that is a good marker to see whether the child is entering puberty. So LH is used for precocious puberty and FSH is used for delayed puberty, basically. As far as the cutoffs are concerned, below 3 years of age, anything below 0.3 is normal. Between 3 to 8 years, below 0.2 is pre-pubertal. GnRH stimulated LH less than 5 is normal in 3 to 8 years, and less than 9 is normal below 3 years of age. This we've already discussed, that before the breast stage 2 development, the uterine volume and the ovarian volume are quite low. So it usually takes off at the breast stage 2, and then there is a role of abdominal ultrasound, and we can look at the shape of the uterus, which turns from the tubular structure to a globular structure, and we should also look at the endometrial thickness, which in such cases who are entering puberty will be more than 2 millimeters. And if it is more than 5 millimeters, then menstruation is quite near. So that we have to keep in mind when we are advising for the ultrasound. So the basic approach of the precocious puberty is to establish whether it is a central or a precocious puberty. If it is where there is a pubarchy, then we have to estimate the adrenal glands, and DHEAS is a good marker for that. If it is less than 40 microgram per deciliter, it is signifying pubarchy, isolated pubarchy. If it is between 40 to 135 microgram per deciliter, it signifies adrenarche. And if it is very high, more than 135 microgram per deciliter, it signifies something is definitely wrong with the adrenals. We need to evaluate further with adrenal imaging or 17-hydroxyprogesterone. And CAH is a strong possibility in this case, and adrenal tumors should be ruled out. In case of only vaginal bleeding, we should be evaluating for the local causes as mentioned earlier. When there's a complete thelarche, we have to take help of the bone age. If the bone age is retarded, so a girl with precocious puberty should be tall to start with. If the bone age is retarded, there is growth failure, we should be having hypothyroidism as a basic diagnosis, and we should work up for hypothyroidism and start treatment on those lines. If the bone age is normal, it is defined as a slowly progressive precocious puberty. Nothing much has to be done in that case, and we need to observe these children for pubertal progression. If the bone age is advanced, that is a cause of concern, and then we need to see for the gonadotropin levels, the LH. If it is in pre-pubertal range, then it is peripheral cause, and we need to evaluate for adrenals. If it is in pubertal range, then we can consider it as a central precocious puberty, and the LH will be elevated more in the pubertal range, more than 0.3, and MRI is located in less than 6 years of age to look at the CNS lesions. It should not be missed in that less than 6 years. It is mandatory to do an MRI. So I would like to introduce our panelist, Dr. Thakur Vikrant Anand, who will be our panelist for this session. You have already met him, and Dr. Yutika Bajpai, who has done MD from AIMS and then went on to do her fellowship in reproductive medicine from Melbourne. So we'll be starting with the cases.
Thank you, ma'am. So let's begin with the case. We have this 7-year-old girl who was brought to us with a concern of onset of breast development. When we examined the girl, her breast stage was 2. There was no sign of menarche and there was no pubic hair. Her height was 118 and her bone age was 6.5 years. And both LH and FSH were in the prepubertal range. Even the estradiol was in the prepubertal range. So, Dr. Vikrant, how should we proceed in this case?
First of all, we would like to know whether in reality is it puberty or not, because the bone age is commensurating. It is not as with the pubertal status. It is not advanced. And second thing, there is no increase in height. There is no acceleration of height, and all the norm values of gonadotropins and the estradiol, they are within normal range. So we will have to palpate it, whether the finding the SMR staging was correct or not. On palpation, we are going to find out whether this is really a cause of truth or not. Because sometimes it can be lipomastia that can be confused.
Definitely, sir, when we examined the case and it was lipomastia. And on examination also we found the vaginal mucosa was red.
These are other signs of estrogenization. The vaginal mucosa becomes pale and some vaginal discharges may also start. So all these point towards the fact that this is not true puberty. The child hasn't entered into puberty at all. So there was no need for further work. They can be reassured. And
moving towards our next case, we have this 2-year-old girl who was referred to us because at this 2-year age, she started breast development. And her parents told us that the onset was 6 months of age and it was gradually slowly progressive. When we examined the child, the breast stage was 3 and there was no pubic hair, there was no menarche.
So this is a very young child who presented with isolated thelarchy to start with. So the onset of thelarchy was at 1.5 years of age, very early. But after 6 months, the breast stage is still 3 and the menses have not happened and there is no pubic hair development. So it seems to be a case of slowly progressive precocious puberty. The height is also not compromised in this child and there are no telltale sign of McCune-Albright syndrome. There are no cafe or light spot. However, we have to be cautious still and we need to monitor such children because it may be initial presentation of rapidly progressive precocious puberty. So we need to constantly monitor this child for pubertal progression. As far as the isolated thelarchy is concerned, we do not need any active treatment in such children. The LH and FSH are in the pre-pubertal range. The USG might show some small cysts, but it does not need any treatment. So the basic key message out of this case is that we can avoid certain investigations if we do a careful history and examination in such children.
And definitely, ma'am, thank you very much. So moving towards the next case, we have this 6-year-old girl who was brought to us for the breast development and the thelarchy started since 1 month. His height was 124 centimeter. The breast space was 3. The pubic hair was 2, and the vaginal mucosa was 3. When we plotted her height and weight on the growth chart, we found out that her bone age is advanced. So, Dr. Arpita, how should we proceed?
Contrary to the earlier case, this definitely looks like a rapidly progressive precocious puberty. Here, the bone age is quite advanced. I can't see from here, but it is definitely advanced. And with pubic hair stage 2 and breast mucosa is pink, so it seems to be a recent estrogenic exposure. So following the approach, we need to establish whether it is a central or a precocious central or a peripheral precocious puberty. We need to look at the bone age, which is advanced. We need to go for the gonadotropin levels, the LH in this child. So I would like to know what was the LH?
LH was in the pubertal range.
It was in the pubertal range, so it seems to be the central precocious puberty. These are an ideal candidate for GnRH analog, because if we do not start it on time, these girls will ultimately have a compromised height, is what will be the result if we miss out on these cases. In less than 6 years, definitely there is a role of GnRH analogs. In between 6 to 8 years, we need to look at 3 things. We need to look at the bone age. We need to look at the progression of the puberty as well as the uterus. If the uterus in the pubertal range by the size, shape, and as well as the endometrial thickness. So if there are signs of rapid progression in between 6 to 8 years of age, also we should be prescribing GnRH analog in that.
So, Dr. Yutika, there's a lot of concern that pediatricians and often people have about fertility and the impact of GnRH analog. What is your take on that?
So this was a 7-year-old girl, a 6-year-old girl with a rapidly progressing precocious puberty. So GnRH definitely in adult women and adult people where they need estrogen for their bone health is something very, we say it will cause side effects. But for a girl who was supposed to be prepubertal, we are making her prepubertal. So she was not physiologically supposed to be having estrogen at that point of time. There are no long-term effects, especially for her bones, and definitely no long-term effects on her fertility.
Thank you so much, ma'am. We have our next case. We have the 7-year-old girl who was referred to us as she has her first 1 episode of vaginal bleeding. And on examination, we found that the breast stage was 1, there was no breast development, there was no pubic hair, and there was no signs of inactive, like there was the vaginal mucosa was pink. So, right. So, Dr. Yutika, what we are dealing with here?
So only case of vaginal bleeding where you have to think about a gynecologist. If you have no breast development and no pubic hairs, so clearly the girl is prepubertal and it's a non-endocrine cause of bleeding. You should look for local causes. And the local cause of vaginal bleeding could be any infection. It could be a foreign body. It could be even, worm infestation, and definitely also sexual abuse. So we should refer this patient to a gynecologist for examination of the local causes. Very commonly, inorganic, materials like tissue paper and those things are missed on ultrasound. So doing a proper local examination is a must in these cases.
Definitely, when the vaginoscopy was done and it was a case of foreign body. Thank you very much, ma'am. So we have our next case with 7-year-old girl who was referred to us with a breast development, and she had hilarity since 3 months and height was 100 centimeter. As we all know that this precocious puberty leads to the advanced bone age and the increased height. But she had a height of 100 centimeter, and her USG abdomen showed a large cyst in the ovary. When we plotted her height and weight in the growth chart, we found out that her height was much below the 3rd percentile, And on examination, her breast stage was 3 and the vaginal mucosa was 6. Dr. Vikrant, what we are dealing with?
An individual who is having precocious puberty is expected to be tall. On the contrary, a person who is having delayed puberty is expected to be short. The opposite is what is happening here. This is the short individual and she is having signs of pubertal progression. So I would like to consider factors like hypothyroidism because that is probably the only case that is leading to, that may lead to short stature along with precocious puberty. There will be no pubic hair and the bone age will be delayed. So most likely this is the case of hypothyroidism and we have to confirm it. The bone age is also delayed. We have to confirm it with a T4 and TSH and then we have to treat hypothyroidism. That will be the treatment for precocious.
Definitely, sir. When the TSH was done, it was more than 100.
Yeah, so we have got the diagnosis. The key message is any precocious puberty presenting in a short child, that is always the ominous sign that this is a red herring. You should have to think of something apart from the usual causes of precocious puberty, just like hypothyroidism. This is von Wieck-Grumbeck syndrome. Here, what happens? There is the discordant pattern of puberty. There will be thelarchy. So normally there should be a concordant pattern. Thelarchy should be preceded by, it should gradually progress over 2 to 2.5 years. And at D4, it is expected that the person should have bleed. So if the bleeding is taking place early, this is definitely a precocious puberty, some peripheral cause. It is most likely a cyst that has been produced and that led to the process.
So Vibha, why is there no pubic hair development in this case?
Bone age was very delayed. It was just 4 years.
And
this hypothyroidism, the TSH level is very high and this leads to the high TRH and this causes the hyperprolactinemia and this hyperprolactinemia causes the hyperprolactinemia.
so basically, again, as we were discussing, Dr. Arpita had showed that slide in which you have good breast development, no pubic hair development. That is hypothyroidism because one, your bone age is delayed, so adrenal will keep on sleeping, and hyperprolactinemia also inhibits. Dr. Yutika, the other interesting scenario is often once we treat these patients, they have a huge amount of vaginal bleeding. How do you manage that?
Before going to that question, I think we missed a huge cyst in this girl.
Yeah.
So that needs to be addressed. So definitely this girl is producing the estrogen via that cyst and that is coming via high TSH. So a TSH at a very high level acts on the FSH receptors and then leads to the stimulation of the ovarian follicle and production of estrogen. So that's how the whole thing is coming. If a young girl, 5-6-year-old, presents to a gynecologist or even to an endocrinologist or a pediatrician with a large cyst of 10 centimeters, then all her puberty signs are missed. They only talk about the cyst. So any girl with a cyst, a large cyst, always get a thyroid test done. A good clinician will definitely look at all her features, look at any breast development, and those things will come. But clinically, any young girl with a large cyst, you should always get a thyroid test done. Coming on to this question, so when very high estrogen levels come into the uterus, there is endometrial hyperplasia. And that leads to irregular shedding of endometrium, which causes heavy bleeding. In this case, if this girl would have presented a bit later, she would have presented with menarche and prolonged bleeding. And for that, giving progesterone actually heals up that endometrium. And even in that young age, we can give high dose progesterone of 10 to 20 milligrams per day for a period of 20 days. That will cause thinning of the endometrium and final shedding. And then you can control the bleeding.
I think the big message was that, in fact, this was a case series which was published by us. Dr. Yutika was the lead author and she presented also there. Around 17 years ago, around 15 girls who were being taken up for surgery. So the gynecology department was referring for surgery, but they were found to have hypothyroidism over a period of time. And in fact, Dr. Grumbach, who was the author of Von Wieck-Grumbach, he came to that particular session to attend and discuss that. So this was he was like 85 years or something at that time, but he was still interested and came to that session to discuss that. Carry on. Yeah.
So we have our next case. We have this 1.5-year-old girl whose parents are very scared that her little girl is having started menstruation. And when we did the examination, actually the breast stage was 2 and there was no pubic hair. And her height was quite advanced, like 86 centimeter, and it is more 1.1 plus 1.1 standard deviation. So, Dr. Arpita, what is the opinion?
A very young girl who presents with precocious puberty, she is definitely having precocious puberty because she is having menarche. So, a very young girl presenting with precocious puberty, two things we have to keep in mind. One is hypothalamic hematoma, and the other is McCune-Albright syndrome. So, I would like to go for the bone age in this child and then go for the gonadotropin levels. Okay,
Bone
so
age was advanced, and as you can see, the bone age, the LH was high,
is in
the pubertal range.
pubertal range. So definitely it seems to be a central precocious puberty. I would like to go for an MRI brain to look at the.
Yes, ma'am, the MRI was done and we found, as we already said,
So,
the hematoma. We
so
found
there
the-
is hypothalamic hematoma. So it is a benign lesion. It is not a tumor actually. It is nothing but a GnRH neuron at an abnormal position. So that it is not under the control of inhibitory factors. Therefore, this child is an ideal patient to be prescribed GnRH analog. There is no role for surgery in this child, and the child will do well on that GnRH analog.
Thank you very much, ma'am.
Why was the breast stage 2? Because you usually said that the breast stage should be 3 or 4 during periods, but in this case, the breast stage was 2. The reason for that, it's too rapid development. If you have a very sudden hematoma is causing a large level of LH and estrogen, the breasts have not got the time to develop. So you may see this discrepancy in these scenarios.
Again, we have this very young girl of 1 year old, and her parents came to us because they have noticed the breast development. 3 months of age, and her height was 88 centimeter. And on examination, what we saw, the breast stage was 3. There was no pubic hair, and the vaginal mucosa was red. And her gonadotropin levels and the estradiol were in the prepubertal range. So, Dr. Yutrika, how should we proceed in this case?
Definitely, she has a well advanced breast development, but her vaginal mucosa is red, which shows that there was a transient phase of estrogen production for a little while, but now the estrogen is not there. So definitely in this case, we should look for any local additional estrogenization due to any medication or any topical use, especially local examination. You would have seen that there is labial adhesion, and very commonly in labial adhesions, they prescribe topical estrogen, and that causes breast development. So this is sort of an iatrogenic puberty due to topical use of estrogen.
Very much. So, the next stage. So, moving towards the next case. You have this explanation of
So I think for the sake of time, we'll do it quickly so that it goes quickly. So we pubertal progression in boys we discussed while we were discussing in terms of the growth also. We know that the most important sign is testicular enlargement that is more than 4 ml. That is what is known as the start of puberty. Penile size is not a good marker for pubertal assessment because penile size measurement itself is a bit difficult. So 4 ml would mean that you have onset of puberty. 10 ml means that the growth spurt has happened. And of course, you have to look at pubic hair as well as the development in terms of the testicular volume. So if you have development of the pubic hair and testicular volume before 9 years of age, you are worried about this development, that this may be precocious. And as Dr. Arpita had already said, that most boys will have more of an organic pathology. They will have a much higher chances of peripheral precocious puberty compared to central precocious puberty. The most important thing to look at in a boy with precocious puberty is the testicular size. So on the left side, what we are saying, central will have a large testis. On the right side, you have got the peripheral, which will have a small testis. This is what will be the most important thing. So if you have both testes enlarged, this is central, both small is peripheral. If one is enlarged, this is testicular tumor. And if you have intermediate size testes, it means the Leydig cell only are working. So this is a HCG dependent cause. So the most important thing to look at will be a testicular volume. And then don't go much, just look at LH levels. If the LH levels are low, it is peripheral. If it's high, it is central. Every boy with precocious puberty requires a MRI, while in girls beyond 6 years, we do not need to do a MRI. If the LH is low, first thing is CAH. Exclude CAH, exclude adrenal lesion. Rare causes of HCG producing tumor and testotoxicosis will come later on. And testicular volume will give you a clue.
So we have this 4-year-old boy who was referred to us for early puberty. And when we examined the child, we found his testicular volume was around 4 ml and there was no pubic hair growth. So Dr. Vikram, what we are dealing with here?
So this most likely looks a central cause of precocious puberty, because the testicular volume you have said is increased along with the penile size. So as sir has already mentioned, if both are of more than 4 ml according to age, then they are probably central cause. If somewhere in between, maybe LH excess due to some reasons because of SCG excess or testotoxicosis, and if one is there, then it will be tumor.
Definitely, sir. And when the LH level was done, was 2.2.
So basal LH more than 0.2 is indicative of the central precocious puberty has started. So an MRI is indicated, this being a boy. Even in a girl less than 6 years of age, it is indicated. It is most likely showing a hypothalamic hematoma, and the values commensurate with the LH is 2.2 and testosterone is also 80. So probably he has to be started on the GnRH analog.
So very well explained. It was hematoma and GnRH analog. To this start. So moving towards the next case, we have this 7-year-old boy again referred to us for the concern of early puberty. And on the examination, what we found, the testicular volume was around 1 ml, but his fresh penile length was around 9 centimeters. So here, is it precocious puberty or some other case? What we are dealing with here?
This young boy is presenting with increase in penile length and with decreased testicular volume. So both the things are not corresponding to each other. And as sir mentioned in the previous slides, if we have a smaller testis, we should be looking at peripheral precocious puberty. So the LH is in pre-pubertal range. And then we need to go for the adrenal imaging and the 17-hydroxyprogesterone estimation. So
definitely, ma'am, when the adrenocity was done, we found the adrenal hyperplasia.
Okay, so there was increase in adrenal size. Now we want to look at the 17-hydroxyprogesterone levels. And it was definitely towards higher range. So this is a case of CAH or classical adrenal hyperplasia, and we should be supplementing this child with steroids. That will be our way forward in this case.
The other thing is that once we started treatment with hydrocor, Dr. Arpita, suddenly the testicular volume increased. What do you think?
That may be the cause, because this it will trigger the central precocious puberty, and that's
So
why.
in my experience, 100% of cases, because they present to us so late, and even at 4 years, if they present, they already have very high level of androgens. Their bone age will be like 10 year, 11 year. So now this high androgen is suppressing their pituitary. As soon as you correct that, it triggers. So they will develop central trigger, and then you will need a GnRH analog. So there are reports by Dr. Vaman's group in which everybody required GnRH analog. The same as our own experience. In 15 cases, at least I remember that all cases required GnRH analog. So although this is to begin with peripheral, it becomes central because your bone age is so advanced. So just to quickly go through about delayed puberty is opposite is compared to precocious puberty. So precocious puberty, we said, is more common in girls, likely physiological, less common in boys, more likely to be pathological. Delayed puberty is more common in boys, but it is more likely to be physiological. While in girls, 35% may be physiological, but you will have large amount of pathologies. So if you have a girl with delayed puberty, And a boy with precocious puberty, you need to be more worried. This will be the big message, I think, from a postgraduate perspective. You need to remember that from that regards. So if you have no thelarchy by 13 years or no menarche within 5 years of thelarchy, this is what we call as delayed puberty in girls. And mostly 1/3 will be physiological, which will be characterized by a short girl with no pubic hair development. This is a classical picture of physiological form. Pathological, you can have hypergonadotropic form. Most common is Turner syndrome. So short stature, webbing of neck, wide carrying angle, but you can have no clinical features also. Then you will have hypogonadotropic, which means the hypothalamus is sleeping, which can either be because of a disease, any chronic disease, malnutrition, malabsorption, celiac disease, liver failure, kidney disease will cause this, or you have rare permanent causes which will cause this picture. So very importantly, if you have a short girl with no pubarchy, you are mostly dealing with 3 causes. So absent pubarchy, without pubertal development, either it is CDGP, systemic illness, or multiple pituitary hormone deficiency. CDGP will be healthy looking. If you have a systemic illness, they will be sick looking. And MPHD will be very short if it's congenital MPHD. So pubic hair. So I said most important thing in a boy with precocious puberty is testicular volume. The most important thing in a girl with delayed puberty is pubic hair. That gives you a real picture, and all others will have pubarchy. And of course, FSH will help you make a diagnosis. So if you have this picture, you have got no breast development, but normal pubic hair development. What does it mean? Adrenals are working, ovaries are not working. So this means it's an isolated problem in the ovary, isolated GnRH deficiency. If you have no breast, no pubic hair, it means both adrenals are sleeping and ovaries are sleeping. Either the child is having delayed development or he is sick. The girl is sick. That's why she's not having development. If you have a normal breast development, but there is no pubic hair development and primary amenorrhea, what is it, Vibha? Which means that this is actually a XY individual who has androgen insensitivity. So the testosterone is not working at all. It is causing feminization. So you have no pubic hair, breast development, because there is no uterus, you will have no bleeding. And finally, if you have got normal pubic hair, normal breast development, that means both testosterone is there, estrogen is working, but you have no periods, it means you don't have any uterus, which basically means it's a local cause. So if you remember what Dr. Yutika was saying, no breast and vaginal bleeding is a local cause. Here the breast is normal, but there is no vaginal bleeding, it means there is no uterus. Just the opposite, if you can think of in that perspective. So this is, I think, one of the most important clinical slides which you can see. So you will look at gonadotrophins after you have done all the chronic workup. Don't miss on celiac, liver disease, and all those things. If it's high, do a karyotype. If it's low, look for hypogonadotropic hypogonadism, and then probably MRI will be required. I think this much is pretty reasonable from that perspective. If you don't find anything on MRI, if you think of a constitutional delay, try to push. Give them a dose of estrogen for 3 to 6 months, and they will start producing hormones. So over to you, Dr. Vibha.
Thank you, sir. So we have this 13-year-old girl who was referred to us with the concern of delayed puberty. On examination, we found there was no breast development for stage 1 and there was no pubic hair leakage. And even her height was 145, which is quite short for her age. And both her LH and FSH were in the pubertal range. And the ultrasound showed there was absent uterus. So, Dr. Yutika, what we are dealing with?
So I think this case was discussed by Dr. Arpita at the beginning of this session. So definitely this girl was overworked out. The one important message that I want everyone to take here is when there is no palpable breast, the uterus will be so small that an untrained and ultrasound specialist will always miss it. Because the uterus is very, very papery at that time. It does not have the proper thickness. So if you haven't got a proper probe and proper technique, you will miss it and report it as absent uterus, which is a devastating thing to tell the family. So I think we should not be referring a patient for an ultrasound scan in such a situation where you cannot palpate the breast. So there is no estrogen, it means.
Thank you, ma'am. So only observation is required. No further investigation is required in this case. So moving towards the next case, we have the 16-year-old girl who was also referred to us for the delayed puberty. And on the examination, there was no breast development and no pubic hair. Her height was 135 centimeter. And even the LH and FSH both were in the prepubertal range. And she was advised estradiol. So, Dr. Vikrant, do you agree with this statement?
Looking at the credentials of the patient, the weight is pretty much less for the age. And you know, growth, puberty, and reproduction to start with their energy intense processes, they require intense amount of energy. And if that nutrition is not provided, the basic critical fat mass is not there, then the body is going to enter into a phase of shell and it is not going to develop. So I feel it is most likely because of the reduced weight, the child hasn't gained appropriate weight and has hence not landed up into puberty. So we have to look for some systemic causes before jumping on to the conclusion we have to start estradiol treatment. So as you have said, the pallor was present, clubbing was also present. So I would like to deal with some malabsorption or the celiac disease or some causes like that. As it is shown their TTG is more than 200, so probably we have got the diagnosis. It was basically celiac disease leading to malnourishment, and because of that malnourishment, though the hormones were normal, everything was normal, but the body went into a shell, and that is why it is not entering into the physical. Most likely, we are going to the patient catches up good weight, then probably she will start the pubertal process.
So a sick looking child who is short with no pubic hair. If she was not that sick, weight was good, it will be CDGP. If it was too short, it will become MPHT. This will be the simple differential.
Who was referred to us for growth failure. Her height was only 122 centimeter. And on the examination, we found there was no breast development and no pubic hair. And as we can see in the photograph, she had webbing of neck, she had the pubitus valgus, even she had brachymetacarpia. And even her FSH was 88, which is quite high. So on looking all these parameters and she had all the Turner stigmata, she was advised 4,000. But Dr. Arpita, what the most important things have been missed while diagnosing this?
So she's like a walking Turner syndrome with all the stigmatas of the Turner syndrome, with brachymetacarpia, webbing of neck, and with the background of high FSH. She is most likely a case of Turner syndrome. What we missed is that we didn't do a karyotype in this case. Here, a karyotype is mandatory before starting the treatment, and the karyotype should be done with 50 cell lines so that we do not miss the Y cell line or the mosaic pattern. Because if we miss that, the child will later on come with abdominal lump and will have gonadoblastoma. So the treatment should be prophylactic should have been prophylactic gonadectomy and followed by growth hormone therapy, followed by pubertal induction in this case, rather than going the other way around.
So Dr. Yutika, what will be the right age to do the gonadectomy in this case?
In this case, as early as possible, because it is prophylactic, we don't want the gonadoblastoma to develop. It can be easily done doing a laparoscopic gonadectomy. So it's not a very major surgery. Very important is not to miss the Y line, especially in cases who come with fair stigmatas of Turner syndrome. People tend to not do a karyotype. They think they're saving on money, but I think that should be the take-home message. Always do a karyotype for a Turner syndrome with 50 cell lines. With 20 cell lines, usually they will miss a mosaic pattern.
So I think that was a very, very important message from there.
Thank you, ma'am. So we have our next case. We have the 16-year-old girl who came to us with a concern of primary amenorrhea. She had breast stage of 4 and there was no pubic hair. And she had a quite good height. She had 163 centimeter height. And FSH was high, 88. And even LH, both were high, but her estradiol was low, was less than 5. But there was no sign of hirsutism. So, Dr. Vikram, what we are dealing with?
So it looks like this is brass stage 4, but it doesn't commensurate with the estradiol levels. I think it should have been a bit higher.
Yeah.
So this is a delayed puberty with a tall girl, and it is always a red herring. If it is tall, then there are a very few causes, like it could be XY gonadal dysgenesis, it could be a complete androgen insensitivity syndrome, it could be estrogen resistance like syndrome, something like that. So we have to do a karyotyping, and we have to see whether it is a male or a female, because in complete androgen insensitivity, a lot of testosterone is being produced that is not working, and hence no hair anywhere. So they are beautiful females.
I think the estrogen, that was a very valid point, and estrogen in this case was erroneously low, because when you're doing an enzyme assays, you can often get a confusing picture in that regard. We repeated, it was found to have a XY karyotype, and that gave us a diagnosis. This was an androgen insensitivity. So again, normal breast, no pubic hair, no periods, androgen insensitivity.
Again, so moving towards the no hirsutism, we have this 14-year-old girl who came to us with a concern of lot of facial hair on her face, and she had menarche 1 year ago, but she is having periods every 2 months. They are not every month. And when we examined the child, the cerebral Galvin score was 6, that is mild. And on the USG, it showed a PCO appearance. So the diagnosis of PCOD was made.
So first of all, what is FGS? A lot of residents will not know FGS.
Okay. It is a score which we use for this grading the hirsutism. We see the pattern of hair on the face, upper lip, upper chest, abdomen, and the breast area. Then on the basis of this, we categorize the patient, whether the patient is having mild hirsutism, moderate hirsutism, and the severe hirsutism. Then if the patient is having mild hirsutism, generally there is no pathology, and if the patient is having moderate, that is 5 to 15, the patient is definitely having pathology. It could be due to high testosterone, due to the cause of PCOD, and it could be due to adrenal cause. So here's this is the relevance.
So this is a very classical case. Everybody with some hairs, everybody with some menstrual irregularity, with some ovarian cyst labeled as PCOD. So Dr. Yutika, do you agree?
I call it, labeling a toddler, toddling away and labeling it as ataxia. So a person who has already, very recently started periods would have a bit of hypothalamic pituitary immaturity, and they can have irregular periods. It's a little bit hyperandrogenic condition. So in the first 2 years of menarche, having mild hirsutism and mild hyperandrogenic features, irregular periods can be very fairly overlooked for, having an immature HPA excess. I think this girl was overdiagnosed, and very commonly on ultrasound in such young girls, you have larger ovaries which have a multicystic pattern, very commonly, labeled as polycystic. So these are multicystic ovaries of the puberty with mild hyperandrogenism of the puberty labeled as PCOD. And definitely we should not work up young girls with mild symptoms and mild irregular periods in the first 2 years after menarche. And it's only after that, if somebody is persisting to have, or if somebody has very severe symptoms, so severe hirsutism or severe acne, or those or very rapidly progressive hirsutism, that's the time when you need to work them up for hyperandrogenism. Otherwise, it is just anovulation of.
So PCO appearance has no role in making a diagnosis of PCOS in adolescents. So finally, delayed puberty in boys, it is again much more common, more likely to be physiological. So any boy who doesn't have a development beyond 14 years of age or has a stalled development, we will be concerned about pubertal development. Delayed puberty again in boys, 2/3 will be physiological. They will have a lack of pubic hair, they will be short, they will have both lack of gonadarchy as well as adrenarchy. Pathological causes may be hypergonadotropic hypogonadism. Classical example is Klinefelter, a tall individual with gynecomastia with initial pubertal development, then no development. And hypogonadotropic is a big challenge because they have to differentiate CDGP from hypo. Both LHFSH will be low. They would usually be permanent because of
various defects. And if you get a history of anosmia, that indicate that this could be Kalaman syndrome. You can have features of other like dyskinesia and other features which will give you a diagnosis. So lack of pubarchy, short child, again there, and otherwise you will have pubarchy. There will be low FSH and high FSH. So if the main thing, when you look at a diagnosis, see, okay, 70% is CDGP. Which child is not CDGP? So if you have a child, boy who has got pubarchy, who has got normal growth, had development and it stopped, and has neurological feature, this is not CDGP. This is a warning sign. That's what you want to know in this scenario. So these are important from that regards. So we will probably go to these. So this is the approach. Don't get too much confused. Basically, first of all, do a screening investigations and then do a LH level. If FSH is high, that is testicular problem. If FSH LH is low, it is central problem versus CDGP. You can do other tests like inhibin or GNRS test, which will give you a diagnosis. But if you remember LH FSH, that will give you a good enough idea in terms of making the diagnosis. So we'll go forward to the last two cases. I think that's there.
Thank you, sir. So we have this 16-year-old boy who came to us with the pubertal concern, and he elaborated that the pubertal development started at 13 years of age, but somehow it is not progressing since 2 years. And on examination, we found out his testicular volume was 3 ml, it was soft, and the pubic hair stage was 3. He had a good height of 170 centimeters, and he was diagnosed with CDGP. So, Dr. Vikrant, do you agree with this diagnosis of CDGP?
No, a CDGP, a child with CDGP, a 16-year-old boy, he's supposed to be short to be CDGP. But here the puberty has once started and then it stalled. So this is the red herring. It is not going to be CDGP. It may be something else. So as it is a tall individual who is having a stalled puberty, so most likely I would like to get a karyotype done. It could be a hypergonadotropic hypogonadism, which may be most likely Klinefelter. So again, this is the key message. These are the pointers against CDGP: a normal growth, pubarchy, stalled puberty, and some neurological signs that clearly indicate this is something else and not CDGP.
When we did the MRI, we found this intracranial region.
So this looks like a craniopharyngioma. So this is another differential diagnosis for stalled puberty. So we have to manage the child accordingly now. We have to treat it with neurosurgical interventions and all those.
Last case with 17-year-old boy who again comes to us with the pubertal concern. His pubertal development started at the age of 12 years. Now it has somehow stopped since 3 years. And on examination, we found his testicular volume was 2 ml, but it was strong, and he had gynecomastia. So, Dr. Arpita, how this case is different from the previous one? How should we approach?
So, like it was mentioned as a differential in the previous case, this child is definitely having delayed puberty and it is a stalled puberty. So definitely it is not CDGP, and even the height is towards higher side. So definitely it is not a CDGP. We need to do the karyotype in this case and the FSH levels. So the FSH level seems to be very high in this case. Next step is the karyotype. And it was a case of Klinefelter syndrome with 47XXY. So we should not be missing that in a tall child with delayed puberty.
So I think again, as we said, testicular volume, testicular texture, and pubic hair, most important. Good amount of pubic hair, but if you have very atrophic, shorty testes, that is Klinefelter syndrome. If you have no pubic, if you have some pubic hair, but very soft testes, this is most likely a Kalaman syndrome. If you have testicular volume between 1 to 3 ml, but no pubic hair growth, this is constitutional delay of puberty and growth. I think so the main message of this whole practical course was to look at clinical clues which will minimize your unnecessary workup. Now, I know this has been a very long session, but all these recordings are already available from previous sessions, which you can have a look at our YouTube channel. Our courses offer them all the much more information about that, so it will not be a problem. And the aim is more to sensitize, because don't get overwhelmed that this is too much now and we can't understand anything. But whatever you get is positive, because otherwise often these issues are not discussed in that regards. So I think we are already at 6 o'clock. This is a very marathon session which is going on. We started exactly at 10 o'clock, so it's like 8 hours. And it's been a wonderful session. And before I hand over to Dr. Arpita, I'd like to thank her for her yeoman's job, a wonderful job. So a big round of applause deserves for her. And she has really done a very wonderful job. I'd like to thank Dr. Vikrant, who has been here since morning. Dr. Lokesh, who has been here, and all the faculty who were there, who went off because of their other engagements. Dr. Dhwani and Dr. Vibha for taking it on their shoulders. This was a big work. Dr. Yuthika, Dr. Manisha, who has left, Dr. Aisha, Dr. Shiva, Dr. Nishant, and of course, Professor Shali and Colonel Janalpuri, who was there and graced the occasion. And over to you, Dr. Arpita.
I think generally I'll talk about pediatric gynecology for 5 minutes. So pediatric and adolescent gynecology is a missed clinical branch. Generally, pediatric trainees are not taught gynecology, and most of the gynecology trainees are taught about only adult science. So adolescent gynecology is quite a key issue that we want should not be missed, especially by pediatricians, because that's the time when most of the patients are coming. Generally, there are two issues that I want you to take home message is very close to my heart is case of dysmenorrhea. So adolescent girls with dysmenorrhea generally are missed because dysmenorrhea is psychologically supposed to be something that women should bear. So a very common condition called endometriosis has its onset during adolescent period, and its clinical signs. Generally, there is a delay of onset of symptoms and appearance of pathology by 8 years. So by the time they present to a gynecologist during their 20s, generally they will give a history of having really severe dysmenorrhea right from the time of their menarche. And it's in that period we can prevent the progression of disease and prevent permanent reproductive disability. So I would want you all to go and read about adolescent endometriosis. I was here to talk about it, but it's been a really huge session. And the other thing is any adolescent girl with anemia. Again, psychologically, women and mothers are generally trained to talk about having less period more often than talking about having more period, because they are trained कि period को सफाई हो रही है. तो अच्छा ठीक है, ज़्यादा हो रहा है तो is good. कम हो रहा है, they will come to the doctor and actively seek assistance. They will say, I'm having less periods, I'm having less frequent periods. But even though they are having heavy periods, they will not talk about it. So this is something that you should elicit, especially in all your adolescent patients, even if they are coming for URI. Say, how are your periods? And detailed explanation of periods is important because they don't realize that they're having heavy periods. And adolescent anemia is one of the major causes of maternal death in their first, generally in rural setting, they have menorrhagia, they have anemia, and then they are married early, and then they have their babies and they die of PCH. So it's very important as pediatric residents to inquire about menorrhagia and period pain in your routine, history taking of young adolescents. Thank you.
That was a very nice summary which Dr. Yuthika gave. The talk is actually already there. So if you search in our channel and you write, I think pediatric adolescent gynecology, it is one of the most viewed talks. I think there are 50,000 people who have seen
It's on
this.
the YouTube. It's available.
So it has got a lot of cases about endometriosis, about labial adhesion, about menorrhagia, dysmenorrhea. I think that but this was, I am sure this is such a long session that people will be a bit keen on that. So I think we'll close on that.